welcome to this academic fiesta being conducted in association with Rssdi Kerala Chapter Quarterly Meeting. It gives us immense pleasure to extend to you a very warm welcome on behalf of the Research Society for the Study of Diabetes in India, the Kerala chapter in association with Indian Medical Association for the quarterly meeting. Since the prevalence of obesity and diabetes is widely on raise, it is very important that we are aware and equipped regarding its practical problems and management. And today, we've gathered here to join in this scientific feast. I request our esteemed guests to actively participate and provide your valuable contributions to this academic program. For our first session of the day, let me invite the chairpersons, Dr. Kochu Esmani, EMS Hospital, Perinthalmanna, and Dr. Anish Ahib, Perinthalmanna, to chair the session. MD DGO Thrissur to speak on the topic Challenges of Managing Diabetes for Mother and Child. Over to the chairpersons.
So first of all, I thank Rssdi Kerala chapter, Dr. Shaji sir and team for the wonderful organization, and it's a pleasure and honor to chair the first session. So we have an eminent speaker, Dr. Geeta AP from Thrissur. So she will be discussing on challenges of managing diabetes for mother and child. So I'm handing over to Kochu Madam for the speaker introduction.
Good morning, everybody. First of all, I extend my sincere thanks to the organizing committee for inviting me as a chairperson of the first session. Let me introduce our first speaker, Dr. Geeta AP, MD DGO MRCOG. She is a senior consultant, Mother Hospital, Thrissur, Kerala, former president and unit chief, Amala Institute of Medical Sciences, Thrissur. And she is president, Thrissur Obstetrics and Gynecological Society, Talks, editor Talks, monthly bulletin, 2017-2020. Scientific Committee Convener, Talks 2016 to 2017. Faculty, IMACOLS Quality Standards, QRRT Training Team, KFOG. Assessor, CRMD, MD, NMSR. UG and PG examiner. Areas of interest is high-risk pregnancies and preventive gynecology. And her other interests, she's a music lover, forest trekking, interested in forest trekking and photography and reading. Madam, please. With all this, I think these words are not enough to describe, madam. Please, madam.
A very good morning to all of you. I bring greetings from Thrissur, and it's my proud privilege to be part of this August conference. And I think this is the very first time I have spoken in an audience which comprises mostly of, I think, physicians. And I'm a bit odd, and I hope meaning like I uphold the trust that my friend Dr. Chandini had in inviting me as the speaker. So I thank Chandini for inviting me for this, and I thank the organizers as well. So although the topic that Dr. Shaji had given me was challenges of managing diabetes for the mother and the fetus, I think we as obstetricians are more challenged by the diabetes than the mother and fetus. So I just changed the topic, and this is an obstetrician's perspective. So, and as was spoken of before, we know that, so as was mentioned before, we know that the hyperglycemia overall all over the world is increasing, and so that naturally the incidence of hyperglycemia in pregnancy is also going to go up. So of the around 127 million live births that is happening all over the world, almost 1/6, that is about 20 million, more than 20 million are associated with some form of hyperglycemia. And the sad part of it is that more than 90% are there in the low middle income countries, including India. And in India, it may be as high as 1/4. In fact, when we checked our statistics in our institution, we found that almost 25 to 30% incidence of hyperglycemia in one form or the other is associated with our live birth. So hyperglycemia, that means that hyperglycemia is one of the most common medical disorders in pregnancy. And of these, 84% is GDM, which puts us obstetricians which increases the responsibility of us obstetricians to be aware and to manage these cases and to reduce the future problems. So GDM is obviously on the rise, parallel to the increase in the obesity, type 2 diabetes, which is exponentially increasing. And another reason we have more cases of GDM is because there is a decreasing age of onset of type 2 diabetes, and many people have their pregnancies at an advanced stage or increasing age when they have the pregnancy. So these contribute to the increase in the occurrence of GDM. So for my talk, I will be talking mostly on GDM. I think the next speaker who is going to speak, or the subsequent talk where there is by the physician, I think they will be talking about the pre-existing diabetes as well as the medical management. I am only going to talk about the obstetrician's perspective. So hyperglycemia, when you look at Indian scenario, it's even worse. We have got about 6.2 million live births affected by hyperglycemia in pregnancy, which is a huge number. And the prevalence is about nearing 30%. That is 1/3 of our live births are associated with hyperglycemia. It's a very huge number. And there is, actually in Kerala, I don't think there is much of a difference between urban and rural incidents. We do get a lot of diabetes, GDM from the rural areas as well. So that is not much different here. And we know the physiology. I don't think I need to go too much on that. That is, there is an increasing demand by the growing fetus, and to combat that, there is a increased uptake of the fuels. There is hyperinsulinemia in the initial part of pregnancy, so there will be a fasting hypoglycemia and a postprandial hyperglycemia. And later on, when the anti-insulin hormones which are secreted by the placenta is going to cause increased insulin resistance. So if it is not overcome, then probably when the maternal system can't cope with that stress, that is one area when you get the GDM. So that's probably why we say that GDM is more common in the second half of pregnancy, but we have found that it can be picked up earlier on as well. So actually our challenges start from the definition themselves. So what is GDM and what is diabetes? So the names keep on changing. So this is what our Federation International of Gynecologists and Obstetricians have given us now. That is in the 2015 initiative. What they have said is there are two names. That is diabetes in pregnancy, which can be our diabetes. So we have diabetes in pregnancy, which could be type 1 or type 2. So, and we have the GDM. So that is what we have now. So what is diabetes in pregnancy? That is the same what we used to call as our diabetes or pre-existing diabetes. So it can be, it could predate pregnancy, or it could be a diabetes which is picked up during pregnancy and which shows the features of the WHO criteria for pre-pregnant or non-pregnant diabetes. So that is when the fasting is more than 126, when the postprandial post-glucose is more than 200, and or the random sugar is more than 200. So it's almost the same as our diabetes. It could be type 1 or type 2. But the only difference is that if you pick it up during pregnancy, previously we used to call it as GDM, but if that falls in the criteria of the WHO non-pregnant, then we consider it as the same as our diabetes. So And in GDM, obviously, if it is less than these values and you pick it up any time during pregnancy, it's called GDM. I hope that is clear. So GDM is what we are, as obstetricians, we have to pick up. So why? That I'll come to in a minute. So obviously we have got a lot of complications because of diabetes or hyperglycemia in pregnancy, which can be maternal or fetal. Maternal complications could be spontaneous abortions, increased incidence of preeclampsia. Then you can have if it is a diabetes in pregnancy, you can have an exacerbation of all the end organ problems, almost all the end organ problems. Then much more common than fetal growth restriction, which could be seen in diabetes, it's that there is excess fetal growth and polyhydramnios, recurrent infection. So these are some of the problems that the mother can have during pregnancy. In fact, the incidence of preeclampsia could be 2 to 4-fold more than in a non-diabetic pregnant patient. So, and obviously, when there is an excessive fetal growth, polyhydramnios, you are going to have a difficult delivery. So you can have preterm labor, you can have traumatic labor, instrumental delivery, prolonged labor, cesareans, and after that you can have PPH and increased chance of infections as well. So these are the maternal complications. But are the complications stopping there? Obviously no. GDM is a forerunner of future NCD. So that is where probably there is a big gap in our caregiving. We are stopping, previously we used to say, okay, GDM is a transient condition which is seen in pregnancy, and so once the pregnancy is over, okay, everything is fine. No, that is what has been found now. So the mother is at risk of future all sorts of NCDs. She can have diabetes, she can have cardiovascular disease, she can have hypertension. So all these can happen. So our care should not stop there. And fetal complications, there can be congenital anomalies, there can be stillbirth or neonatal deaths if it's a poorly controlled diabetes. You can have a difficult delivery resulting in shoulder dystocia, Erb's palsy, and a headache for the neonatologist, that is hypoglycemia, hypocalcemia, hyperbilirubinemia, all those metabolic problems which can be there for the infant of diabetic mother. So these are the things that we are bothered about immediately, but we should be bothered about something else also, because the intrauterine programming is going to modify the later life of the baby. And if you don't control the sugars during the pregnancy, you're going to increase the chances of NCDs for the fetus as well. So we are now aware that the occurrence of GDM not only causes problems for the mother and the baby during pregnancy and immediately after delivery, it's going to cause problems for them later on in life. So the onus of reducing all these NCDs now falls on us poor obstetricians. So that's why I think, and I come from an institution where, as I told you before, we have almost a 30% incidence of hyperglycemia in pregnancy. So, to the chairpersons, please, if I overrun the time, stop me there, so that if anything else is left, I can carry on the discussion session. So that is why this is not my quote, obviously. I heard Dr. Sheshaya mention it like this, that GDM today is the mother of all NCDs tomorrow, because it's going to alter the system of the mother. And also, that is exactly what I was saying, the womb is where we should concentrate if we want to reduce the future generations' risk of NCDs probably. So there is one consensus regarding hyperglycemia, that is, we all know optimal glucose control is essential. That is, I think everybody agrees. So, but then that is the point where the challenges start. Challenges start from screening diagnosis, how to manage, that is all those methods of management that are in our part. Probably in medical part, maybe it is easier, but then and the follow-up. So let me come to the screening and diagnosis. There is a plethora of algorithms. Should we do universal screening? Should we do selective screening? Should we do one step or two step? And what are the cutoffs? So we are left with wondering, so where are we? So I'll just run through all this, because I think in India, those parts are not very unclear. We are a little bit more clear on that, but still, should we do selective or universal? Selective is when we have to calculate, meaning assess the risk to the mother, like previous history or the family history or obesity, race, all those things are taken into consideration, and then we select those high risk patients, and then they only undergo screening. So that is being followed in the whole world. Probably the only place where it is being followed still is the UK. NICE guidelines still say, okay, you do only selective screening. Advantage is that probably it is it reduces the number of persons screened, but the disadvantage obviously is that when you have to do a risk assessment, you have to have a proper setup for that. You should know what are the risk factors. There is no consensus so far whatsoever about what constitutes these risk factors. So there is no uniformity, and that risk assessment places a lot of burden on the health system, and so there is poor compliance, and ultimately there is more chance that you are going to miss out on picking up the patients, especially in high risk populations like the low middle income. So there the record keeping is poor, and you are not going to get the patient back for test again. So what we can offer is a universal screening. Screen all pregnant women. So that is what is recommended now by the Government of India and almost all the world bodies. So it is better that we screen all the pregnant ladies. And because now the epidemic of diabetes is going on to become a pandemic, so probably all populations are at risk and the whole world, so probably that would be the best option. So that is clear. So that has become quite clear now. So the next thing that is confusion is, should we do a one step or two step? But I think this is a little bit less clear. There are a lot of people still, in spite of very clear guidelines from the Government of India, still a lot of people, a lot of us, my colleague obstetricians also, still go for a two-step procedure. So what is this one step and two step? This this is a very busy slide. I am not planning to talk anything about this. I just showed this book to show the confusion in the methods in the same country or in the same place. See how many different, in the first few ACOG itself there are different methods. So in the same country, in the same place, in the same and all over the world, there is a lot of confusion as to how we should go about screening and diagnosis of diabetes. So this slide is just to show that. So let me first talk about the one-step method. One-step method is when the DIPSI guidelines, which is a pragmatic guide to the Indian population, and it is recommended by the Government of India also. And that is, the patient comes first, fed or fasting, whichever. You give her 75 gram of glucose in 300 ml of water, and then she takes it over 5 to 10 minutes. After 2 hours, you are going to take a single blood sample. And if it is more than 140, it is considered as TDM. 120 to 140 is considered as impaired glucose tolerance. Less than 120 probably denotes a normal glycemia. So that is, what is the advantage of having such a one-step method? So the advantage is that, the very first advantage is that it is done as a single step. And the second thing, if you look at the Indian population, how many percentage of our pregnant ladies come fasting? I think probably very few. They are not supposed to fast. They are supposed to, for a long period of time. That is what the elders tell them. So they come in a fed state. And they might have traveled a long distance. You give them in... Over? Time is over? My God, I have not even reached half.
I think we had some technical, so we can give you 5 more minutes.
I don't think I'll finish, so I'll run over because the screening itself will take another this thing. So then I'll run fast over my slides. So that is one thing about the. Just let me. So that is why in India, it is better that we go for the single step. So we have the 2-step, and then we have got the IADPST. You don't have to think more about it. The only difference is that it has got a fasting 1 hour, 2 hour samples. And the values obviously are higher than the values in the, when you think about the DIPSI. So 2-step is when you have screening test. That was what we were following for some time. So we have got a glucose challenge test, the screening test followed by a diagnostic test. Obviously, the dropout rates will be more if you have a 2-step procedure. So we have, this is the Carpenter-Houston, which is followed in America. We don't have to follow that, so that's not important. So DIPSI test is what is being recommended by the government of India as well as the, and it is approved by the world bodies as well, who, some of them which follow IADPST. So when, how frequently should we do, when should we start? At the first visit obviously, and because we may pick up some of the diabetes in pregnancy, and if we can pick it up early, then that is the time when we can institute changes in the embryo as well as in the fetal milieu. So what is recommended is 3 times. So first, at the first booking, then 24 to 28 and 32 to 34. That last one is very, very important because we do get a lot of patients in the 3rd trimester who come with GDM. So that is very, very important. So again, management, I will be just talking only about MNT and exercise or and the follow-up. So MNT again, what the HAPO study, that is a hyperglycemia and adverse pregnancy outcome study, had shown was that there is a relationship between the blood sugar values and adverse pregnancy outcome. But what is the cutoff? It's not clear. Where is it 1 hour, 2 hour? They say it's not any timed value. It is just that it's a continuum. Whenever there is a hyperglycemia in pregnancy, it's going to be associated with adverse pregnancy outcome. It's not based on the time. So there is no absolute cutoff. So we are not sure where should be what should be the cutoff value. But based on the odds ratio of 1.75, that is how we have IADPST has calculated those cutoff values. So lifestyle modification is the base. Then again there is a big confusion there. What sort of diet should we, that we have all know about medical nutrition therapy. So then again a problem, you need to spend a lot of time on these, that is, it should be a carbohydrate restricted diet. But then how to plan that? So what we usually do is do a dietary recall, ask about what the patient is usually having, then modify accordingly. So that is the ideal. It may not be practical in all situations, especially when you have a whole big crowd of patients. So probably for a population we can plan for a diet chart or something and then follow it up with the in the subsequent visits. So MNT is the basic thing, or is the sheet anchor of diabetic control. And if we have a proper medical nutrition therapy, probably 85% of the diabetes may get controlled, but that is still a big question mark, whether we can get that much of a control. So In general, we can tell them that you plan your own plate. With the half of the plate with the vegetables and fruits, and only a quarter of the plate will be carbohydrates, and that too only complex carbohydrates. So, and of course everybody knows about the meals, dividing into meals and snacks, and then so exercise. The one point I want to stress is we always tell them, okay, 30 minutes of exercise every day. One thing which has been found recently is that if they walk for about 15 or 20 minutes after the main meals, then that will reduce the postprandial hyperglycemia, and probably that may be more effective, and that may increase the patient's compliance. That is one thing which we have found effective. So the glycemic targets again, we go with 95, 140, 120, but Sheshaya sir says 90, 120, 110. I think many of the endocrinologists also say that. But the problem is if you have too much of a strict glycemic control, there is a likelihood of the baby going for a fetal growth restriction. And much more than that, the problem is that when there is a hypoglycemia or a ketosis happening because of that, it may affect the, impair the neurodevelopment and the later on intellectual function of the baby. So a very, very strict euglycemia may be harmful also. So monitoring again, it could be if she's only on an MNT, maybe after start on an MNT, 2 weeks later ask her to have a 1 hour fasting and a 1 hour, and then if it is controlled, keep doing that. But if she is not controlled with an MNT and lifestyle modification, and she has to be started on drugs, probably she must be advised to do self blood glucose monitoring. And tell her to get a glucometer, show her how to do it, and that would be better. And let her keep a chart of the diet chart as well as of the blood glucose monitoring. I don't think continuous blood glucose monitoring is too much of a thing in our present situation, but it may be needed when she is not controlled with the intermittent monitoring. So how frequently should we monitor? Probably for 0.7 depending on how good her control is. And so if we keep a chart like that, it may help the patient to have an idea as to what foods or at what point of time she is having this increase in the sugars. So, and one more thing, there are people who recommend 2 hours. I feel 1 hour is better for the patient to remember, as well as the fact that a normoglycemia maintained at 1 hour is going to have a better fetal outcome. So this I think I'll skip. No, I'll just say, and when you pick up a diabetes, you are going to increase the surveillance, the maternal surveillance as well as the fetal surveillance, and the antenatal visits will comprise the monitoring for both. So for the mother, main thing is the control of the sugars. Look out for preeclampsia. For the fetus, you need to rule out the possibility of congenital anomalies, and the growth abnormalities. So fetal surveillance will be, you have the routine 11 to 14 weeks early anomaly scan along with the chromosomal screening. You have the double marker test, you have the anomaly targeted scan to rule out anomalies. You have the growth scans at starting at 28 weeks. You have the fetal surveillance with the fetal kick. You have the biophysical ultrasound and the biophysical profile. You have the CTG. And planning delivery, if that is another thing. If it is a well controlled, then probably we can deliver her on the expected date. If it is poorly controlled, after 38 weeks, because there is always a risk that she is going to go in for a stillbirth, or if you don't deliver her. So there is no indication for delivering her just because it's a macrosomia. But if you feel shoulder dystocia is going to happen with a weight of more than 4.5, yes, you are going to go for a section. So management in labor, it's important is to maintain the glycemia between, the glucose levels between 70 and 120, because if we don't do that, the baby is likely to have complications. So postpartum, again, you have to make sure that her sugars are monitored, and if she has a persistent hypoglycemia, then you, just 10 seconds, just I think I have only 1 or 2 slides more. So follow-up care, OGTT at 12 weeks. Actually, I was reading something which said that probably you can monitor the fasting and the 2-hour PPBS or do an OGTT 2 days on the postpartum. Somebody is doing a study on that. So that if that is high, probably you don't need the patient to come back at 12 weeks. But our patients do come back at 12 weeks for checkup. 6 weeks. So this is just what we should do. That is, whenever there is a GDM, you need to plan her future care in conjunction with the physician, with her, if there is a local person whom they can contact, then yes, they should be advised that they are at risk of future NCDs and they have to be followed up in that manner. So to conclude, I would like to say that GDM is on the rise, and we obstetricians are, if my talk seemed a bit confused, so I think we are still in a state of, we are not very clear on many aspects, but we are trying our best. The best option or the best bet is to try to maintain a euglycemia, and whatever be the method you are adopting, then our aim is to reduce the complications for the mother and the baby and the future NCD. So let us, I don't know whether I should say this in this forum, but I think our dream should be a diabetes-free future generation. Thank you so much.
So thank you, Geeta ma'am, for the excellent lecture. So I think, as madam rightly pointed out, this needs to be a teamwork, where your primary physician and obstetrician. So what a practical problem we all face, and Kochu madam will explain me. Once patient become pregnant, we tell them the medical nutrition therapy. That is where the differences occurs, because even obstetricians sometimes tell, you need just make a statement that we need to take the intake, and patients, the intake is
very difficult.
So that is what we all have a problem. And second point is, as you rightly pointed out, the fetal programming of adult disease. So as you pointed out, when there is a hostile environment in the intrauterine, where the genetics and epigenetics play. So I think, as madam rightly pointed out, these patients needs a long-term follow-up, because they are at very high risk for PCODs and insulin resistance and a future risk of diabetes. So I think we need to have a more preventive strategy, and that is what we all aim at. It should be a diabetic-free world rather than we treating diabetes. So handing over back to Kochu madam.
It was well narrated, ma'am, and everything is, you have to tell everything. Really, it's a nightmare actually for obstetricians. We are getting, because the diabetes in pregnancy, whatever it is, GDM or whatever it is, it's really on the high, it's going up only. So we have to do some plans, we have to do some workout for the patients and advice, whatever it is. Okay, anyway, thank you very much.
And one more thing which are probably left out is that the family also should be involved, because the problem in India, and I think maybe in Kerala also, is that pregnancy and postpartum are the areas, are the times when the girl is supposed to eat and eat and eat. So that is one thing which we have to convince the parents, grandparents, and whoever is around her. So that is also there.
So thank you, ma'am. We are running short of time. We can entertain one question, if there is any. So thank you, ma'am, and we are handing over for the next session.
Thank you for the patient listening.
For this enlightening session. Now I request Dr. Kochu S. Mani to present Dr. Geeta AP with a memento as an expression of our gratitude. I request Dr. Anish sir to give away the certificate. Next, I request Dr. S. Mohan Das to present a memento to Dr. Kochu S. Mani and Dr. Anish Ahmed for chairing this wonderful session.
Our next topic of the day is diabetes and heart disease, a deadly duo. To chair the session, I would like to invite Dr. Mohan Das and Dr. Raj Gopal from EMS Hospital, Perinthalmanna.
A very good morning to all. First of all, thank the organizers for giving an opportunity to chair this session. This session is diabetes and heart, the deadly duo. As you all know, diabetes, if uncontrolled, is deadly, like coronary artery disease is also deadly. To talk about this, we have got Dr. Govindunni, who is Professor and Medical Director, Jubilee Hridayalaya and Jubilee Medical College and Research in the Trichy. I invite Dr. Govindunni to the stage. To his credit, there are a lot of academic activities he has got, and if he go through all these things, it will take one day, full day, to tell all these things. But a few of them is already shown here. He is a first rank holder for MBBS from Calicut University and delivered Calicut Medical College Alumni Oration in 2004, recognized as an inspiring cardiologist by Economic Times in Doctors Conclave 2018, regular faculty at many of the annual Cardiological Society of India meetings, and also Indian College of Cardiology, Hypertension Society of India, Indian Society of Hypertension Association of Physicians of India. Teaching faculty at several CMEs conducted across India and outside India also. Recognized as a PhD guide of Kerala University of Health Sciences. 38 publications to his credit, including 4 chapters in textbooks. Part of major studies like ACS QUIC, Kerala Atrial Fibrillation Registry, Pulmonary Hypertension Registry, Kerala Acute Heart Failure, etc. These are only some of his credits. The rest I am, as I told, if I continue, it will take 1 or 2 hours. Now I invite my co-chair, Dr. Rajagopal, cardiologist of EMS Hospital, to introduce the topic.
Good morning all. As Mohandas sir has already said, the topic is diabetes and heart disease, a deadly duo. As the previous speaker has said, the numbers of diabetes is exploding, whether it is gestational diabetes or other diabetes, the numbers are just exploding. So hopefully we are at the fag end of a pandemic, but before this pandemic has happened, we are being affected by an epidemic of diabetes and diabetes-aided coronary vascular disease or cardiovascular diseases. So it is estimated that around 8% of the world's adult population will be affected by diabetes by the end of 2030, which is not far away. And what is more important is around 70 to 75% of this 8% will have one of the cardiovascular disease as the cause of mortality. So it is in this context we should see the topic. Exploding number of diabetes, exploding number of cardiovascular disease, and the cardiovascular disease as the major cause of mortality in these diabetic patients. So to explain about this topic, how diabetes is related to cardiovascular disease and what are the points in which we can interfere to prevent the development of cardiovascular disease, we have an eminent speaker. Over to you, sir.
Thank you, Mohandas sir, for the introduction, and thank you, Dr. Rajagopal. Let me also thank the Rssdi for giving me this opportunity. Okay, as already said, the topic today is diabetes and heart disease, the deadly duo. Now, if you look at diabetes and heart disease, cardiovascular disease is the principal comorbid condition and primary contributor to mortality in type 2 diabetes mellitus. It is not just coronary artery disease, it is cerebrovascular disease, peripheral vascular disease, heart failure, atrial fibrillation, everything has more importance, more prevalence in type 2 diabetes than the non-diabetics. In fact, many people consider diabetes as a vascular disease with some associated hyperglycemia also. There is 2 to 3-fold increase in the risk of coronary artery disease, cardiovascular mortality, all-cause mortality, and cardiovascular hospitalization. In fact, even below the diabetic level, even if you take a non-diabetic, there is an increased risk in the setting of an ACS between, say, somebody with a fasting blood sugar of 80 and somebody with a fasting blood sugar of 100, even though both are well within the below the diabetic range. So even in that area, we have some relationship between blood glucose and overall prognosis. The first thing when a patient with diabetes comes to you, if you want to prevent cardiovascular disease, is risk stratification of the patient. Normally we risk stratify into primary and secondary prevention, but in diabetes there was a time when everyone considered diabetes as a cardiovascular disease risk equivalent, which means all diabetes should be considered as someone who already had an MI. So naturally the distinction between primary prevention and secondary prevention is blurred in diabetes. This is the European Society of Cardiology risk stratification, which I thought was the best. The very high risk are secondary prevention, diabetes with established CVD, or diabetes and other target organ damage, diabetes and 3 or more risk factors, and long-standing type 1 diabetes also if it is more than 20 years. And the high risk are patients with a diabetes duration of more than 10 years without target organ damage plus any other additional risk factor. And you have the moderate risk category, which are the young patients less than 35 in type 1 and less than 50 in type 2. Diabetes duration 10 years, less than 10 years, and no other risk factors. So you can see that the vast majority of the diabetic patients that you and I see fall in the high risk and very high risk category, with a small group of young patients in the moderate category. Also notice that in diabetes, there is no low risk category. It is either moderate, high, or very high. There is no low risk category in diabetes. When you consider prevention of atherosclerotic cardiovascular disease and heart failure, the first thing to do is to assess the risk factors systematically, at least annually, and then treat the modifiable abnormal risk factors aggressively. That aggressively is very important. The modifiable risk factors include obesity and overweight, hypertension, dyslipidemia, smoking, chronic kidney disease, and presence of albuminuria. And there are non-modifiable risk factors, which includes the duration of diabetes and family history of premature coronary artery disease. Of course, we start with lifestyle modification, important things being no smoking, more than 150 minutes of aerobic activity per week, weight control, and healthy diets. And then I think we will next go to lipid management. Now, each component of the diabetic dyslipidemia have been independently associated with cardiovascular disease risk. This includes small dense LDL, ApoB, triglyceride, HDL cholesterol. All of them have been independently associated with cardiovascular disease risk. But unfortunately, as far as our treatment is concerned, we have only one drug, and that is to treat LDL cholesterol. So even though all these are related to cardiovascular disease, treatment is basically bringing down LDL cholesterol. Unfortunately, drugs that modify triglyceride, drugs that modify HDL have failed at the altar of randomized controlled trials. So that still remains questionable. Treatment of triglyceride and HDL remains questionable and controversial. And the drug, of course, is statin. Unfortunately, we have all that in our pharmacological armamentarium. If you look at the number needed to treat to prevent one major adverse CVD complication over 5 years, it is really fantastic to see that it is just 39 for patients without CVD. And if you consider patients with CVD, it is just 19. Treat 19 patients for 5 years with statin, and you have already prevented one event in patients with a CVD. So the results are really good. So the ESC guidelines on diabetes, pre-diabetes, and coronary artery disease say that in a moderate risk patient, you should aim for an LDL of less than 100, whereas for a high risk, the LDL should be less than 70, and remember that LDL cholesterol should be 50% reduction. You have to achieve both these values. It has to be below 70, and it has to come down by at least 50% from the baseline value. And in the very high risk, it is 55, LDL less than 55, and again remember it is and, not or. LDL reduction of at least 50%. So again, you have to attain both these targets, which in turn means that all high risk and very high risk patients should be on statin, should be on high intensity statin, because that is one that will reduce the LDL by 50%. Irrespective of their baseline cholesterol levels. And as I said, the vast majority of the patients that you and I see daily are either high risk or very high risk. In the moderate risk, however, you can adjust the dose of the statin based on the baseline LDL cholesterol and bring it down to less than 100. So in short, I would say that all diabetics will be on a statin, because diabetic with an LDL of less than 100 is possibly an utopia, not commonly seen. Well, coming to non-statin drugs, we have some drugs available. Ezetimibe has some data in the Improve It trial that it did reduce cardiovascular event rate. We have a lot of data with PCSK9 inhibitors, also multiple PCSK9 inhibitors. Both of them are given on top of high-dose statins. Even though PCSK9 inhibitors have more data than ezetimibe, the guidelines say you first give ezetimibe after high-intensity statin therapy and then add PCSK9 inhibitors because PCSK9 inhibitors are costly. Once it becomes off-patent and cheap, it will become possibly first. As far as fibrates is concerned, unfortunately, as I said, it reduces triglyceride, but that reduction has not translated into reduction in cardiovascular event rates. We have one omega-3 fatty acid, which is known as icosapentaethyl, which has shown reduction in cardiovascular event rate. So we have one drug in that category. We have other drugs like inclisiran and bempedoic acid, which also reduces LDL, but we have to wait for more data that they will reduce. The reduction in LDL will be translated into reduction in cardiovascular disease that we still do not know. The outcome trials are still to come. So to make a long story short, we have ezetimibe and PCSK9 inhibitors where we have data. We have icosapentaethyl where also we have data. Fibrates, unfortunately, is on the other side. The data is not satisfactory. And inclisiran and bempedoic acid, we are waiting for data. We are waiting for outcome data. A word about icosapentaethyl, because now that is come more and more important. It is becoming more and more important. It is a stable icosapentaenoic acid, and it was tried in the Reduce It trial with about 8,000 subjects, followed up for 4 or 5 years approximately. And the primary endpoint of a composite of CV death, non-fatal MI, stroke, coronary revascularization, unstable angina did come down significantly after giving icosapentaenoic acid. With the result that the new diabetic guidelines on high triglyceride, ADA 2022, says first that what you require is intensify lifestyle therapy, optimize glycemic control for elevated patient and low HDL. And then second, for patients with a fasting triglyceride of more than 500, evaluate for secondary causes and consider medical therapy to reduce pancreatitis, not to reduce coronary artery disease, to reduce pancreatitis. And now we have this class 2A recommendation of patients with ASCVD or other cardiovascular risk factors on statin, controlled LDL, elevated triglyceride, you can add icosapentaethyl, which is a class 2A recommendation, not a class 1 recommendation. From there, let me go to hypertension management. Approximately 70% of diabetics have hypertension, and there is a steep graded association between increased BP and adverse cardiovascular outcomes. The goal is less than 130/80 in general in patients with diabetes, but if the patient does not tolerate so low a BP of 140/80 is possibly also acceptable. Now the benefits of BP reduction are profound. It is actually more than any other intervention in the treatment of diabetes. Look at the fatal and non-fatal myocardial infarction. There is a 12% reduction for every 10 millimeter reduction in systolic blood pressure. Fatal and non-fatal stroke, 19% reduction for every 10 millimeter reduction. Microvascular endpoints, again 13% reduction. Amputation, peripheral vascular disease, 16% reduction. And heart failure, again you have 12% reduction. All of them you can see are statistically significant values. The only endpoint which is probably not affected by blood pressure control is cataract extraction. There is no difference whatsoever with BP control. So the cornerstone of hypertension management in diabetes is ACE and ARB because they have favorable effects on the kidney as well as the heart. But if you look at the heart, the cardiovascular outcomes, ARB evidence is much less robust. And so most guidelines say ACEI should be the first line, and if the patient cannot tolerate an ACEI, change to ARB. If the BP is not controlled, you can very well add CCBs, diuretics, MRA in that order probably. The guidelines from the European Society of Cardiology says individualized BP targets, target to 130 millimeter and maybe less than 130 but not less than 120. In the elderly, you can have a slight reduction, a liberalization to 130 to 139 and less than 80 but not less than 70 millimeter. So this is what you should do when a patient to control the blood pressure. More than 140 over 90, less than 160 over 100, start with one drug. But if it is more than 160 over 100, you are justified in starting two drugs. Lifestyle management, of course, is there. The next question is there albuminuria or coronary artery disease? If neither is there, you can start any of these three drugs, one among these three drugs. And if you are giving two drugs, you can give any two from these three drug options. But if there is albuminuria or CAD, RAS blockers should be part of the treatment, either alone or as a part of combination. Well, if the blood pressure is not controlled, if it is controlled, fine, continue therapy. If it is not controlled with this, then you can add a complementary drug. You can give a two-drug combination, one among the other. And if it is an adverse effect, of course, you can change to another drug also. If the BP is controlled, fine, continue. But if the BP is not controlled, you can give a combination of all three drugs. That is S or ARB, calcium channel blocker, and diuretic. If the BP is controlled, okay. If the BP is not controlled, the next drug to be added is an MRA, mineralocorticoid receptor antagonist, not beta blocker, but an MRA. So RAS blocker, calcium channel blocker, diuretic, mineralocorticoid receptor, MRAs. That should be the order when you treat hypertension. Aspirin. Aspirin is recommended by all guidelines for secondary prevention. In patients with established CVD, there is no confusion. However, the role of aspirin in primary prevention is now questioned, and most guidelines say there is no role for aspirin in primary prevention. There is a weak indication, class 2B, maybe for patients with the very highest ASCVD risk, but in general, no. It is more of an exception rather than the rule. This is another thing which is now increasingly becoming important, the coronary artery calcium scoring, because it is a clear marker of risk for CV events even in the general population, not just diabetes alone. The higher the score, the greater the risk, and it adds incremental prognostic information to traditional risk factors. The prognosis of patients with no CAC is excellent for mortality and cardiovascular events. In an asymptomatic diabetes, if you do CAC, you will find that quite a good number of them have extensive CAC, which tells us that there is atherosclerosis in these patients. However, there is about a quarter to a third of patients who had no CAC, and they have a very good prognosis, independent of the duration of diabetes. In each CAC risk score, obviously, diabetics have higher all-cause mortality than non-diabetics. But if you look at the lowest group where the CAC score is between 0 to 10, irrespective of whether they're having diabetes or not, the mortality rate is less than 2% at the end of follow-up, which is about 12 years. So it is a very good effect if the CAC score is 0 to 10. Event-free survival of diabetes and metabolic syndrome. When a patient has diabetes and metabolic syndrome, we usually presume that they are very high-risk people. But if they do not have coronary artery calcium, they survive, 95% survive at the end of 12 years. Contrast it with patients independent of the duration of diabetes. Contrast it with patients with long-standing diabetes and a CAC score of more than 400. More than 30 to 35% are already dead by the end of 12 years. So the mortality is predicted by the CAC scoring system. So most guidelines now say that it is reasonable, class 2A indication, to perform initial risk assessment with a coronary arteries calcium screening in asymptomatic type 2 diabetes. But it is not as simple as that, because all patients with CAC should obviously be offered aggressive risk reduction. But it is not as simple as that, because there is no trial-based evidence showing that in the absence of CAC, it is permissible to de-escalate preventive efforts. You cannot just really reduce your statin or hypertensive treatment just because there is no calcium. So what is the big fun in doing these things? Moreover, you have no idea when is the patient with no CAC going to develop CAC. How long will you wait? How long is it safe to not treat? So these questions are yet to be answered. Next will be some of selected medications with diabetes. I will start with metformin, which had the UKPDS at its database. New diagnosed type 2 diabetes who are overweight, and it showed that metformin reduced diabetes-related endpoint, diabetes-related deaths, and all-cause mortality. It can now be given even with an eGFR of less than 60 and even less than 45, because only you have to assess the safety frequently, but definitely not if the eGFR is less than 30. Most guidelines now consider metformin as the first line drug because of its safety, tolerability, low hypoglycemia risk, clinical outcome data, and relatively low cost. The other old drug which has some data is pioglitazone, thiazolidinediones, in the proactive trial. Pioglitazone in diabetes with prevalent CVD at study entry, that is secondary prevention, showed a significant 16% relative risk reduction for secondary endpoint, which included mortality, non-fatal stroke, and MI. But unfortunately, there was no effect on the primary endpoint. So this is the second drug which has some data, old drugs. Now, among the newer drugs, DPP-4 inhibitors, though it is widely prescribed by diabetologists, as far as the cardiologist is concerned, it is a gross disappointment because it has neutral effects. There is no benefit whatsoever. It is safe, but no benefits. And two gliptin, saxagliptin and alogliptin, actually increase the incidence of heart failure hospitalization rates, with the result that the recommendations say that if the patient develops heart failure, stop gliptin, not only saxagliptin and alogliptin, stop gliptins, because we really do not know what is going to happen in patients with heart failure. Then, of course, the new drugs came, a revolution in diabetocardiology, I should say. The GLP-1 receptor agonists, as you know, they are neuroendocrine hormones secreted by the intestine in response to meal ingestion, and they stimulate glucose-dependent insulin secretion, suppress glucagon, and equally important, slows gastric emptying and enhance satiety, with the result that they reduce weight, they have favorable effects on blood pressure and lipid profile also. And they do not increase the risk of hypoglycemia. And if you look at the leader trial with liraglutide, 13% reduction in MACE and concordant results, death, non-fatal MI and stroke, and all-cause mortality also reduced. Heart failure hospitalization, however, did not differ. And if you look at the meta-analysis, you can see that significant reduction in the 3-component MACE, significant reduction in cardiovascular death, surprisingly no benefit in myocardial infarction, really surprising. The benefits were actually driven by the significant reduction, as you can see, in stroke. So it was stroke that was significantly reduced. The next important drug, SGLT2 inhibitors, as you know, reduces glucose, reduces body weight, reduces blood pressure, and most recent meta-analysis shows that there is a risk reduction of MACE, CV death, hospitalization, heart failure, and CKD of 10%, 15%, 32%, and 38% respectively. The MACE benefit is there only in patients with established CVD. That is not why you give SGLT2 inhibitor. You give it for heart failure and CKD. And the benefits of heart failure and CKD are seen irrespective of the presence or absence of ASCVD, irrespective of the presence or absence of heart failure. Preferred agents in ASCVD, especially in those with mild to moderate heart failure. So if you look at the meta-analysis, significant reduction in MACE, significant reduction in heart failure hospitalization, significant reduction in CV death, and very significant reduction in the renal composite endpoint also. So the 2018 consensus report from ADA and ESD says, advises the use of either GLP-1 receptor antagonist or SGLT2 inhibitor after metformin therapy in those with established ASCVD. And for those in whom heart failure or CKD predominates the clinical picture, SGLT2 inhibitor will be favored. Intensive glucose control versus less intensive glucose control. Post hoc analysis from UKPDS said you can give intensive glycemic control earlier in the course of the diabetes, particularly without prevalent CVD. Whereas if the patient is at an increased risk, the glycemic target should be more liberal, like very elderly, high burden of underlying comorbidities, and prevalent CVD. So tightness of the intensity of glucose control should depend on the severity of CVD. Moderate to severe CVD, you can even go to 8% of HbA1c. It reduces microvascular risk, but not macrovascular coronary artery disease risk. So less stringent target is preferred in significant patients, less motivated non-adherent patients with a high risk of hypoglycemia, long-standing diabetes, short life expectancy, important comorbidities, and established vascular complications. And the last question I would answer is, should asymptomatic diabetic patients be screened for ISD routinely? Silent ischemia, if you screen in 26%, and all of them have increased CV risk, but Treatment is not going to improve the outcomes. RCTs fail to demonstrate screening, and so in nearly all diabetes, there is no need to screen for IHD because it is neither going to change medical therapy nor going to change the prognosis. What is required is aggressive BP, lipids, and other controls. So the guidelines are uniform, only ECG, no screening whatsoever. The European Society of Guidelines say you can maybe do a functional imaging, but there is no benefits other than controlling the CV risk factors. The medical care in diabetes 22 same, no use of screening. There is not recommended for coronary artery disease in asymptomatic patients. So to conclude, one last news, a good news also. This is the Swedish National Diabetes Register. 271,000 diabetes and 1,035,000 non-diabetes. 5 risk factors were taken into consideration: HbA1c, LDL cholesterol, albuminuria, smoking status, elevated BP. If all these are controlled, there is no significant excess risk of stroke, MI, or death. But unfortunately, heart failure does not regress with this control. So you still need some SGLT2 inhibitors. So I conclude here, ladies and gentlemen, Mr. Chairperson, reduction in diabetic complications stands on the 4 pillars: glycemic management, blood pressure management, lipid management, and the last 4th pillar, which has come now, agents with cardiovascular and kidney benefit. And they stand on the foundation of lifestyle modification and diabetes education. Thank you very much.
Thank you, Govindanoni, for a very excellent and informative talk. Now the topic is open for discussion. 2 or 3 questions can be.
It is a high risk because in the definition of hypertension is systolic and diastolic BP. So if either is elevated, it is hypertension. So even if the diastolic BP is elevated, it is hypertension. But fortunately, as age advances, the diastolic BP comes down. So as the patient becomes older, usually that problem is solved on its own. But you have to treat it. There is no doubt about it. It is not an invasive drug. It is something like a CT scan, where you get the coronary artery calcium score. The advantage is there is no human being involved. The machine gives the report. So only a technician is required. It is a very good test, but underutilized.
So I would like your stand from the cardiac perspective on treatment of 3 drug groups in a diabetic patient: cilnidipine versus amlodipine, rosuvastatin versus atorvastatin, and pioglitazone versus DPP-4 from the cardiac perspective in a diabetic patient.
Well, with respect to cilnidipine plus amlodipine, amlodipine has the largest data that is available. So far, if you consider all antihypertensives, there is no drug which can compete with amlodipine as far as data is concerned. So I personally is a votary of amlodipine compared to cilnidipine. But recently we did a study which is actually published in American Journal of Cardiology, where what we did was that we compared telmisartan with amlodipine versus telmisartan with cilnidipine in 100 patients, and we measured central aortic pressure, pulse wave velocity, ambulatory blood pressure monitoring, and to our surprise we found that there was not much difference between the two. But of course it is only a 100 patient study, so I would still say amlodipine is the drug of choice. Between pioglitazone and DPP-4 inhibitors, if you look at the data, if you want to get benefit from cardiovascular point of view, I would still go for pioglitazone as long as there is no renal failure or heart failure. If there is even the mildest LV dysfunction, I will not give pioglitazone because it produces water retention. And what was the last question? Atorvastatin versus rosuvastatin. I don't think it makes any difference. What is important is the dose, the intensity. It doesn't make any difference.
We found that the higher dose 40 milligram rosu or 80 milligram atorvastatin is not needed to achieve the target which we have set. Because Indian population, there may be some difference, especially in Kerala where we practice. Are there any studies, or are you still sticking on to the same American recommendation?
No, as what I said, it is not only less than 75, it is also 50% from the baseline.
which means if your baseline LDL is 100 and you are a high risk candidate, you have to bring it down to 50, not less than 70.
It will come with 20 milligram or 10 milligram.
So this 50% reduction can be attained only by high intensity statin. Either 80 milligram or 40 milligram is good enough. 40 is also high intensity. So I would still suggest 80 or 40, but not 20. As far as rosuvastatin is concerned, 40 or 20, but not 10.
So thank you, friends. As we are running short of time, we will conclude this session. Thank you, Govindroni, once more.
Thank you.
Thank you, sir, for this informative session. I welcome the chairpersons to present the memento to Dr. T. Govindranoni for his marvelous contribution to the RSSDI. Thank you, sir. Now I request Dr. Kasim Kolakadan to hand over the mementos to the chairpersons. Thank you, sir. For those who wish to be an important part of the RSSDI Association, there is yet a chance. To register to be a member of the RSSDI, there is a counter right outside the hall and we have a lady to guide us there.
Of insulinization from hospital admission to post-discharge. And to chair the session, let me invite Dr. Vishnu Vasudevan, Maulana Hospital, Perinthalmanna, and Dr. Anup V.S., District Hospital, Perinthalmanna.
Good morning. So, welcome to this wonderful event. This is the third session of the program, and we have a eminent speaker. We should say he is a teacher of teachers and a mentor of mentors. He is Dr. R.V. Jayakumar, sir. He is a senior most endocrinologist from Kerala. He was a formerly professor of endocrinology at Amrita Institute, and he is now working in Astromedicity and Caritas Hospital. He is the past president of the Endocrine Society of India. He is the past national president of Rssdi, and he is the founder president of Indian Thyroid Society. He was also recently elected as vice president of the Asia Pacific Organization of Thyroid Organization. So I invite, sir, his lecture is on the optimal insulinization in hospital and at the time of discharge. So that's a very important topic for all the physicians and everyone who is practicing diabetes and endocrinology. So I invite R.V. Jayakumar sir for his speech.
Dear friends, thank you at the outset for the nice words of introduction, but I don't deserve all this. Anybody who grows to this age or remain at this age will have all these things in their background usually. Second thing is I must thank the organizers for this meeting today for inviting me here, and I must thank Novo Nordisk for requesting me to present this topic today. As you know, the spectrum of insulin, the previous speaker was an excellent speaker. He gave us about the cardiology, and all the physicians are interested because even the public is interested. When they have a cardiology problem, they will run to the cardiologist and get it done. When it is a diabetic problem, they will say, oh, this is only diabetes, we'll eat some, we eat and take some tablets and that is enough. Not only the attitude from starting from the government of India to the down officials of Kerala, this is the attitude. Oh, it is only diabetes, take tablets and eat some wheat and all those things. So the topic will not be very interesting, but the topic is what the previous speaker has said, glycemic control. That is the most important thing. In addition to the blood pressure and lipid control, glycemic control is main for managing diabetes. Just a financial disclosure. Yes, so if you look at the chronic complications of diabetes, it is a microvascular complications, macrovascular complications you all learned during your MBBS days, and non-classical complications are also now described. That is the cognitive impairment, depression, and then latest on the fatty liver, the NFLD and NASH, and lastly heart failure, which you and I were not thinking about it when you managed diabetes 5 years ago. Now we always look at it, whether this patient has got cardiac failure, which is incipient or obvious and all those things when you prescribe drugs. And obstructive sleep apnea and all those things. If you look at the drugs or armamentarium at our disposal to control diabetes, what are the drugs? If you look at very clearly, the amount of hemoglobin A1C reduction possible with the different drugs, starting from GLP-1 receptor agonist, ending up with SGLT2. The maximum one is for the pre-mixed insulins of 1.91%. This is a published study, but we don't usually see this type of changes because in clinical management we always combine the drugs. We always combine with insulin with other things, or we combine one OAD with another one. So you can't be very clear which drug has contributed to the maximum reduction in a given patient of yours. But if you individually study this is the available literature showing that the insulin has got the maximum hemoglobin A1C reduction. So when a patient gets admitted to the hospital, whether it is for acute illness or for investigations, you will be called as a physician, will be asked whether it is for some operation, pre-operative, for labor or cesarean section or hysterectomy, whatever it is. They will call you if the patient happens to be diabetic, give your expert opinion and fitness certificate for or make the patient fit for the undergoing the surgery, the diabetic patient. And usually when the patient is in the hospital, there is not much time for the OAD, the oral antihypertensive, to play around. You want quick results, and the quick results are possible only with using insulin. So insulin is the usual thing. So it all depends upon what type of patient you are dealing with. If the patient is critically ill in the intensive care unit, you may require intravenous insulin, whereas if the patient is in the ward running around, you can use still the subcutaneous insulin to manage the diabetes. And the usual thing, if the patient is in the hospital and we want to get a tight control of blood sugar, the basal bolus regime is the usual thing which is accepted all over the world. Superior efficacy compared to multiple subcutaneous insulin injection. And why it is so? Because every time you eat and drink, your blood sugar goes up. That can be sorted out by a bolus dose, and the basal dose look after the hepatic or production of glucose and all. So basal, the ADA recommends the use of basal bolus regime in the following settings. That is basal to control the fasting state of insulin requirement, bolus the mealtime insulin requirement, and correctional depending upon the blood sugar values you can add or subtract the dose of insulin which you already prescribed. And this is definitely will improve the glycemic control of the patients in the hospital. And the use of basal bolus therapy, these are the things I think everybody, you are all doing it in day-to-day practice. When you start using start with usually with the 0.4 unit per kg per day. Consider lower units depending upon the body size and all those things. And the other thing is prefer IV infusion when there is uncontrolled hyperglycemia despite the use of basal bolus regime. And then initiate IV infusion at a dose of about 0.05 to 1.1 unit per kg per body weight, and titrate the infusion. So nowadays it is very easy. When I was a medical student in 1970s, it was very difficult as a house to titrate the dose, because if you take a sample and send the blood sugar, it will take 2 hours for the blood sugar report to come. By the time the patient has gone to another state of glycemic state, and your management will not be perfect. Now we are all lucky that in every hospital and anywhere you can know the sugars on the spot itself, and you can take a decision. So that is one advantage which you and I are having nowadays with the availability of technological improvement, the blood sugar. So some people may ask you, are you sure that what you are measuring at the bedside by the glue is perfect and correct? But at least it is reasonable, and it gives a really good idea what is happening to the patient's blood sugar value. So with that availability, it's easy to titrate. See, every hour, usually in a intensive care unit, what you instruct the nurses to do hourly blood sugar, GRPS by the glucometer, and inform the doctor, so that on the basis of the blood sugar you will decide whether to increase the insulin infusion rate or decrease the days or stop it for the time being and do it. So it is much more convenient nowadays to do this. And the target also you must know, when you are in the hospital treating a patient, where should you keep the blood sugars? It is usually said that 140 to 180. If you can keep the blood sugar around 140 to 180 around the clock when the patient is in intensive care, that is the ideal thing. There was previously one study which shows that if you keep it below 140, Swedish study, which showed that when you get the number of patients requiring the ventilation, the number of stay in the intensive care all reduced by keeping it less than 140 or 130 like that. But people found out that that produces more of cardiac problems and more of other mortality, even though the patient, the number of days in the intensive care can be shortened. So now the accepted criteria is to go for about 140 to 180. If you are happy to, if you can achieve that target for your patient in the intensive care or in the hospital setting, you can be credited as managing the diabetes very well. I think just remember that nowadays every talk must start with a case and end with a case and all those things. So here is a patient who is a female patient, diabetic for the last 4 years, weighing around 75 kilos, BMI around 30, and BP around 150 by 60, creatinine is around 1.8, LFT normal, and activity moderate, and his hypertension for the last 3 years, dyslipidemia, hypothyroidism for the last 6 years. Drug history, the patient, she is on glimepiride 2 mg daily, metformin 1 gram daily, sitagliptin 100 mg daily, telmisartan 40 mg daily, rosuvastatin 10 mg, and levothyroxine 100. The question is, what that patient requires tight control, because the hemoglobin A1C is 10.2%. and his fasting blood sugar, her fasting blood sugar is 210. So a blood sugar of 210 and hemoglobin A1C of 10.2 with metformin, glimepiride and sitagliptin is a very poor control, and you have to take action. And the patient is admitted in the hospital. So you have to change over or to add on to insulin regime, and what type of insulin to use. There are now long-acting basal insulins are available. Glargine is available, and the new co-formulation insulin is also available. So you can, this study which shows that if you compare Degludec, which is a co-formulation, compared to the Glargine, the fluctuation, day-to-day fluctuation is much lesser with Degludec compared to Glargine. And the other thing is with the Degludec, the Glargine is around 20 to 24 hours time, whereas Degludec is 24 plus to 32 to 36 hours. So one advantage is that you can, even if you delay the second 1 day's dose by few hours, it will not be affecting. So here it is, the morning, even up to 8 hours change in the time of the 24-hour dose is not going to affect much if you are using a preparation which has got an activity up to 32 to 36 hours. So Degludec has got that advantage, and so the patient was put on IV fluids, supportive medications, OAD stopped, basal bolus regime was started, and telmisartan was stopped, and statins and thyroxine was continued. And this is the, at the end of the day, see, on 26/6, the blood sugar value was 142, the lunch value is 192, and the night value before was 174, and so the patient was well controlled, and the patient was discharged on sitagliptin, metformin, glimepiride, and Degludec 15 milligram, and 50 days follow-up, and she was well controlled. So how can we effectively, how can we offer effective, safe and convenient insulin therapy to this patient post-discharge for the ambulatory care? So the thing is that the advantage of this drug is this co-formulation is of ultra-long-acting insulin Degludec with the rapid-acting insulin aspart. It is, if you inject in the subcutaneous area, it is a co-formulation. You have got the long-acting preparation which is on the blue, and the short-acting which is on the red color, and once you inject it, the hexamer shape, is Degludec is in hexamer shape, and the hexamer shape is the aspart, and once it gets, the phenol diffuses quickly, and the insulin degludec dihexamers link up via single chain contrast to long multi-hexamers, and the initial action by the short acting ones and the longer action by that. And if you look at this is how it is acting. The initial action is taken over by aspart, the meal time taken for, and the basal level is maintained by degludec. And remember, this degludec combination gives you a 1.4% reduction of hemoglobin A1C and 70% reduction of improvement in fasting blood sugar. So, and also Rssdi ESI clinical practice recommendation of 2020 shows that the practice recommendation for management of type 2 diabetes, once you are decided to give insulin, degludec is once daily degludec is recommended as choice of insulin initiation as far as this Rssdi ESI guidelines recommend in 2020. So the advantage of this is intermediate start and stay therapy. Patients uncontrolled on oral hypoglycemic stress, patients uncontrolled on basal insulin, patient uncontrolled on premix insulin, and patient uncontrolled on basal bolus therapy. This degludec combination is good, and it may be for type 1 patients or type 2 patients, elderly with type 2 diabetes, and type 2 diabetes with the renal or hepatic impairment and other comorbidities. So initiation is very easy, administer alone or in combination with the OADs. So now another case, Mr. Das, a teacher in the high school, 56 years old, and type 2 diabetes in 7 years, hypertension 5 years, and the present drug is metformin, glycoside, linagliptin, rosuvastatin, telmisartan, glimepiride, and pregabalin. And this is the blood sugar values. Fasting 220, postprandial 312, hemoglobin A1C is 9.5%. So definitely he requires some modification in the treatment because the present drugs are not doing it. So the question is, what do you do start? Should you go for a basal insulin suitable for high carbohydrate or for direct control? So basal is not the one because here the both fasting and postprandial both are high and the hemoglobin is high. So the consider premix co-formulation suitable for high carb diet and suitable in case of delayed insulin therapy, offer direct control of PPG. And insulin initiation usually easy. You can continue once daily with the major meal of the day, counseling, and you can continue with the OADs. But the question is, once you are decided to give this combination preparation, both basal and short bolus regime, whether to continue with the sulfonylureas. That is the question which is usually asked. You can see, but in this patient, because the patient was on glycoside, which is a sulfonylurea, it was stopped. But if you ask me clearly, do you want to stop sulfonylurea when you start insulin for all this uncontrolled diabetes? There are studies which shows that there may be a place for continuing sulfonylurea in some cases. Then what is the basis for it? Because you are decided to give insulin because the beta cells have already gone and unable to produce insulin, so are you giving insulin from outside? Then why do you want to give sulfonylurea, which is going to stimulate insulin production? The argument in favor of is that, see, when you give injection subcutaneously, it reaches first the peripheral circulation and finally reaches the liver, which is the main source where the metabolism take place, where insulin is required. That's the last part. Whereas if your pancreas, if this patient so-called non-responding to OHS, he or she may have some beta cells reserving. Even that little amount of beta cells producing little insulin, if it reaches from the pancreas direct to the liver, it will be more effective than what you are injecting from outside. So that is why some of your patients, even if they are put on insulin, they will do better when you give an added sulfonylureas. That is advantage. And other thing is the extra pancreatic effects of sulfonylureas also is there. That may be also contributing to it. So I am not saying that you must all patients whom you have put on insulin because of OHA failure should be continued with the sulfonylureas, but some of the cases may require it, and the explanation is that it is because even the small quantity of insulin which is produced by the pancreas goes straight to the liver, where the action takes place. So this patient was aiming for total control of both fasting and postprandial, and you can see after 6 months of therapy, the fasting is 146 and postprandial is 182, and after 6 months, another 6 months, 1 year, the hemoglobin A1C has come down to 6.9. And CGMS was down. Nowadays, if you want to convince the patient that your treatment is good and you are having a round-the-clock control, CGMS is available now. Only thing is the cost factor, but it definitely gives you clues to do the finer tuning of your insulin or OH therapy, which one to increase, where is the rise of blood sugar, which part of the day, and all those things. So if you can affordable, and don't do it on day one when you have uncontrolled diabetes, it will be very high. After giving the whatever therapy, basal bolus or whatever therapy you are giving, and after making sure that many of the fasting blood sugar and postprandial sugars are reasonably controlled, then even if your hemoglobin A1C is elevated, then that is a time to consider CGMS, so that you will get the clue where you are missing or where your diabetic tuning has to be perfect. And Mr. Das is on current treatment with the degludec in 24 units, metformin, linagliptin, rosuvastatin, telmisartan, and so the aim is for total control of both fasting and postprandial blood sugar. Insulin initiation should be suited to the individual requirements, considering the Indian realities of diabetes management. So I must wind up saying that people with type 2 diabetes should have a good glucose control so as to reduce the risk of severe COVID-19 infection also nowadays. Diabetes was one of the most frequently comorbidity in COVID-19 patients. Uncontrolled diabetes leads to severe COVID-19, resulting in higher IUC admissions and increased mortality and morbidity. And with these few words I thank, and only the message is that in the hospital setting, for a tight, you require a very tight control, and for a good tight control, you require insulin therapy. And insulin therapy, the best is basal bolus, or you can consider co-formulation where both are, the number of injections can be brought down because of the combination of short-acting with long-acting insulin. Thank you.
Thank Jaykumar sir for his excellent speech on co-formulation insulin importance. So I have one question to Jaykumar sir, and after that I think one or two questions, because we have finished right on time. One question I have is, sir, they say that this co-formulation insulin should be given at the largest meal of the day, but considering that it is after breakfast that the maximum glycemic excursion occurs, what is your take on that, whether we should start it at the breakfast, or which meal is the one in your practice as you found more suitable?
Okay, the question is, if the patient is on multiple OHAs and you are going to add this insulin, not as a basal as a treatment in the hospital when you are going to take off the patient from all the OHAs, but the patient is on OHAs and you are going to start. It depends upon the cases. Some of the cases I may start in the night because the fasting is the higher on. With the other OHAs are able to manage the postprandial spikes. But usually morning, see, you are elderly patient, you are worried about the blood sugar going out at night. Second thing is post breakfast is on the higher side. So then that case I will start in the morning. So the morning for people who are elderly people who have got elevated postprandial blood sugar compared to fasting. See, both are elevated, okay, that is another thing. But if there is a disproportionate elevation of postprandial blood sugar, the morning is the best. If disproportionately the fasting is elevated, fasting is 180, but postprandial is only 220 or 230, I will give it night.
Thank you, sir. The session is open for discussion. Any questions from the audience? I think there are many senior physicians and diabetologists who would like to put in their words regarding this co-formulation insulin. We have this in the market for many years now, and we have some advantages, and some patients you might have found that it is not suitable in some group of patients. Any comments from the audience?
Yes, any comments? Are you? The thing is, the simple basal, the problem is it will only cover fasting. The advantage here is this is the first time this co-formulation is the one where both designer basal insulin and a designer short-acting insulin are combined together. Otherwise, you will have to give glargine and then separate to short-acting separate. You can't give. This is the only advantage of this. But two designer insulins being put in a single packet and given injection. And the other thing is 24 hours, especially in type 1 diabetes, when you are giving basal compared to glargine, degludec is found to be a little more effective because 24 hour to 36 hour cover in a type 1 diabetes so that the fluctuations can be reduced compared to, there are studies which show that compared to glargine this is better. But for adults type 2 it is all variable. There are studies, both companies will bring out the study saying that this is better, that is glargine is equally effective. These people will say this is little better, so slight difference is there.
This is a very good addition. Actually, the only cost factor is the cost factor is the only thing which limits in an oral practice. But definitely it is an added advantage, especially as Sir has said, once daily it scores over the glargine. Definitely it scores over glargine, especially for type 2 diabetes.
No further questions. Let us conclude this session. Once again, thank you, sir, for such an excellent set. And I offer thanks for the Rssdi team for arranging such a wonderful session by sir. Thank you, sir.
Thank you for that informative session, sir. Now to present the memento to the speaker, let me invite the chairpersons, Dr. Vishnu Vasudevan, sir, and Dr. Anup V.S., sir. Now to present the memento to the chairperson, let me invite Dr. Mumtaz Bam, gynecologist, MES Medical College, Perinthalmanna.
Thank you, ma'am. Thank you, sir. Now, let us move on to the most awaited event of the day, the debate on diabetes reversal, fact or fiction, between Dr. Joe George Calicut and Dr. Prashant Shankar Pathanamthitta. Dr. Joe George is the Senior Consultant Endocrinologist and Director of EndoDie Group of Institutions, and Dr. Prashant Shankar, MBBS, MD, MRCP, FRCP, Consultant in Internal Medicine and Diabetes, in MGM Mudud Hospitals, Pathanamthitta. Now, let me invite our esteemed moderator of the debate, Dr. R.V. Jayakumar, sir, Director and CEO of the Indian Institute of Diabetes, Trivandrum, and endocrinologist of Aster Medicity, Cochin. We welcome you, sir.
Very good morning. See, as you know, all continuing CME programs nowadays, debate is a very important thing because there will be always two speakers. They will be looking at both the aspects of a problem, and the audience can get a good evidence, the evidence based on the argument and where should you vote for it. And in the end of the day, we will have a consensus that whoever has presented the data which is more reliable and which is more acceptable and which is more applicable to the day-to-day practice. But remember, this is only a personal, bringing out the literature. Nothing personal rivalry is not there. It is only bringing out what is available literature. And you know that two doctors will always, one thing common among doctors is they always agree to disagree rather than agree to agree. So that we will also have some disagreement with this. So Joe is a very popular debater, I think, and having been in the field and having worked in Mumbai and all those things in famous hospitals in Mumbai, he will be arguing that diabetes is a reality. You are going to say it is a reality. It's not so?
Yes, sir.
Okay, so you will be very popular in the social media, I hope so. Because social media is the one which highlight that we modern medicine people are misusing the drugs and giving toxic chemicals and destroying the human beings. And you are the person who are going to say that we are really destroying the person. Okay, Dr. Joe, please.
Thank you very much, sir. First of all, I would like to thank the organizers of Rssdi Perinthalmanna for giving me this topic. But my topic for today is to talk on diabetes reversal, whether it's a reality. What is a debate? Debate, as per the definition, is an argument about a subject, especially in a formal manner, where there could be difference of opinion or a conflict of interest. But here, I don't have a conflict of interest for sure. Why? Because unless there is a misinterpretation of the question or the available facts, there is not a debate itself here. Let's go outside this debate. The senior teacher who is sitting in front of me is possibly one person who has been the examiner for maximum number of MD students in medicine and the DM students in endocrinology. So if he is sitting in front of me as an examiner and asking me the question for my DM endocrinology exam, Mr. Student, can diabetes be reversed? And what is the answer that I am supposed to give there? Outside this debate, what is the answer? Is there any chance that diabetes can be reversed? If he is asking me as a DM examiner in my DM exam, the answer I would be giving, and answer all of you should be giving, is yes, diabetes is reversible. Why it's so? Why is it so? Because the question is not that can you reverse all diabetes? It is not that can you reverse type 2 diabetes. That is not the question. The question is, can diabetes be reversed? And the answer is yes. It's not moving. Slide is not moving. Yeah, fine. See, why I'm saying so is because let's take this case scenario from 2004. It's a live case scenario of a 17-year-old female with a history of diabetes, history of 18 months with facial puffiness, weight gain, red striae, livid hyperpigmentation, difficulty in standing from squatting position, amenorrhea, was admitted with diabetic ketosis with a RBS greater than 600 and a ketone body which was 3+ positive. She was treated in ICU with routine measures, stabilized to basal bolus regime. On evaluation, she was found to have a basal cortisol of 17.2 microgram, basal ACTH of 25.9 and an ODS cortisol of 6, and MRI showing a microadenoma of 18 to 7 millimeters. She was, as you know, it's a very simple diagnosis of a case of Cushing's disease, and she was treated with transphenol pituitary surgery, and after 6 months you can see her photo. What's there? She is completely cured of the disease. And in 2020, I am having a follow-up after 16 years. She's now a 33-year-old female with 2 children, 12 years, 8 years, with a fasting blood sugar of 81 and postprandial sugar of 111. Not even a history of gestational diabetes. And now tell me, is she cured of diabetes? Yes or no? Yes, she is cured of diabetes. Why? Slide is not moving properly. Yeah, see, why? Because the reason for diabetes in this patient is not that ominous octet. The ominous octet that we are talking about is not the reason for her diabetes. Slide is not moving. Sorry. No. No. You go to the first slide. This is the last slide we are showing. Do you have a slide changer or something? Yeah, now it's moving. Fine. Now it's moving. So the reason for her diabetes is not ominous octet, which has caused the diabetes like any other type 2 diabetes. But the reason for her diabetes is the pathological excess of counter-regulatory hormones. The beta cell is normal. The pathogenesis of so-called type 2 diabetes is not working here. Her pancreas is perfectly normal. So when you remove that excess production of counter-regulatory hormones, her sugar goes back to normal, and the reason for diabetes is completely removed. When do you say that a disease is cured? When the pathogenic mechanism is removed and you can say that the disease is completely cured. So in this case, the disease is completely cured. I am not going to the explanation of hyperglycemia in Cushing's, but it does not involve the pancreatic beta cells. The same is true with hyperglycemia in pheochromocytoma. Not just that, there are other diseases also, like this patient who is having acromegaly. She can have diabetes, not because of the problem with pancreatic beta cell. It is because of hypersecretion of growth hormone, which is a counter-regulatory hormone to insulin. And the same thing with glucagonoma. We know it's a hypersecretion of glucagon that can produce diabetes. And just treatment or removal of the tumor cures the disease. Not even that, even GDM, if you look at the NHS criteria, what is GDM? GDM is a high blood sugar that develops during pregnancy and usually disappears after giving birth. What happens in GDM? We know that it's the fetoplacental hormones which is in hypersecretion, which produces increased insulin resistance, and because of the compensatory increased insulin secretion is there, and most of the patients, this hypersecretion of counterregulatory hormone happens in all patients. 80% of them compensate by excess secretion of insulin from the pancreatic beta cells. It's less than 20%, 15 to 20% who is not able to compensate it properly, whom we label as GDM. Here again, what happens in GDM? 30% may progress to type 2 diabetes in the next 5 years. So what happens to the next 70%? 70% is completely cured of the disease. And even then, those patients we have seen that those people who go on for a lifestyle control and exercise and weight loss and a proper lifestyle, we see even after 15 years, they don't have diabetes, and also a lot of them would have gone through a second and third normal pregnancy without a gestational diabetes. So here again, what would you call them? Actually, won't we call that there is a cure of the disease there also? So when you ask this question, is diabetes reversible, as a debatable question also, I would say it's not a debatable question, because of course diabetes is reversible. Only thing is that we have to see what is the basic pathogenic mechanism that is there in place, that is playing here, and whether that pathogenic mechanism is reversible. That is for the debate part of the today's topic. But as for this is an academic discussion, this is a forum of Rssdi, I would just point out a few other points which is outside the debate topic. Can you reverse type 1 diabetes? What are you talking, doctor? Type 1 diabetes, how can it be reversible? We know that beta cell is completely damaged, isn't it? So can it be reversible? Here I would like to talk about the James Bond 007. Have you seen James Bond movies of the 60s? There are so many gadgets which are given there, which we would have saw. Even the latest James Bond movie, all James Bond movies shows gadgets which are imaginary. But most of them, if you look at it, they are based on some concrete theoretical data of possibility. In the 1960s movie, if you look, you can see GPS system, internet system, mobile phone, wireless phones and all those things. Even laser guided machine guns are there in 1960 movies. Then we would say that that's imaginary. But this is a James Bond movie watch, which was there in the 1960 movies. Now we know that much better watches are available. So it's just based on the current concrete concept. That is science, isn't it? Something which is not just imaginary right now. If the scientific concept is there, we know that it may happen in the future. In the same way, in type 1 diabetes also, there is beta cell regeneration to the transdifferentiation of pancreatic cell, which is undergoing research. That means people are thinking of regenerating beta cell from the remaining cells of acinar cells and ductal cells. And is that an imaginary thing? Not really. There are actually the methods which have been devised, the theory which has been postulated and has been put into research. And what is the current status? There are actually multiple ways of trying to regenerate the beta cells that is happening currently. And what is the status? There are cell sources within the pancreas that has been definitely shown to regenerate to beta cells currently in research. Earlier it was just in animal practice, but recently, as you can see from the study which came in Cell Journal, Cell Review, which is a very reputed journal, it has been shown that in human studies are also getting successful. This is a 2017 article which shows that in humans, even in humans, pancreatic beta cells has been found to be regenerating in trial situations. That means even in type 1 diabetes, we are going to see a revolution of possible reversal maybe in the next decade. So even type 1 diabetes in the next future may be a reversible disease. What about type 2 diabetes reversal? There is a problem of the definition. There is a consensus definition which says a partial remission, complete remission and prolonged remission, where prolonged remission is complete remission for at least 5 years. And what is cure or reversal? That's a debate question. It's not remission, that's a debate question today. It is about diabetes reversal. As per the definition, they say that a complete remission or 5-year period is arbitrarily chosen as a period of reversal, is called as reversal of diabetes. So what is the data? Here I am looking at some data on type 2 diabetes on 5 years. I have only taken data which is there for more than 5 years data, because that is the definition of reversal and not remission. Can I have 1 more minute, sir? Yeah. So here it's a bariatric surgery, that's a Stampede study which showed that less than 6 of A1C at 5 years was seen with gastric bypass surgery in 30% of patients, sleeve gastrectomy with 23%. So by the current definition of ADA and ESI, there is a diabetic reversal in stampede study with bariatric surgery in 30%. And this is the Swedish obesity study where again 15 years follow-up. It's not just a small number, it's 15 years follow-up. They say that in surgery there was a reversal at 15 years of 30%. Why is it so? Because weight loss induces diabetic reversal or remission by reduction of ectopic fat deposition that is there in the muscle cells, intrahepatic cells and intrapancreatic fat cells, which we producing a sustained improvement in muscle, liver, insulin sensitivity and improves beta cell function and leads to a diabetic reversal in type 2 diabetes. There is a counterpoint study which was a very small study with 11 people where there was a very low caloric restriction of 600 calories and it was shown that there was complete reversal. And this is the last slide I would like to present is a 2-year remission data of direct trial which they have seen that there is a complete reversal of diabetic mechanism. So reversal in diabetes, type 2 diabetes, is it a possibility? Yes. Is it possible to reverse all type 2 diabetes? No. Does pathophysiology of diabetes reverse with caloric restriction and bariatric surgery? Yes, to a varying degree. Is reversal durable? Probably yes. Is it practical? Absolutely. So coming to conclusion of the debate topic, is diabetic reversible? Again I am saying absolutely. Of course it's reversible. Only thing is that diabetes due to excess counter-regulatory hormone is reversible, GDM is reversible, type 1 not yet, but in the future it would be reversible, and type 2 diabetes, the probable answer is yes. Thank you very much.
Thank you. Take a seat here. I think we can call the person who is going to oppose the statement. Dr. Prashant Shankar. He's a leading practitioner, practicing physician, diabetologist in Koranjeri area of Central Kerala. He has done his MD and FRCP, and he is going to give us the definition and his view of diabetes reversal. Dr. Prashant, please.
Very good evening to all. Can I have the slides, please? At the onset, I would like to thank Rssdi for giving me this opportunity. It's a very difficult task for two reasons. One, I am standing against a very seasoned endocrinologist who has given a big chunk of evidence on diabetes reversal. Second thing, I am speaking against one of my favorite topics of diabetic reversal. So, diabetes reversal or remission. So that makes it double difficult for me. But as I have been given the topic, I will have to stand with what I am given. Is this slide moving? Yeah. Dr. Joe has spoken about the reality. So I will be talking about the real reality. So again, I would say that I have no conflicts of interest, because at the end, if I am telling that diabetes is not reversible, indirectly I will be supporting all the pharma companies, because naturally I will have to write the drugs for treatment of diabetes. So at the end of this topic, you might feel that my views are pessimistic, negativistic, nihilistic or unscientific, but what I am trying to do is I am just trying to be realistic. Black is a favorite color nowadays. So this is what I saw when I woke up today morning, when this is my Twitter message which I got from Dr. Shalini Singhal, who is a well-known dietitian. So she was just talking on a patient who approached after, I am not able to view this in this thing, so that's why I am looking back. This is comfortable for me. Can I go back? This is going back automatically. Yeah. Yeah. I think. So this is a patient who went for a diabetes reversal program after reading the book from Amazon, and suddenly he spent 85,000 for a diabetes reversal program. Within 2 days of diet itself, he got fed up and came back to a dietitian for a decent plan, not for reversal, but for just for basic diabetes control. Next slide. So these comparisons might look wide. So you can see these are on the right, you can see direct, diadem, counterpoint, retune. These are all the landmark trials on diabetes. The names on the other side may not be familiar to you, but all these are studies which looked at a car which is driven by water. So that is again something which we wanted to be real about. So a car which is driven with water without using much of energy and without using much of current. Again, this was a reality. This is not something which is a myth. This was a reality for some time. And we had, we had something like this which was being used a decade ago, but this never materialized because again, there were a lot of problems in between. So this is Roy Taylor, everybody knows him, and Dr. Joe has also spoken about him. And this is what he mentioned about stopping of diabetes or reversal of diabetes. Is there anybody in this audience who is able to put his genes at the age of, which he wore at the age of 21 years? Anybody? Probably Dr. Joe is wearing the same size as in the age of 21 years. That's why he was so confident of lecturing on diabetes reversal. Yeah. So definition of diabetes remission, this is the ADA definition of diabetes remission. I will not talk about diabetes reversal because the ADA has not spoken about diabetes reversal. It's only diabetes remission because that's where the evidence all points towards. So just one thing, it says that only for a period of 3 months, at least for a period of 3 months if it's a diabetes reversal, diabetes remission, the time period is only 3 months. But what are we going to achieve just by keeping the patient at remission for 3 months? It's a lifelong process. So these are the numbers which we are looking at. Diabetes, the IDF's data which shows the amount of patients which are having diabetes, the patient at risk of diabetes, and the numbers are going high every day. And the poor glycemic control still prevails. We are talking about bringing back a patient to less than 7 or 6.5 or less than 5.7, which is complete remission. But we are having a population which is having a mean HbA1c of 8.2 despite the best of standard of care which is being provided. And we are not able to even bring the patient to good glycemic control. Then how are we going to bring this patient into remission? This is what all the studies have shown. This paper again was co-authored by Dr. Ranjit, who has just arrived. Again, he will agree that the amount of glycemic control in this country is very poor. And I am just comparing the CVOTs with the remission trials. Why I am putting the CVOTs? Because these have shown that drugs for diabetes are safe. Drugs for diabetes help us to prolong the life and beyond the standard of care. So you can see the number of patients enrolled in all these studies. And amazingly, you can see the number of patients in the diabetes, the landmark trials of diabetes remission. You can see hardly 300 patients. And it's not only the number of participants which we are talking about, the duration of trials. Again, you can see all these trials have got significant duration. And you can see the direct was the maximum for 22 years. Dr. Joe was speaking about that. And one thing to remember, at the end of 2 years, there was 29% dropout in the direct study. And again, the patient selection for trial. The cardiovascular trials, you know that patients had high risk ASCVD, established ASCVD. Even despite of that, they were living longer. And you can see the landmark trials for remission. You can see young patients, 3 years of duration, and again 6 years of duration. The retune, again 2.5 years of duration. And calories, this is probably the most important slide of the day. Anybody knows what was given in the direct trial for patients to eat? This was the food, 800 calorie diet. You might think that this is a complete meal, but this is breakfast, lunch and dinner. Sorry, it's not moving. Can you put the next? Yeah. So, how many of you will be able to take this diet for at least a period of 2 weeks? I won't be able to take this for at least a single day. So therapeutic dosing is very important. So the importance of appropriate dosing in the context of lifestyle modification can hardly be overstated. Lifestyle modifications required to produce diabetes remission are significantly more intensive than that is produced to prevent diabetes. So preventing diabetes is actually what we should do. And that is much more easier than putting a patient into diabetes and reversing back. So this is what the studies have shown. These are a group of studies which looked at therapeutic dosing of diet. That is, you can see the calories. You can see the calories here. You can see the total calories is around 1,000. And these are the studies where they looked at reducing the calories to less than around 500 from the baseline level. But all these studies failed to show any good amount of remission. And another thing, all the data which is there is from the RCTs. We know that RCTs are different from the real world practice. So numerous studies have associated poor medication adherence and problematic long-term persistence with poor patient outcomes for patients with diabetes. I might take a couple of minutes longer because this is taking a lot of time. And as we know, in contrast, patients enrolled in the RCTs may be more likely to take their study medication as directed. The dropout rates are likely to be less. And they will be more motivated to improve their health because somebody is there from the top who is guiding them. This is a beautiful trial which looked at the aspect of remission on a long term. This is actually the droplet trial, which had an initial period of controlled, focused treatment, and then the patients were followed up. This is not a randomized controlled trial. This is actually a pragmatic trial, which we are nowadays more talking about because it has got more value than an RCT, because it has got it is something like a mixture of an RCT with the real world. So again, you can see at the end of 3 years in this trial, nothing happened with respect to the HbA1c or body weight. The only thing which happened was slight reduction in the diastolic BP. That was the only statistically significant thing which was there. Sorry, it's not moving again. Yeah, this is something which we heard Dr. Shashank Joshi talking about in the ADA, which was over a couple of weeks ago. And again, here we are using artificial intelligence to reverse diabetes. Again, you can see the duration of diabetes in these participants were 3.9 years. And HbA1c was 9%, and the number of participants was very less. Again, this is something in which the patient were put on a strict diet, and more than diet, it had a lot of changes associated with behavioral change. Lot of behavioral changes were introduced into the patient. You had a lot of gadgets put on to the patient, and you can imagine how difficult it is to continue such a plan. And this is not something which is done free of cost. Next slide. Yes. So I just tried to look at the cost of this TWINS program yesterday, and this is around, it costs around 75,000 per month. So per year. I think it was more than 1 lakh last year, because nobody was there to take up. They have cut down the price, and it's not available in my place also. So now we are looking at artificial intelligence, and where we should use our own intelligence. Next slide. Again, this is the direct trial. You can see what happened in the direct trial. The incremental cost of the direct trial, you can see the gray line, the incremental cost compared to the control group. So this is not something which comes at free of cost. It's something has got a high economic burden on the patient. Next. This is a very popular program in the US, the Verta Health, which is again looking at diabetes reversal. And again, you can see it costs around 30,000 or 20,000 per month for the patient. So there are a lot of barriers for transitioning into a healthy lifestyle. The inability to maintain intensive lifestyle intervention, poor nutrition education, economic burden, the lack of motivation. Next slide. Important disparities in diet quality. Those belonging to lower education are having poor access to all these things. And again, the emotional stress is a big factor. Next slide. And as you can see, the emotional stress and weight regain are very important things which are happening, especially in the females, where they find it difficult to control the weight. Next slide. So barriers are present at different levels that impede a transition to a healthy lifestyle. You can see lot of things are there. These are things which are present to make a patient from poorly controlled diabetes into a controlled diabetes. So we are talking about going beyond that into remission and into partial and complete remission, which at this moment I would tell that it's more of a myth than a reality in the majority of the patients. So these are the most important things of behavioral change that we have to look at while putting any patient into remission. I am not talking about the endocrine diabetes or the type 1 diabetes. I am talking about the type 2 diabetes. The term reversal and the discussion of reversal has come only because of the amount of reversal which is being hyped in type 2 diabetes. So I am restricting the discussion to type 2 diabetes, and I am restricting the discussion to the dietary part, because we all know the problems and the restrictions and the limitations of bariatric surgery. So stages of change, the pre-contemplation, contemplation, these are the preparation, action, maintenance and relapse. So all these things are very important. It's very important to get a patient into this track to make sure that the patient goes into some sort of lifestyle change. And only if the patient is in the maintenance phase, he will be able to maintain the diabetes remission if it happens. Otherwise, he will soon fall back into the relapse. So at this moment, I would just one slide back. One slide back. So I had, will you be able to play the audio? So I had one patient who was asked for a good dietary intervention. I would just like to play the video of audio of that patient. So this is the reality which we are facing every day. I think everyone will agree with that. So you can get books in the Amazon, you can read a lot and enjoy the topic of, I too spend a lot of time on life without diabetes, reversal of diabetes, low calorie diets and all those things. But in reality, it will take a long time. I don't say that it's not something which cannot happen, but at this moment, it's more of a myth than a reality. And what can be a reality is preventing pre-diabetes, NASH, metabolic syndrome and gestational diabetes from getting into diabetes, which is very much a reality, and that can be done much easily without much less cost, much less intervention and much less caloric restriction. So that is the reality and not the reversal of diabetes, which is reality. So this is the slide in all my presentations, irrespective of the topic which I present. You have to use the best scientific evidence. You have to take into consideration the patient's values and your clinical experience. So if you look at only at the scientific evidence, you can say that diabetes remission, yes, by all the papers, it is possible. But if you take it as a whole, you might tell that still it's far from a reality. Lifestyle medicine is something which is coming up in a big way. That has been the basis of diabetes remission. If anything has played a role in diabetes remission, that's purely lifestyle medicine, because it's not the diet and exercise which matters. You have to manage stress, relation, sleep and avoid substances to maintain the patient in remission. And whether or not the patient has gone into remission, even the ADA recommends that you have to follow up the patient for the look out for the complications. Even if the patient is in remission, you have to screen the patient annually for the complications. Thank you for the patient listening.
Thank you. Dr. Prashant, please take that chair and sit there. Put it. Okay, sit. Okay, I think both the stalwarts have discussed their points. I think few things are highlighted here. First of all, the most important thing our studious Dr. Joe has brought out is that whoever is a scientific chairman has not put the question correct. He put, so the fault is, he's a very shrewd student. He screwed the examiner. The problem is, the question was, can diabetes reversible? and he took up the part of the secondary diabetes and showed everybody. But the question was not for type 2 diabetes, that is the thing. Second thing is, everybody says that because we are living in a free country like India, freedom is you can talk anything today, you can call the Prime Minister or President anything, no action is taken, unlike other countries. So in a country like India, where you can practice whatever you want, you can write anything in the this one, free internet, all these things and all these messages. What is happening to the diabetes rate with all these things, freedom available? Is it increasing or decreasing, Dr. Joe? Hey, sit down, sit down. With all these things, with the freedom to do, freedom to act, freedom to listen.
Say from the, as a social person, as a politically or a national loving person, I should be unhappy, but as an endocrinologist or a practicing doctor, it's like a thief saying that people getting rich, I should be more happy. Isn't it? So the diabetes increasing, in a way, it's good for us, isn't it?
That is but the fact that diabetes is increasing, you are free to practice whatever this one, then still it is increasing. That is a point I personally feel is a point against that it is reversible. If it is reversible, at least some people would have followed and the rate would have been at least leveled off rather than going up like this. What is your, Prasad, is there any restriction in the country for people to practice whatever is given in this website and all those things?
Yes, sir. It's again regarding the behavioral change. It all depends on the behavioral change. Even though people know that they are taking the wrong things, they are unable to control the diet which they are taking, or they are unable to change their lifestyle. So I think despite all these evidences on diabetes reversal and all these things which are coming up, the rate of diabetes is going up.
I personally feel that I've been in the practice for the last 50 years after MD medicine. I think I around 50 years, 72 to now to. So 50 years, what I find is good old days the number was few, now the number is going up sky high. Even though freedom is there, you can add, so many gadgets are there, it is still going up. So there is, second thing is, we have not defined what is cure. Because he said 5-year cure. So Dr. Joe very tactfully take up that definition, 5-year cure. But you have seen after bariatric surgery, even you say only 30% after 10 years or so, something like that, you showed a slide. So 30%, can you say treatment is effective? Is it right? 30% reversal is. Okay, so all said and done, what is the opinion of the crowd? Yeah, for those who think that it is reversible, can you raise the hand? Do you think it is reversible? Only 1, 2, 3 people only say that it is reversible. And the rest, sorry, 4 people. 4 people of the house feels that diabetes is reversible. And what about the rest? Non-reversible? Anyway, see, the message is that, I think at the end of the day, what is this CME programs and what is the debate? To highlight what are the things which are happening in the field of medicine and especially in diabetes and regarding the reversibility. And Dr. Joe and Dr. Prasad has brought out their views. They have highlighted the studies which showed it. And I am sure both of them agree that it is partially reversible. I am sure. And I think the crowd here also, our friends here also will agree it is partially reversible. Especially secondary, okay, 100% reversible, secondary diabetes. Partially reversible in type 2 diabetes, especially if they have if they change into the Gandhian mode. So they must be lifeline change into Gandhian mode. Work like, our Mahatma Gandhi. So, but if you can change people to Gandhian mode, it will be reversible. But I think Gandhis are born only one Gandhi in a century. So the rest are all non-Gandhis. So it is reversible for that guy who is willing to become a Gandhian and accept the policy, and who is really having type 2 diabetes, not other diabetes. But otherwise, I am sure Dr. Joe, who said it is reversible, will also agree that it is only partially reversible, and in a certain number of cases. And what about you, Prasad? You also think it is only partial? You also agree that even though it is not reversible, you also agree that it is partially reversible in certain cases?
Yeah. Yes, sir.
Sir, here one point I would like to highlight is that a surgery which ends up in failure in 99% of the cases and is successful in 1%, but when you take that one person who has, for that person, it's a success. So when you look at from that point, sir, I totally agree that it's a very difficult thing to practice, but a person who is willing to do that, a motivated person who has the right guidance and is willing to do that, significantly, like that counterpoint trial, 11 people who actually did it, it was 100% successful in all patients. So for that, even though the percentage is less, for that one person who is ready to do it, it might be reversible. No, sir. Sir, actually we have up to 15 years follow-up data which I have presented, which says that up to 30% remained in remission. See, that we know of the time bomb of the complications that happen. So if we can just metabolically and physiologically and biochemically reverse it for 15 years, I think that's something worth taking. If the person is ready to do the hard work. See, nothing comes free of cost. Either you pay for the bariatric surgery or you pay for the diet.
I think you must agree that quality of life is very important. Yeah, we are you and I live, but the quality is very important. How with the quality of life, as he showed that slide and the plate and all those things. So any.
Me, it should be discouraged, because you are removing an organ which is not at all connected with anywhere related to diabetes, and the total surface area of the villi of the small intestine is is the size of a tennis court. And Dr. Jayamar sir has not taught me about GLP-1 and SGLT2 at that time, because it was not known. There are so many other hormones maybe there. My daughter may be teaching about another hormone from the intestine which is maybe there, which he is asking me to destroy. I totally disagree with that, but I agree with that with him regarding it should be tried. Reversal of diabetes with lifestyle change and behavioral change should be the focus, and the prevention of diabetes is the most important thing, as both have said. Prevention of diabetes is, I am for prevention of diabetes rather than reversal of diabetes. Diabetes is not to be reversed. Only the lifestyle has to be reversed, and the behavioral change has to be made normal. That is my point of view. Thank you.
Yes, I think Dr. Joe also quoted so many things. This which is whose cinema? That cinema? James Bond series and all. So like that, in 1980s, I wrote an article in Kerala Medical Journal, future of this transplantation and cure of diabetes. That is in 1980, saying that a day will come when you can walk into the diabetic, when you are a diabetic, walk into the diabetic, get an intrahepatic injection of beta cells and forget about diabetes, only to keep it as a past history in your medical records. That was the thing which was hoping in 1980s. Now it is 2022. That is, at least 42, nothing has happened. Still, we are talking. But I think this reversibility and all this is a good for us. People who can meet together, you have to have something to talk about. So you can, some topic of interest, go on talking around it, have some fun. I don't think it is a reality, because I wrote it at that time in 1982. Still, it is still like that. Nothing has happened. So like that, we can hope for the future. But I'm sure something will come as you go time and again. Something will come. Your beta cells get regenerative and type 1 may get reversed. Hope for the best. And I think any other comments? I think we'll all wind up by saying that type 2 diabetes, the question must be modified as type 2 diabetes, and it is partially reversible with intense physical modes of lifestyle changes. Thank you. Thank you both the speakers.
That was indeed an engaging, wonderful and fun-filled session. Thank you, sir. Now, as an appreciation for Dr. George and Dr. Prashant Shankar, I request Dr. R.V. Jayakumar, sir, to offer this small memento as a token of appreciation.
Dr. Abdul Nasser Sir, IMA Perinthalmanna President. Dr. Shaji Abdul Ghafoor, Organizing Chairman. Dr. Jayakrishnan B, Organizing Secretary.
Good morning, all. Respected Chairperson, Dr. Chandini, our Chief Guest, Professor Dr. R.V. Jayagumar, IMA President, Dr. Abdul Nasser, Rssdi Kerala Chapter Secretary, Dr. Suresh Kumar, today's Organizing Secretary, my friend Dr. Jayakrishnan B. Welcome you all. As we are running short of time, I'll just mention the names. Although they are all stalwarts of diabetes care in Kerala, I first of all welcome our today's chief guest, Professor R.V. Jayagumar, sir, for the event. നമ്മുടെ എല്ലാവരുടെയും പ്രിയങ്കരിയായ ഡോക്ടർ ചാന്ദിനി മാഡം. ഡോക്ടർ ചാന്ദിനി മാഡമാണ് നമ്മുടെ RSSDI കേരള ചാപ്റ്ററിൻ്റെ ഇപ്പോഴത്തെ ചെയർപേഴ്സൺ. ഈ പ്രോഗ്രാമിൻ്റെ എല്ലാം മാഡത്തെ ഞാൻ ഔപചാരികമായിട്ട് ഈ പരിപാടിക്ക് സ്വാഗതം ചെയ്യുന്നു. നമ്മുടെ ഈ പ്രോഗ്രാം നമ്മുടെ IMA പെരിന്തൽമണ്ണയുമായിട്ട് അസോസിയേറ്റ് ചെയ്ത് നടത്തുന്ന പ്രോഗ്രാമാണ്. അതിൻ്റെ ഇന്നത്തെ നമ്മുടെ ഗസ്റ്റ് നമ്മുടെ IMA പ്രസിഡന്റ് ഡോക്ടർ അബ്ദുൽ നാസർ സാറിനെ ഈ പരിപാടിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. നമ്മുടെ RSSDI കേരള ചാപ്റ്റർ സെക്രട്ടറി ഡോക്ടർ സുരേഷ് കുമാർ ഈ പരിപാടിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. ഇന്നത്തെ പരിപാടിയുടെ ഓർഗനൈസിംഗ് സെക്രട്ടറി ഡോക്ടർ ജയകൃഷ്ണനെയും ഈ പരിപാടിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. എല്ലാവരെയും ഈ ഫാക്കൽറ്റീസ്, നമ്മുടെ ക്ഷണം സ്വീകരിച്ചെത്തിയ ഫാക്കൽറ്റീസ്, ഡെലിഗേറ്റ്സ്, ദ ഫാർമ പീപ്പിൾ, എവ്രിബഡി, I am giving a warm welcome for the session. Thank you all. I invite Chandini Madam for presidential address.
Respected Chief Guest, Dr. R.V. Jayagumar Sir, IMA President, Dr. Abdul Nasser, IMA Perinthalmanna, and other dignitaries on the dais and off the dais. COVID-19 has taken a lot of our time for the last 2 to 3 years, and in fact we have gone through a very interesting debate and we have forgotten the huge pandemic we have been tackling over the last several years. And Jayagumar sir rightly pointed out, we are really every day we are telling that the number is increasing day by day. So we in RSSDA, we have a huge task with us. And for me, my association with RSSDI has started from immediately after completing my MD General Medicine, and it has been closely associated with Jayagumar sir. The first research grant I got was in 2004-05. It was a rupees 30,000 from RSSDA, and it has given me the whole lot of interest in research. And in fact, I still can't imagine at that time I could present that paper in 2006 IDF South Africa. So that was the motivation that an association can give, and I think all the juniors should really take up this opportunity to be members of RSSDA, and we should bring up the research part in a bigger way. And today we have a very good academic program, as we can see, and RSSDA has been lot of thing in the past. Except for the COVID-19, it has been actively involved, and with this year we are really pushing on more activities, academic programs, educations, interventions, both for the patient, public, as well as doctors and other healthcare providers. And with this start, probably with all the support of every seniors who have contributed significantly in RSSDA, starting from Jayagumar sir, Muddi sir, and all our colleagues here, we would be able to take it in a further heights. And I really proud and congratulate to be associated with Dr. Shaji and Dr. Jayakrishnan in organizing this program in a brilliant way. And the list we have, the brilliant speakers we could gather today here, starting from Dr. Geeta AP, Govindanunni sir, Jayagumar sir, Jojo and Prashant we have already listened to, and now we have other great speakers joined here, Dr. Sunil Prashop, Dr. Ranjit Unnikrishnan. In fact, I am proud he is here. There is another reason, because he is from Calicut Medical College and all the way from Chennai. He did his MD. And Dr. Vijay Kumar sir, Ajit Kumar and Arun Shankar. And we will enjoy the scientific feast and we can move together for a better, stronger Kerala, India, which will take care of all these problems we have been discussing day in and day out. Thank you so much.
Thank you, ma'am. Next, we have the inauguration ceremony by our chief guest, Dr. R.V. Jayakumar sir, Senior Most Endocrinologist of Kerala and our senior member. We are really honored to have sir here amongst us today and are grateful to you, sir, for agreeing to inaugurate the first meeting of this new Rssdi team. We invite sir to inaugurate the function by lighting the lamp and request all the dignitaries on the dais to join the program.
Thank you, sir. Now we request Dr. Abdul Nasser. Now we request Dr. Jayakumar sir to deliver a speech.
Good morning. Dear friends, at the outset, let me thank the organizers for inviting me here, for inaugurating and giving this honor of inaugurating this first conference of Rssdi Kerala, New Kerala chapter. As you remember, Rssdi is completing 50 years this year. That means about 50 years ago this organization was formed. But remember at that time, it was started by Professor M.M.S. Ahuja and team, and the person from Kerala who was responsible at the time was Professor Givargis. And 5 people were the main instrumental in starting that. Professor M.M.S. Ahuja, Tripadi from Orissa, Dr. Givargis from Kerala, Dr. Vishwanathan from Chennai, and Dr. O.P. Gupta from Gujarat. These are the 5 people who joined and started the session. At that time, it was decided that it is a membership is for research people related to diabetes. That is why the name Rssdi came, Research Society for Diabetes India. You have to be a researcher with postgraduate degree, working in an institution, having papers and all, then only you can become members of this. And I still remember in the early 80s when I go for conferences, Rssdi annual conference, it was not a separate conference, it was associated with the Endocrine Society's conference. And there will be about 30 or 40 people of us, that is all. Because admission was restricted, it's only you must be in the teaching faculty of an institution and all those things and doing research, then only you can become a member. But as you know, it become, everybody, crowd is required and more people participation is required. And the diabetes was getting not very much popularized at that time. It was only the research, some people from institute do some research and show it. Pancreatic diabetes from Givargis sir will do some research from Kottayam and show it like that. So it was being confined to too much. Then when P.V. Rao was a secretary at that time in, I think in early 90s, it was decided, no, we should make it more democratic or more, this message of diabetes must be carried all over the India, and it is the physicians and general physicians and all the general practitioners must be involved in it. Then only we can spread the word about diabetes, and the new drugs are being discovered at that time. So pharma companies also get interested. So finally it was decided, I still remember in one of the meetings that membership may be, the basic qualification for membership for Rssdi must be in MBBS only. With those, anybody with interest in diabetes with MBBS. So then started the organization, it became the number 1 now in Asia. I think the biggest number of diabetic related physicians organization is Rssdi. But only thing is the name is little not very attractive, because every time you will ask RSSD, they will ask what is your relation with RSS and all that. So I think in early 90s we suggested to change the name, but I think the old Star Wars like MMS Ahuja and all said no, you cannot touch the name, it is meant for research. And Dr. Givargives was one of the oldest person from Kerala who had the privilege of becoming the national president of RSSD and all those things. And I am the only one now after that who has got the chance to become the president of our national president twice. I was there in 2002 and 2004. Twice I was there. And the thing is that we in Kerala, this Kerala chapter was started actually initially in the early 90s. We started as a Kerala Diabetic Federation, KDF. And then in late 1990s, RSS Central Committee passed the resolution that you must start the state chapters. Then what I did is I changed this KDF meeting, one of the meetings we passed a resolution, dissolved the KDF and it formed the Kerala chapter of RSD. That was it. At that time, if I remember correctly, N.N. Ashokan was the president and I was the secretary at the time, the founder, president and secretary, and that started it. And then we had a nice time. Kerala chapter had done history at the national level because we conducted twice the national conference in Cochin. In 2002 and 2012, I think. 2002, I was the organizing secretary and Dr. Ashokan was the organizing president. In 2012, I was the organizing president and Jabbar was the organizing secretary. And we made, that was the first time in 2002, the number of RSSD annual conference went about 1,000. In Cochin, first time, it was in 2002. Then now the crowd is 3,000, 5,000, and it goes like that. And during that 2012, we made a good profit. More than 150 lakhs of profit was made by the Kochi conference, and we got 75% of that as our contribution from the central. And from that only we managed to buy a flat. We decided to buy a flat for better to have. See, the money is meant for research only. They give you for research. But I suggested that if you research alone, you can't do research for 50 lakhs, 75 lakhs research. The money may be spilled over. So better to have a place where we can sit and all. That is why the IMA house, we purchased a flat in IMA house for about 30 plus lakhs, I think. And so that we at least have a base now. And this Dr. Chandani said the research grants, because RSSD when I started, they started making a textbook, we started a journal, but the research was the last one which was started in 2002 or something. The national decided to give grant, and we followed it up and gave it. The Kerala chapter also decided to give grant, and we had a lot of papers, not of international standard, at least standard care, to know what is happening in Kerala regarding diabetes. So many people got there, and still the money is there, I think, and it's not so. Secretary, we have got a lot of money, and I think we must organize more research, and the new committee must make sure that more research and more diabetes data related from our area must be published and brought out. And I think that today's debate, as I said, they can see the Kerala diet and the classical Kerala diet and how we can prevent diabetes or cure diabetes, whatever it is, anything, some hot topics must be selected, I think. So research is good, but very molecular level, many of our practitioners may not be interested, but if it is something spicy, hot topic which is going to create media awareness and channels interest and all, will be much more useful. That is my personal view, because as you want to highlight the importance of diabetes, it must be more media related and all those things. And I wish the new team headed by Dr. Chandani and to run the show very well, and I am sure you will take our Kerala chapter higher heights and have another national conference here, and some of you must become national presidents in the national committees and become presidents and all those things, because otherwise we will be sidelined. So without somebody in the national committee, our presence will not be well appreciated. And good old days, Dr. Givargis was there in the committee, so we used to get some preference because he's a senior most guy. So when he says a thing, they will give. Because we got 2012 diabetes annual conference because so many people objected. We can't give it to Kerala at a time. It's not very. Then Givargi said, see, I may not be, this is my last wish. I have to have a conference. Finally they agreed. When he said they agreed and gave it. But real sad part was that in the conference, first day morning he came and inaugurated the scientific session. In the evening session, he was not seen. See, evening session, the official inauguration when the minister came to inaugurate in the I was waiting for him, he is not in the chair. Then people came and asked, did you not, because did you not call him, did you not invite him? I said, he came in the morning. Anyway, we didn't have time to find out what happened. Anyway, the function went on, and then later on only we found out that he was putting the jacket for coming for the inaugural function. He collapsed and fell down with cerebral hemorrhage, and that was the last. So his last wish was to have the conference, but at least morning he inaugurated and later on he passed on. So anyway, it was a real memory event. We were able to conduct it twice, and we must conduct further conferences and make our Kerala chapter's presence well in the Indian area. With these few words, I officially inaugurate the conference and wish you all the best for the deliberations.
Thank you, sir. Now, I request Dr. Abdul Nasser, sir, President of IMA Perinthalmanna, to give the facilitation speech.
Chairperson Rssdi Kerala State Chapter, Dr. R. Chandani, Secretary Dr. P. Suresh Kumar, our organizing Chairman Dr. Shaji Abdul Ghafoor, Secretary Dr. Jayakrishnan, respected teachers, faculty members, and dear colleagues. Good morning and greetings from Indian Medical Association, Perinthalmanna branch. We are really happy and proud to be part of this prestigious meeting. I'm sure that this is really a very informative session with a lot of relevant talks to our present practice. This benefits many sectors of the doctors, not only to the physicians or diabetologists. It is helpful for people like me, anesthetists, the obstetricians and surgeons, because it covers a vast area of topics. Dr. Jayakumar told that this society is mainly to promote research. I think it's relevant in our country because there is a lot of varying prevalence in diabetes in different parts of this country. There is a rural-urban difference, there is a north, middle, and south difference in the prevalence. So we have to look into the cause of this, maybe the racial aspect, maybe the lifestyle aspects, or the food habits. And if we do research on this aspect, we'll be able to at least implement some preventive measures. I hope you will direct your association guidelines in this and do something. And the second thing, this talk is really, this meeting is really very useful, and on behalf of Indian Medical Association, I wish this meeting all success. Thank you all.
We invite Dr. Suresh Kumar, Secretary Rssdi Kerala Chapter, to kindly felicitate Dr. R.V. Jayakumar sir, today's chief guest and senior member of Rssdi, with Ponnada and citation. Thank you, sir. Next, we request Dr. Abdul Nasser, sir, President of IMA Perinthalmanna branch, to honor Dr. R. Chandani ma'am for getting Best Doctor Award and Best Teacher Award with a Ponnada and citation. Thank you, sir. Next, we request Dr. Jayakrishnan B., Organizing Secretary, to kindly give the vote of thanks.
മാന്യബന്ധുക്കളെ, അതീവ സന്തോഷത്തോടെയാണ് ഇന്നത്തെ പരിപാടി ഇതുവരെ നടന്നു പോകുന്നത്. നമ്മുടെ RSSDI കേരള ചാപ്റ്ററിൻ്റെ സ്ഥാപക നേതാവിനും തന്നെ ഉദ്ഘാടകനായും ഒരു പ്രസൻറ്ററായി നമുക്ക് ലഭിച്ചതിൽ അതിയായ സന്തോഷവും കൃതജ്ഞതയുമുണ്ട്. ഒപ്പം തന്നെ ഞങ്ങളുടെ ക്ഷണം സ്വീകരിച്ച് ഇവിടെ എത്തിച്ചേർന്ന എല്ലാ സഹപ്രവർത്തകർക്കും എല്ലാ പ്രഭാഷകർക്കും ഇൻഡസ്ട്രി സുഹൃത്തുക്കൾക്കും എല്ലാവർക്കും ഹൃദയത്തിൻ്റെ വാക്കിൽ നന്ദി രേഖപ്പെടുത്തുന്നു. അസോസിയേഷൻ ഓഫ് ഫിസിഷ്യൻ ഓഫ് ഇന്ത്യ കേരള ചാപ്റ്ററിൻ്റെ പ്രമുഖ നേതാക്കളും മറ്റ് സഹസംഘടനകളുടെ പ്രമുഖ നേതാക്കളും ഇവിടെയുണ്ട്. വി അക്നോളജ് ദെയർ പ്രസൻസ്. അതോടൊപ്പം തന്നെ റിസർച്ച് സൊസൈറ്റി ഓഫ് സ്റ്റഡി ഓഫ് ഡയബറ്റിസ് ഇൻ ഇന്ത്യ എൻഡോക്രൈനോളജിസ്റ്റുകളുടെയോ ഫിസിഷ്യന്മാരുടെയോ മാത്രം സംഘടനയല്ല, മോഡേൺ മെഡിസിൻ പ്രാക്ടീസ് ചെയ്യുന്ന എല്ലാവരും നേരിടുന്ന ഒരു അവസ്ഥയാണ് പ്രമേഹ ബാധിതരുടെ എണ്ണം കൂടി വരികയാണ്. പ്രമേഹത്തെപ്പറ്റി കൂടുതൽ അറിയാനും ശാസ്ത്രീയമായ അറിവും ചികിത്സയും പൊതുജനങ്ങൾക്ക് പറഞ്ഞു കൊടുക്കാനുമുള്ള ലോകത്തിലെ ഏറ്റവും വലുതിൽ രണ്ടാമത്തേതായ വി ആർ വെരി നെക്സ്റ്റ് ടു അമേരിക്കൻ ഡയബറ്റിക് അസോസിയേഷൻ മെമ്പർഷിപ്പ് ബേസിസിലും പ്രവർത്തനങ്ങളുടെ രീതിയിലും കേരളത്തിൽ RSSDA വളരെ നല്ല രീതിയിൽ മുന്നോട്ട് പോവുകയാണ്. എല്ലാവരും ഒപ്പം നമ്മുടെ സഹപ്രവർത്തകരെയും ഇതിലെ അംഗങ്ങളാക്കിക്കൊണ്ട് നമുക്കിതൊരു വൻ മുന്നേറ്റമായി കൊണ്ടുപോകണമെന്ന് അപേക്ഷിച്ചുകൊണ്ട് എല്ലാവർക്കും ഒരിക്കൽ കൂടി ഓർഗനൈസിംഗ് കമ്മിറ്റിയുടെ പേരിൽ പ്രത്യേകിച്ചും ഇതിന് അരോഹാത്മം പണിയെടുത്ത ഡോക്ടർ ഷാജി അബ്ദുൽ ഗഫൂർ സാർ ഉൾപ്പെടെ എല്ലാവർക്കും ഒരിക്കൽ കൂടി നന്ദി പറയുന്നു. നന്ദി, നല്ല നമസ്കാരം.
We'll now move on to our next session. Challenges in management of gestational diabetes mellitus. I invite the chairpersons, Dr. Mumtaz, MES Medical College, and Dr. Sujit S. Nair, Maulana Hospital, Perinthalmanna, for chairing.
Good afternoon, everyone. After that inauguration session, we will immediately move on to the next scientific session. As we are running short of time, we will quickly go through. And next session is regarding the challenges in the management of gestational diabetes mellitus. As you all know, gestational diabetes mellitus is a very common problem which we all used to frequently encounter in our daily practice. And to guide us regarding the updates, we are having an eminent speaker, Dr. Sunil Prashop, who is MD FRCP, FCCP, FIAMS, PGDHSC, Professor of Medicine and Diabetologist from Government Medical College, Kollam. MBBS, he had his MBBS and MD General Medicine from Government Medical College, Trivandrum. He had as postgraduate diploma in diabetology from Annamalai University. He has certificate course in diabetology from MV Diabetes Research Center and Hospital, Chennai. And he is an invited speaker for various conferences, and he has numerous publications in his national and international journals in his credit. And over to you, sir.
Good morning to all of you. Let me at the onset itself thank RSSDI for this fantastic opportunity. It's a real privilege for me to be here presenting on a topic gestational diabetes. So this is our agenda, the gestational diabetes, the current definition, the pathophysiology, screening and diagnosis, complications and management. So let me start my presentation with a case which I happened to see 3 weeks ago. He is a patient, 35-year-old, second gravida. He was found to have diabetes at 27 weeks of gestation. And since diabetes was mild, she was put on lifestyle modification. And after 2 weeks, her results came like this: fasting 98 and PPBS 156. So is her glycemic control adequate? what is the next line of treatment. So as we all know, pregnancy is a diabetogenic event. The woman is transformed from a physiological point of view by the nutritional demands by the fetus, the metabolic changes in the mother. The gestational diabetes mellitus is any degree of glucose intolerance with the onset or first recognition during pregnancy, and the prevalence has been steadily increasing. And if you look at the prevalence, it comes up to 15% of the pregnant woman worldwide. So if you look at the statistics, we can know that globally there are around 21 million GDM per year. If you look at the Indian statistics, it says that around 5 million GDM per year. And the most important aspect is the Indian woman, there is a 11-fold increased risk of GDM. And the most important aspect, if you are treating GDM, you are treating 2 generations. It is very clearly said that 50% of the GDM develop type 2 diabetes over a period of 5 to 10 years. So any degree of glucose intolerance between the normal, the fasting between 95 and 126, the 2-hour PPG between 140 and 200, you say it as gestational diabetes. So this is what is happening. If you look at the first half of pregnancy, due to the effect of estrogen, there is an increased insulin sensitivity. But if you look at the second half of pregnancy, after 20 weeks, there is an increased insulin resistance and there is a diabetogenic stress. And this leads to the 2 things, the pregestation. The early half of diabetes is seen, it is pregestational diabetes, and after 20 to 24 weeks, it is the gestational diabetes. So this is a very clear concept. There is a facilitated insulin action during the first half of pregnancy. And during the second half of pregnancy, during the development of placenta development, the increased placental hormones like the human placental lactogen, the cortisol, the prolactin, all these cause an increased insulin resistance. And there is a 3 times more insulin is secreted by the 3rd trimester. So this is a very, very clear concept. In normal pregnancy, what happens is there is an increased insulin resistance that is equally matched by the insulin secretion. But in a GDM patient, the increased insulin resistance is not matched by the insulin secretion. So that is why the GDM develop during the second half of pregnancy. And why do the beta cells fail? And these are multifactorial. There are genetic factors. There is chronic insulin resistance antediabetic pregnancy, and there is a level of subclinical inflammation. So this is another very important concept all of us know. It is an increase when there is an increased glucose. This glucose can cross the placenta. This can cause an increased insulin release in the fetus beta cells. As a result, as we all know, insulin is an anabolic hormone. It can cause macrosomia. What happens to the neonate? There is an increased incidence of neonatal hypoglycemia. And in the future child, there is a high risk of obesity, IGT, and GDM. Type 2 diabetes. So these are the complications from the perspective of maternal and fetal. There is increased chance of miscarriages, infections, cesarean section, birth trauma, all these complications are there from maternal point of view. But if you look at the fetal point of view, one of the most important aspects is the congenital anomalies, the macrosomia, the shoulder distortion, neonatal asphyxia, hypoglycemia. These are some of the important aspects that we should look. When you think of screening and diagnosing, this is really a big area of controversy because several aspects has to be looked upon. Selective versus universal screening, the timing of testing, the 1-step or the 2-step approach, and the criteria. The most important risk factors of GDM is there is a history of GDM in the past, the obesity, macrosomia in the past, age more than 35 years, strong family history of diabetes, all these are risk factors for GDM. So when it comes to the universal versus selective screening, the most important, the India and the South Asia, all these countries are considered as a very, very high risk population. So there is absolutely no concept of selective screening. We will have to do universal screening the moment the patient steps to your clinic. So Indians are a very high risk. We should do the selective screening the moment patient comes to you. And when it comes to the screening, as I have already told you, there are different ways by which we can screen the patient. Most often, the second screening is during the period of 24 to 28 weeks. There are different ways by which you can screen. There is a one-step method, there is a two-step method, which I think the madam has very clearly in the morning pointed out, the one-step. The two-step methods are accepted by the American and Canadian guidelines, while the single-step method has been accepted by the WHO, IADPSG, and DIPSI. So there is a one-step method, there is a two-step method. So what ADA says is that you can go with a two-step method. The first, you give a 50 gram of glucose. After 1 hour, if it is more than 140 milligram, you can do a second step with a 100 gram 3-hour OGTT. You can also do a one-step method using ADA criteria. For that, you can make use of IADPSG criteria. So this IADPSG criteria makes use of 75 gram of glucose. You can give in the fasting state and look for glucose in the fasting 1 hour and 2 hour. There is another criteria known as the DIPSI criteria, in which the patient comes in a non-fasting state and you take a 75 gram of glucose, and after 2 hours, if the blood glucose is more than 140, you can diagnose. So there are several advantages if you are using DIPSI, because in the resource limited settings, you can really use this DIPSI guidelines, which even the Ministry of Health, India government has accepted using this DIPSI guidelines. So if you look at very closely the diagnostic criteria, the IADPSG criteria makes use of the single one-step method is accepted by WHO, ADA, FIGO, and Australia. All these guidelines are accepted in IADPSG criteria. So why to diagnose and treat GDM? Because you want to treat both the mother and the child, which I have already told you. You want to treat both the child and the mother. That is what importance of GDM. One of the very important things that we should all understand is, in the first trimester, if the blood glucose is elevated, there is an increased risk of fetal malformations. But in the second and third trimester, there is an increased risk of macrosomia and the metabolic complications. So this is why we aim to treat. We want to treat the macrosomia, the shoulder distortion, the neonatal hypoglycemia, the increased incidence of cesarean section. All these are our focus when we are trying to treat the GDM. So this is a very, very famous study, HAPO study, hyperglycemia and pregnancy outcome study, published way back in 2008. It is basically a Caucasian study in which Indian population was not included. Around 25,000 people were studied in this, and it very clearly showed that when the blood glucose were elevated above the normal range, there was increased incidence of the complications which I have already mentioned. And this formed the basis of the IADPSG criteria. The IADPSG criteria values were got from this HAPO study. Now coming to the treatment of GDM, as we all know, the lifestyle modifications are very, very important. The diet, the exercise, all these things are absolutely important. But when it comes to the treatment, the most important thing is insulin is the gold standard of treatment. To some extent, we can use the drug like metformin. So now, when it comes to the insulin initiation, there is absolutely no consensus. The targets for glycemic control and test vary. Insulin is usually initiated if the medical nutrition therapy fails to achieve the glycemic target after 2 weeks. And if the initial blood glucose are very high, start insulin along with medical nutrition. So this is what the DIPSI guidelines say. The fasting is more than 90, the 2-hour PPB is more than 120, you can start insulin. But internationally, the various guidelines very clearly say that what is the target that we want to always attain. Always focus on the target, the fasting 95 milligram percentage, the 1-hour PPG 140 milligram, and the 2-hour PPG of 120. If this is not attained, we can start insulin, and our focus for target is always these values. When it comes to monitoring of GDM, it is HbA1c is useful in the pre-existing diabetes only. What happens in pregnancy is there is an increased red cell turnover. So there is a decrease in A1c once the pregnancy happens. So you cannot make use of the HbA1c during the entire course of pregnancy. So the most important thing is the SMBG, self-monitoring of blood glucose, and monitoring is very, very important. So this is what the insulin requirement in pregnancy look like. It starts, the insulin requirement increases during the mid-half of pregnancy, it rises, and by 36 to 38 weeks, it suddenly comes down. So now coming to the most important question, what insulin to use in pregnancy? You can use many of the insulins that are available, a regular human insulin, the NPH, the premix insulins, the rapid-acting analogs, and the long-acting analogs. When it comes to insulin, the insulin therapy has to be highly individualized. No convincing superiority of one insulin regimen over other is there. Many GDM have isolated elevation of the postprandial glucose levels, and in such cases, a small dose or a single dose of regular insulin before breakfast or lunch or dinner may suffice. So this is what we usually do. Look at the fasting and the pre-dinner. If it is more than 95, start with a small dose of basal insulin. And if the post-food, the post-breakfast, lunch or dinner, if it is more than 1 hour, more than 140, 2 hour more than 120, you can give a small bolus insulin. So when it comes to the drugs, which all drugs we can use in pregnancy, the most important drug is the metformin. I think all the gynecologists all will agree, and they are now using this extensively in patients with pregnancy. As we all know, metformin is being used for PCOD, and most of the gynecologists continue with the metformin throughout. There is a large-scale study known as the MIG trial, insulin versus metformin in gestational diabetes, which very clearly proved that metformin is absolutely safe when it is compared to insulin. So this is what I am telling, the MIG trial involving metformin in diabetic pregnant patients. So if you look at the guidelines which say that we can use metformin as a first-line therapy is the FIGO guidelines, the NICE guidelines, the ACOG guidelines. All these says that we can, in the resource-limited settings, we can use metformin as a first-line therapy. When it comes to glibenclamide, the thing is that it can cross placenta to some extent. It can be teratogenic. The large-scale studies are not there, and so the AD all does not advise the use of this glibenclamide anymore. So the most important aspect is insulin is the gold standard for treatment of diabetes in pregnancy, and which all analogs should not be used is the glulisine, glargine, and degludec. They are considered as category C drugs, and they are not advised for use in this group of patients. The most important aspect is the fetal assessment. As Madam earlier very clearly pointed out, by 18 to 22 weeks, we need to do an anomaly scan and rule out congenital anomalies. And the timing at delivery, it's always we can wait till 38 weeks of gestation. We cannot take it for granted that LSCS is always needed. There are specific indications, and we can look for a normal free-term delivery. And during the labor, we need to be very cautious and try to attain a blood glucose between 80 and 120 milligram percentage, and give insulin only if the blood glucose rises. The treating GDM, the story does not end there, because the postpartum follow-up is also very, very important, because as I have clearly pointed out, 50% of the patients can have or can develop diabetes over a period of 5 to 10 years. There is a 11-fold increased risk of diabetes after GDM in this group of patients. So this is what I told. So coming to the patient, which I have already discussed, she was put on 4 units of rapid-acting insulin before breakfast, and was advised to monitor her blood glucose daily. And her FBS came like this, 110 milligram percentage, the 2-hour value of 119. So is our glycemic control adequate? What is the next line of management? Of course, the blood glucose target is 110. The target that we are aiming is 95. So we need to add a small dose of basal insulin at the night. The postprandial, if you look, it is within the target, 180. So always we can add a basal insulin at the night, or even we can add metformin. So the key to success is the most important thing, the pre-conception counseling, the tight blood glucose control, the timing of delivery, the follow-up, look for diabetic complications, and the very, very amicable role played by the diabetologists and the obstetricians. So just to summarize what I was trying to convey in the last 20 minutes, the prevalence of diabetes is increasing. The complications are also increasing. When you are treating GDM, you are not only treating the mother or the fetus, you are treating 3 generations. You are treating the perinatal complications, and it is a window of opportunity to treat the mother developing diabetes in future. It's a window of opportunity to prevent diabetes, obesity in the future child. So it's a window of opportunity to prevent several complications. In a way, we can see that if you are treating GDM adequately, it is a part of primordial prevention that you are doing. Now, when it comes to screening, there is no more selective screening. It is a universal screening that is most important. When it comes to the diagnosis, you can very well make use of the IAD-PSG criteria. In resource-limited settings, you can make use of DIPSI guidelines. When it comes to the targets, absolutely clear. Fasting 95, 1 hour PPG 140 milligram, and the 2-hour PPG 120 milligram. There is absolutely no doubt insulin is the gold standard of treatment. To some extent, we can make use of metformin. Everything does not end there. The postpartum follow-up is very, very important. We need to follow up the mother for the future occurrence of diabetes. And once again, thank you, Rssdi, for this fantastic opportunity.
Thank you, sir, for that very informative talk. I have a doubt to ask. We obstetricians usually start with metformin because there is an element of insulin resistance in our patients, whether due to obesity or the pregnancy event as such is insulin causing insulin resistance. And how long should we wait for a patient with metformin to see whether it is acting and whether we have to add additional insulin? Is there any time period?
No, actually, there is the guidelines does not say that, because what guidelines very clearly says that regarding the lifestyle modification, 2 weeks you can look.
Yes,
but of course, if the blood sugar is not very high, we can try for 1 or 2 or 3 weeks with metformin. But it provided blood sugar should be not that high. Especially in the first trimester, we don't want to make so much, we don't want to take so many risks. As we all know, the organogenesis is happening in the first trimester. So that if the blood sugars are very high, there is a high risk of teratogenicity and congenital anomalies. So I think the thing is that the metformin, we may look for 2 or 3 weeks or maximum 1 month, not more than that.
Okay, sir, and when we start insulin, we usually admit the patient and do the blood sugars at 7 points and initiate the dose according to the trimester.
Pardon, madam?
We do the blood sugars at 7 points and initiate the insulin therapy. And we usually go by calculate the total dose by trimester wise. And once the she has reached the glycemic control, we discharge the patient. But as we know, as the pregnancy advances, the diabetogenic state increases. So should we always admit the patient to increase the insulin dose?
So what is being said about the insulin requirement is, in the first trimester, the insulin requirement comes to the tune of 0.9 unit per kilogram per day. But as the pregnancy advances during the second and third trimester, the requirement comes to the tune of 1.2 to 1.6 milligram per day. And if you are asking whether it is a type 1 or type 2 diabetes actually need more insulin than the type 1 diabetes. So it's all depends upon the monitoring. The monitoring is very important.
What the guidelines very clearly says that you need to monitor 2 weekly, once or 2 weekly, up to 32 weeks. And after 32 weeks, you monitor at least fasting and postprandial. Weekly, after 32 weeks, you monitor weekly till the pregnancy. So the most important thing is regular monitoring. There is no hard and fast rule that the patients will be coming in normal in this way. We need to monitor regularly. And as far as possible, as Madam said, 7-time monitoring would be the most ideal thing. If you are in a resource-limited setting, at least you can monitor using a fasting and postprandial.
Thank you, sir. Any questions?
Which basal insulin you use to advocate in GDM, and if you are using any other insulin analogs, which insulin analog you will prefer?
The insulin analogs, as I have already talked, in the resource-limited settings, there is absolutely no choice other than NPH insulin. Only NPH insulin we can give. But if the patient can afford, I think the Levimar or Detimar is the most ideal thing, because as I have already pointed out, Glargine does not have that huge data backup. So Glargine, Glulysin and Degludac is not being used because the guidelines does not warrant the use of these molecules.
Those patients who are coming from Middle East or like that, you used to see many prescriptions of this Glargine.
Yes, I also personally know many diabetologists or even gynecologists, you do use Glargine, but what ADA says is the Glargine is in a category C group. These drugs are category C.
Any questions from the audience?
Yeah, no, just one. Thank you, Dr. Prashop. That was super presentation. Just one comment and one question. So the comment is that is just one observation we have had. That is, you are talking about monitoring the patient and adjusting the sugar, meaning the insulins. So what we have observed is, even if the blood sugars look a bit normal, because they usually, maybe they check the fasting postprandial, even when the mother's blood sugars appear normal, we have to monitor the fetal growth and the fluid volume. If they appear disproportionately high, then probably you need adjustment of your glucose control. We may even need to add insulin in the patient who is not on insulin. And one more thing that we have observed is that when a patient comes in the 3rd trimester with decreased fetal movements, be on the lookout. She may be a diabetic, she may have an impaired glucose tolerance. That is also what we have observed from our clinical experience. Then one more, my question is, what about Detimir?
What about?
Detimir.
That's what I told.
Yeah.
Detimir can be used as a long-acting analog.
Okay, thank you. Maybe I didn't hear.
For blood glucose control, you don't have to admit any patient for for GDM or anything, because that is not needed and that is not useful also. For even if the 2-3 days, if you admit and get a good glycemic control, after that the patient is not going to get a proper control. So most important thing is to teach them SMBG. That is the most important thing. So even if you spend half an hour for teaching them SMBG at the initial point of time, first point of time, when you get a abnormal 1 blood glucose value, even if you get 1 blood glucose value abnormal, if you teach them SMBG, that is going to have a much more impact than getting a good glycemic control for a 1 week or something. The whole 40 weeks the patient has pregnancy, they have to have a good glycemic control. And I teach my patients to do an SMBG. If they are affordable, they can do 4 times daily, fasting, and after breakfast, after lunch, and after dinner. And you have good guidelines to follow. Otherwise, you get a fasting once and a postprandial once daily. You can change the postprandial. One day you can do after breakfast, one day you can do after lunch, one day you can do after dinner. That's also acceptable. Or once in a week at least. So even if that much is being done, so we can avoid many of the complications. You don't have to diagnose and treat once the patient already has developed a macrosomia. And
one more point to add is, as Madam said, most of the time the blood glucose doesn't go very, very high. Most of the time we may be able to control with a small dose of bolus insulin or a small dose of basal insulin. Very rarely we may have to go with a conventional basal bolus or most of the time, many of the gynecologists make use of this premix insulin also. But if the blood glucose is very high, and if the patient can afford, we can always make use of the continuous glucose monitoring. And this is one area which we need to practice more, the type 1 diabetes. The other indication is the pregnant patients. The continuous glucose monitoring can be very well used in this group of patients.
Thank you. Thank you, Dr. Vishnu. Thank you, sir.
Thank you for this illuminating session. May I request our chairpersons, Dr. Mumtaz ma'am and Dr. Sujit S. Nair sir, to present the memento to Dr. Sunil Prashop P. for his presentation. Now, let me invite Dr. S. Ramdas sir to present the memento to the chairpersons. Sir, please.
We sincerely apologize, Suresh sir, for missing the secretary's remarks, and we would like you to deliver the same now.
Anyway, it's already we are running out of time. I think probably you can excuse me for this thing for the time being. So I'll skip that, and please carry on with these things, academic activities. Thank you very much.
Now I request Dr. Shaji sir, organizing chairman, to onto the dais, and I request Dr. Pareed sir to hand over the memento. Now I request Dr. Jai Krishnan sir, organizing secretary, onto the dais, and Dr. Harish sir to present the memento.
Continuing with the sessions, to chair the session on the topic Clinical Aspects of Monogenic Diabetes, let me invite Dr. Ramdas Hospital, Perinthalmanna, and Dr. S. Mohandas, Ramdas Clinic, Perinthalmanna, to chair the session. Sir, please.
Good afternoon. We have now a very interesting session on a topic which is, although not very common, but often missed in clinical practice by very eminent diabetologists. We know that both type 1 and type 2 diabetes are polygenic. Now, there's one condition, monogenic diabetes, which occurs where there is a single gene is involved. There are two major types. One is neonatal diabetes, which occurs in infants and children. And second is, of course, the more important, MODY, or maturity onset diabetes of the young, which comes more in the adolescents and young people. And that, I think it's only right that Dr. Anjay Thundikrishnan is going to talk on this topic, because in fact, Dr. Mohan's, he belongs to Dr. Mohan's Research Center at Chennai. They have done a lot of research on this topic on genetics part. Majority, the diagnosis primarily comes on diabetes of such monogenic diabetes is made only by genetic testing, but clinically, a young patient who's got 3 generations, both a family history of a grandfather, father, and now son having diabetes, and a young, non-obese person fasting hyperglycemia, one has to suspect and keep things in mind. Now to introduce Dr. Unikrishan detail, Dr. Mohandas.
Hello. Our next speaker, Dr. Ranjit Unikrishan, is currently the Vice Chairman and Consultant Diabetologist at Dr. Mohan's Diabetic Specialty Center, Chennai. He has completed his MBBS and MD course in Calicut and went on to do his specialization abroad. Due to paucity of time, I don't want to go into various things which is various orders he has received, but he has received the Best Doctors Award from Tamil Nadu, and he has got international recognition as well. He is a member of several professional bodies and has written chapters in several books. Suffice it to say, he is a distinguished speaker, and not taking more of time, I would like to hand over the mic to the eminent speaker.
Thank you, dear chairpersons, for kindly introducing me to this august audience. Before I start, I would like to thank the organizers of this quarterly Rssdi meeting, Dr. Shaji Abdul Ghaffur and Dr. Suresh Kumar, for inviting me to Perinthalmanna to deliver this lecture on a topic which I feel is very important, but as the chairpersons pointed out, is quite easily missed. I'm also very happy to deliver this lecture in the presence of my teacher, Dr. Chandni ma'am, who I'm happy to learn has been awarded the Best Teacher Award, which I think is long overdue. She should have got it 15-20 years ago when she was teaching all of us. So, and along with other senior members of the profession. So without any further ado, let me move to the topic at hand. I do not have any relevant conflicts of interest. So what do you mean by monogenic diabetes? So monogenic diabetes is diabetes which occurs as a result of an inheritance of a defect or a mutation in a single gene. Now we all know that type 1 diabetes and type 2 diabetes are also genetic in origin, but they are polygenic. That means you cannot pinpoint a mutation in any single gene as being causative for the phenotype of that particular patient. In fact, type 2 geneticists is often called a geneticist nightmare because there are so many genes involved, each of which contributes only minimally to the pathogenesis of diabetes. But these conditions are not like that. If you have the mutation, you have diabetes, you have that particular phenotype. If you don't have the mutation, you do not have that particular phenotype. It is classical Mendelian inheritance. So how do you classify monogenic diabetes? Now this is a classification which I made myself, it's not found in any textbook. But I feel this is very logical and rational classification because we know there are two main pathophysiologists in diabetes. One is that there is not enough insulin, and number two, the insulin is not working properly. So you can have genes involved in both of these. You can have genes involved in insulin secretion, and you can have genes mediating insulin sensitivity or insulin resistance. Now the monogenic diabetes phenotypes caused by insulin resistance, I will not be discussing in any great detail today because they are all specific syndromes which anyone with any clinical interest should be able to diagnose. Things like Rabson-Mendenhall syndrome and leprechaunism and so on and so forth. They do not generally present any diagnostic challenge. What I will focus on is the monogenic diabetes caused by mutations in genes involved in beta cell function. And for ease of discussion, I will divide these into four phenotypes. Neonatal diabetes, familial diabetes with affected parent, mild fasting hyperglycemia, and diabetes with extrapancreatic manifestations. So these are the four categories, the phenotypes, which should alert us to the possible presence of monogenic diabetes and prompt genetic screening. So this cartoon tells you the pathway of insulin secretion from the beta cell, and this also shows you, do I have a pointer? Doesn't matter, I'll take you through the picture. So we know the glucose enters the beta cell through the GLUT2 transporter, gets metabolized by glucokinase to form glucose 6-phosphate, and thereafter takes place part in all the metabolic pathways, the end result of which is the generation of ATP through the mitochondrial electron transport chain. This ATP goes and binds to the potassium sensitive ATP channel and closes it, leading to depolarization of the beta cell membrane. entry of calcium into the cell, entry of calcium into the cell, and degranulation of the insulin granules, preformed insulin granules in the cytoplasm. And you can have mutations in genes involved in each of these pathways. You can have glucokinase mutations, you can have mitochondrial defects leading to defective generation of ATP, you can have mutations in the KATP channel, you can have defects in insulin release, you can have actual defects in the development of the beta cell, transcription factors which are necessary for the development of the beta cell, and you can have situations when there is endoplasmic reticulum stress. We all know that the protein synthesis takes place in the endoplasmic reticulum, the rough endoplasmic reticulum. So any mutation affecting this organelle can also cause defective formation of proteins. It's not moving. So it's important to know each of these because each of these is associated with specific clinical phenotypes, and these can be broadly classified into the 4 phenotypes that I mentioned. So where does this term MODY come into it? Now the term MODY was developed when in the 1960s diabetes was diagnosed and classified based on clinical criteria. In the 1960s you had maturity onset diabetes, juvenile onset diabetes, symptomatic diabetes, asymptomatic diabetes, and so on and so forth. So these two gentlemen, Tattersall and Stefan Fahans from the US, UK and the US respectively, they found that there is this group of individuals who develop maturity type of diabetes even though they are young. So it is a type of type 2 like diabetes occurring at an age where we expect type 1 diabetes, and so they termed it maturity onset diabetes of the young. And looking at lot of family histories, pedigrees, they gave these criteria. Age of onset 25 or below, no ketosis, no insulin for at least 5 years, and 3 generation transmission, autosomal dominant. But now we know that these criteria are not sensitive or specific enough to differentiate monogenic diabetes from type 1 or type 2 diabetes, so genetic studies are essential for diagnosis. And also what we term as MODY, there are different types of MODY, up to MODY 14 have been described. Number one, not all of them are true MODY. Many of them are only what we know as variants of unknown significance. They cannot be functionally or phenotypically related to any form of diabetes. Just by the way they found the polymorphism. So we are not really sure or all of these are actually pathogenic. Number two, it is a very heterogeneous condition. MODY 1 is not like MODY 2. MODY 2 is not like MODY 5. So there are a lot of heterogeneous, that doesn't really make sense to club them all under one category. So now the teaching is that better to avoid the term MODY, use the term monogenic diabetes and then mention the gene which is involved. But now we know that genetic analysis is not available for most of us, so I believe that at least for the time being the use of the term MODY will continue. As long as you know the limitations of the terminology, that is good enough. So we'll talk first about the first phenotype, that is neonatal diabetes. Now neonatal diabetes is defined as diabetes diagnosed below the age of 6 months. And at this particular age, type 1 diabetes is virtually unknown. I wouldn't say not known, it is very, very, very rare. And there are two types of neonatal diabetes, transient neonatal diabetes and permanent neonatal diabetes. As the term suggests, transient neonatal diabetes comes in infancy, stays for a while, and after a few weeks to months it disappears, but may recur in adolescence. We are more interested in permanent neonatal diabetes, which is diabetes which comes and remains and does not go away. And many of these cases are due to mutations in these two genes, KCNJ11 and ABCC8, which code for the subunits of the potassium ATP sensitive potassium channel, which is essential for insulin release. So these patients are actually insulin dependent. If you check the C-peptide, it will be 0. But they respond to tablets. Because you know sulfonylureas, they go and bind to the same KATP channel at a site distinct from ATP, which is not affected by the mutation. So here we have a situation where there is no C-peptide, but sulfonylureas will work. And that is what this cartoon shows. ATP cannot close the potassium channel because of the mutation, sulfonylureas can. So oral sulfonylureas will be the treatment of choice in these children. And to show an example, we had a baby from Kolkata. 15th day of delivery, she was found to have diabetes when they investigated for fever. They started on insulin. She was taking 3.5 units of insulin per kilogram body weight. Sugars did not come down. Sugars around 300 to 400. She was referred to us. Because of history below 6 months of age, we took a sample for genetic testing. And we found this particular mutation, which our geneticist was able to find that this has been shown to respond to sulfonylurea. It's very important. Not all mutations respond to sulfonylurea. So we cannot blindly change any child from insulin to sulfonylurea. We need to get a proper genetic diagnosis. So we started the baby on glibenclamide. Dose of insulin was gradually decreased. As you can see, this is the dose of glibenclamide. This is the dose of insulin. It became 0 by day 4, and the sugars gradually came down. So she was able to stop the insulin. And this is not the only case. We have so many cases which have been shifted to insulin and from insulin to sulfonylurea. And you see what has happened to the HbA1c. 14.3 to 7. 16.6 to 6. Remember, these children are taking insulin. With 3 times insulin, their HbA1c was 16.6. With sulfonylurea, the oral tablet, half tablet, they are able to get their A1Cs to 6. Absolutely normal. And the interesting thing here is that unlike when you give sulfonylurea for type 2 diabetes, there does not seem to be the phenomenon of sulfonylurea failure, at least for a few years. You see that for 4 or 5 years, we are able to maintain the glucose levels with sulfonylurea. These are people with KC and J11 mutation. And these are children with ABCC8 mutations. And Dr. Andrew Hattersley's group from Exeter has shown that HbA1c can be maintained for more than 10 years with sulfonylureas in neonatal diabetes. It's much longer than the effective period of action of sulfonylurea in type 2 diabetes. Usually by 5-6 years, they tend to fail the sulfonylureas. So it is a very effective and long-lasting treatment. The second form is a familial diabetes, an affected parent, and this can be misdiagnosed as type 1 or type 2 diabetes. Type 1 diabetes because they occur at young age, type 2 because they occur in adolescents and young adults, and they are able to manage without insulin. So the classical examples are the MODY1 and the MODY3. And they are due to defect in transcription factors. These are required for beta cell development and function. The most common form of transcription factor monogenic diabetes is what is known as MODY3. It is due to defect in HNF1 alpha, hepatocyte nuclear factor 1 alpha. Second most common is HNF4 alpha, otherwise known as MODY1. So many others are there. In India, actually, MODY12 is very common. MODY12 is due to the mutation in the same ABCC8 gene that causes neonatal diabetes. But it is a different mutation, less severe mutation. That is why they develop diabetes at an older age. So this again, 16-year-old girl, thin patient, came with very high sugars. She was diagnosed to have type 1 diabetes, started on insulin, not improving. She came to us. This is a pedigree chart. You see that there's a lot of diabetes on both sides of the family. That's a problem in India. There is no family in India without diabetes. But if you look at carefully, you find that the father doesn't have diabetes. The mother has diabetes, and all the members of the father's family who have diabetes are related by marriage. They are not blood relatives. So the actual familial transmission occurs through the mother's side. So naturally, we did further investigation. C-peptide was showing fairly good reserve. Autoantibodies were negative, so we did genetic testing. And here we find that, number one, the sister of the patient who came to us as normal was found to have diabetes. And everybody on the mother's side of the family who has diabetes has the mutation, this particular mutation in HNF1 alpha, whereas nobody in the father's side of the family, irrespective of whether they have diabetes or not, had the mutation. That means the diabetes on the father's side was a garden variety of type 2 diabetes, whereas the diabetes is inherited in the child from the mother's side. And we know that people with MODY1 and MODY3 respond quite well to sulfonylurea. So she was taken off insulin, started on glibenclamide. This is an old story. You can give any sulfonylurea, you can give the newer ones also. A1C came down to 6.8 and they responded to sulfonylurea even after several years. But remember, this is a progressive form of diabetes. It's due to developmental defect in the pancreas. So there is a possibility that they can deteriorate. And ultimately, irrespective of what Tattersall and Fahan said, they may require insulin. There are some reports of them developing ketosis also, case reports. So I don't think the clinical criteria are absolutely correct in this particular respect. So the moral of the story is that because of genetic testing, we were able to avoid unnecessary lifelong insulin. So MODY3 is the most common form, generally in adolescents, young adulthood, 3-generation transmission. Initially the fasting glucose will be normal, 2-hour value will be quite high. They may develop glycosuria prior to the development of diabetes because the same nuclear factor is also found in the renal tubular cells and they are very sensitive to sulfonylureas. As I said, it's progressive. Most may require insulin if they live long enough. Microvascular complications are as frequent as in type 1 and type 2 diabetes, so you should not consider it a mild form of diabetes. Lipid profile is considered to be favorable in MODY 3, but clinically, theoretically it is favorable. Clinically, you don't find any protection from CVD. And this is what happens when you stop sulfonylurea in somebody with MODY 3. So the patient is doing very well with sulfonylurea. For some reason, they stopped the sulfonylurea, started metformin, because Western countries do not allow sulfonylureas to be given in children. So only metformin is allowed, metformin and insulin. Metformin is given, A1C went up from around 5 to around 10 before they realized the mistake. Sulfonylurea was restarted and the patient got back to normal. MODY 1 is similar to MODY 3, less common. There is a risk of macrosomia in affected fetuses in this case. That is one of the peculiar findings. Otherwise, it is more or less similar to MODY 3, but because MODY 3 is more common, test for that first, and if negative, test for MODY 1. Nowadays, we have gene panels which can look for all these genes. And it is also important to make the diagnosis early, because the earlier you make the diagnosis and the better control the sugar is when you make the diagnosis, the more likely the patient is to respond to the treatment. So if you allow the patient to accumulate a long duration of hyperglycemia, the beta cell may fail due to glucotoxicity. So at that time you make a diagnosis, shift over to sulfonylurea, you may not have the expected benefit. So making an early diagnosis is very important. There are also other types of MODY. This is one of the papers which was published by one of our PhD students looking at the rarer forms of MODY, and many of them do not respond to sulfonylurea. So it is very important to have an accurate genetic diagnosis before considering shifting anyone from insulin to sulfonylurea, as in the case of neonatal diabetes. Many of them are actually not even accepted as MODY subtypes. That KLF11 and all, nobody accepts it nowadays. Third type, an interesting condition, is what is known as MODY 2 or glucokinase MODY. This is characterized by mild fasting hyperglycemia. This is due to heterozygous inactivating mutations in glucokinase gene. Glucokinase is the glucose sensor. So what happens is when you have a mutation, the glucose level has to rise beyond a certain threshold before the insulin secretion starts. And once it starts, it proceeds normally. So these people have elevated fasting glucose, 130, 135, 140 milligram per deciliter. But when you do a GTT, the increment after giving glucose will not be that high. Therefore, the HbA1c will not be too high either. It will be below 8. And these people do not have any risk of macrovascular or microvascular disease because diabetes is mild. Treatment is not required, it won't work also. So there is no need of giving treatment unless the patient is pregnant. And there too, it depends whether the fetus has inherited the mutation or not. The fetus has inherited the mutation, you don't have to worry. Because even if the glucose is high, the baby will not produce more insulin and become macrosomic. So if the baby is developing macrosomia, that means the baby has not inherited the mutation and you will have to consider early delivery. Finally, we have cases where there are extra pancreatic features. Now again, these do not generally present any diagnostic challenge. But recently there was a paper again from Dr. Hattersley's group which said that the diabetes can precede the other extra pancreatic manifestations by several years. So even if they do not have any of the other stigmata, you should look for those genes because it is very important in deciding the prognosis. This is an example, a male baby of consanguineous marriage found to have diabetes at 45 days, managed on insulin. C-peptide is low but remaining low for many years. So that means it is not type 1 diabetes. Type 1 will not maintain C-peptide over 11 years. GAD is negative. He has recurrent episodes of hepatitis. Very high OTPT. Creatinine also goes up, then it comes down. Seizure disorder. 2 sisters had the same phenotype. One died at age 4 and the other 20 days after birth. And he is growth retarded. Dysmorphic features are there. You can see the height and weight are much lower than expected for the age. And here you can see, I'm not sure whether you can see it, you can see all the dysplastic phalanges, the platys spondyli, the flat vertebrae, and these are all the classical skeletal manifestation of Walcott-Rallison syndrome. And lo and behold, when we did the genetic mutation, we found the mutation in the EAF2AK3 gene. Parents are heterozygous for the mutation. Consanguinity, the disease manifested. And the prognosis is quite poor even with treatment. So how does it help the patient? Really, it doesn't help in treatment because you have to give insulin. Even then, it may not help in controlling. It definitely won't help the extra pancreatic manifestation. But you can tell the parents what to expect and you can also counsel them. For instance, these parents came and asked me, can I have another child? I said, considering your hit rate is 100%, it is always better to go in for an adoption next. Because 3 out of 3 have been affected. So that is a way in which family counseling can help these patients. We also have MODY5, which is a renal system diabetes syndrome due to HNF1 beta mutation. This is another form of MODY, which is monogenic diabetes characterized by extrapancreatic manifestations. So this is not an exhaustive list. You have the TRMA Rogers syndrome, Wolfram syndrome, mitochondrial forms of diabetes, ARCAT syndrome, all these are there. But again, these are more of academic importance because generally you won't find any difficulty in diagnosing these conditions. And this is our list of monogenic registry cases, 1,500 we have. Around 970 have the different forms of MODY, 300 have neonatal diabetes, syndromes are 74 in number. And we also have a few cases of congenital hypoglycemia. All these mutations can work in the other way also. So why should we test for monogenic diabetes? This is my last few slides. Naturally, it can differentiate from type 1 diabetes, avoid insulin unnecessary. Helps to define the prognosis, helps family counseling, can help in treatment decisions as well. So these are the people who can expected to benefit from genetic testing. If you have somebody with type 1 diabetes who just doesn't look right, family history is there. There are other members of the family, young diabetes on tablets, no ketosis, C-peptide maintained, GAD antibody negative, then they may be having MODY1 or MODY3, they can be switched out to sulfonylurea. Those with mild fasting hyperglycemia, which has been going on for years on end, they probably have MODY2, they can stop treatment. Then neonatal diabetes is a situation where testing is mandatory because yield rate is also high. You may be able to switch them over to sulfonylurea, you can change the life of that particular patient. And extrapancreatic features helps define the prognosis. This is our details about our registry. If anybody is interested, you can send the samples, how to send the samples and all here. These are all the collaborators. Chandri madam is also there. It's not moving, excuse me. It's not moving. Yes. This is our team, led by Dr. Radha Venkatesan. So before I close, I would like to invite you to our Dr. Mohan's International Diabetes Update, which is again being held virtually. This is the 9th session of that between 22nd and 24th of July. Registration is open. Please do attend if you have the time. We have the cream of national international faculty. And also later in the year, we have the 50th annual meeting of Rssdi in Chennai. We are proud to host Rssdi in Chennai between the 6th and 9th of October. Registration is open. Early bird registration is also available. And also we are trying to have a membership drive. Those in your circle who are not members of Rssdi need not necessarily be doctors, even educators, nurses, whoever is interested in diabetes can be encouraged to join the Rssdi. Thank you for your attention.
I agree that was a brilliant talk. Any questions from the floor?
I was planning to ask Mohan sir next week, but now that I have got you.
You can also ask him, no problem.
One thing is, sir, how can you suspect MODY during pregnancy? You told that there is some difference in management during pregnancy.
Yeah, that is mainly for MODY2. Of course, there is a difference in already treated MODY when they become pregnant. Whether to continue the sulfonylurea or not, there's a big controversy going on, and I don't go into that. MODY2, the ideal way of diagnosing, you have to do some invasive study, either an amniocentesis or CVS, but that you can't do in every patient. The clue will be that we know the mother has got MODY2. If the baby is growing too big, abdominal circumference and all these things, the OGs will be able to tell you. If the baby is growing too big, then you can assume that the baby is normal. It has not inherited the mutation. It is responding appropriately to the mother's increased glucose levels. Of course, you can give insulin, but we do not know how much it will work because the defect is not insulin deficiency, and anyway it will not cross the placenta. So what you need to do is you will have to consider early delivery, just like we do in the case of GDM.
Second question was that you mentioned in between that extrapancreatic features might come later.
Yes.
So I have one observation, probably it might not be true. The cases of chronic calcific pancreatitis,
yes.
Some of them have pre-diabetes and later they develop. I have clear-cut evidence that at that time patient's pancreas is normal, and later after 4 or 5 years, when somebody did a USG, they found a calcification. So do you think in your series there is something like
the
that?
FCPD is really not monogenic, although a lot of genes have been identified like the SPINK mutation and all. It's not really a monogenic, it's more of a polygenic form. Classical picture of FCPD is they get features of acute pancreatitis in childhood, exocrine insufficiency in adolescence, and they develop diabetes in adulthood. The problem is many a time it is difficult to visualize the pancreas. I mean, most people don't do abdominal X-ray. Stones may not be that visible. Ultrasound, we know how difficult it is to pick up subtle changes. So only when they are very florid, they pick up. Otherwise, what you need to do is you will have to do some test of exocrine pancreatic insufficiency like fecal elastase or chymotrypsin or other PABA test and things like that, which is not, but any young patient, lean patients, see we have learned about lean type 2 diabetes, all of them should get pancreatic imaging done. You may not be dealing with lean type 2 diabetes, you may be dealing with a pancreatic diabetes.
I have a family of 2 brothers who have a CCP with secondary diabetes.
It is known. In fact, I have another family, 2 brothers, and they look like Laurel and Hardy. The elder brother has got FCPD, the younger fellow has got type 2 diabetes. Interesting thing is that they are both Marwadis. The elder fellow was in Calicut for a short period of time during his childhood and adolescence. He studied in Presentation Convent. The younger fellow has never left Rajasthan. So all these things add on. This is polygenic, isn't it? So.
Thank you, sir.
Suresh sir.
I have a case of PNDM. He has been on sulfonylurea since probably 2 years now. 2007 he was diagnosed, 15 years now.
You said what is the diagnosis?
PNDM.
Neonatal diabetes, yes.
KCNG11 mutation. He was actually initially was diagnosed when he had diabetic ketoacidosis.
That's how they come, because they're insulin dependent.
Right. So that was treated. Now he is okay. Just a quarter tablet of like glibenclamide is responding. Sometimes he go into even hypoglycemia when he's been.
Yes.
That's there. But recently he's been found to have like growth retardation. And his growth hormone level is borderline. It is not too low, but borderline low. So in such cases, that's been an association actually in PNDM sometimes. Should we give growth hormone or wait, or probably what will happen to this case in future?
See, I think there is no harm in giving growth hormone if the other criteria for giving it are met.
Okay.
You can definitely do that. The classical extrapancreatic features of neonatal diabetes is what is known as DEND syndrome. It is a spectrum. DEND syndrome means developmental delay, epilepsy, and neonatal diabetes. The next less severe is what is known as intermediate DEND, where you also have seizures and diabetes. Then you have PNDM, TNDM, normals, and if the mutation goes to the other side, you get what is known as congenital hyperinsulinemic hypoglycemia. So it's a spectrum. We still don't know what are the full florid features of all these mutations. We are only now picking up. Even Hattersley series is only 10 years old. We have been doing it probably for the last 5 years.
And this monogenic diabetes actually is a very interesting topic.
Interesting topic. It may not be very common, but like Joe was saying, for that one patient it is 100%, isn't it? You may be able to reverse only in 1%, but that person is 100%.
We have, you know, that we from Calicut we have picked up the largest series.
So sir always says Suresh and Chandni ma'am are biggest collaborators.
Like we had the largest series of MIDD from India. It's never been reported. MIDD, maternally inherited deafness, largest series. Like 4 from my side, I think, madam, I don't know, one or 2, madam, I also.
I think a bit of consanguinity also adds.
Not that very uncommon actually.
Not that uncommon, yes.
The only thing is that we are not picking.
We used to see all these syndromes, madam, if you remember, we used to see all these syndromes in our clinical meeting, isn't it? Rarest of rare.
Sir, which all young patients should be monitored for monogenic diabetes?
See, I told you the 4 phenotypes. See, the point is that our main aim is to differentiate type 1 diabetes from these conditions. Type 2, even if you make a misdiagnosis, doesn't matter, because ultimately at the end of the day, what do we give? We give sulfonylurea. Type 1, who does not look like a type 1 in the sense that they don't need too much of insulin, they have a family history, other members in the family being under control with tablets, having young diabetes, then if you have the access to test, if they have detectable C-peptide at the end of 5 years, or if their autoantibodies are negative, these are the clues. Then any patient who is diagnosed with diabetes below the age of 6 months. These are the 2 conditions where I think you should definitely ask for a genetic testing, because that will help the patient. Otherwise, for academies you can do for every patient, but we don't have the money, so that is not possible. Thank you.
Any other questions? If there are no more questions, we should thank you for this brilliant talk.
Thank you, sir. Thank you so much.
Thank you for this educative session, sir. I request the chairperson to present Dr. Ranjit Unnikrishnan sir with a memento of our admiration. Thank you, sir. Now I request Dr. Abdul Jalil sir to present our chairman Dr. Ramdas sir and Dr. Mohandas sir with a memento. Thank you, sir. Inviting you all to be a member of Rssdi. Please visit the stall outside. You can have your membership right here.
Moving on with our next session, we have our next topic, diabetic food, a physician's perspective. For this, let me invite Dr. Abdul Jalil, MES Medical College, Perinthalmanna, and Dr. Muhammad Hassan, Aster MIMS Cortical, to chair the session.
We know that we talk a lot about the cardiovascular system and diabetes and kidney, but it's equally important that to talk about the diabetes and food. And we have Vijay Kumar sir here to talk about this. And I don't think we need an introduction for the topic, but just to talk about sir. Sir is a physician, diabetologist and researcher from Central Trivandrum. He did his MBBS from Trivandrum Medical College and MD from Kottayam Medical College. And sir has his fellowship in tropical medicine and hygiene. And he has taken his fellowship in from diabetes from Newcastle University. Sir was a president of AP of Kerala chapter during the year 2009 to 2011. Over to you, sir.
First of all, let me thank the organizers of this conference, Dr. Shaji, Dr. Chandani, and Dr. Suresh, for this opportunity to present a topic which I'm practicing for the last 20 years or so. My classmate, Dr. Parid, is also here, and my friend Chandani is here. Dr. Ramdas is here. I'm thankful to all of them. First question is it a big issue? Because we are talking in the morning, all the other sessions were there, cardiology, GDM and all. Is diabetes foot ulcer, is it a big issue? I think the prevalence of diabetes in Kerala, our latest study shows that it is around 27%. That is around 45 lakh diabetic patients. That means around 90 lakh feet. And about 25% of these diabetic patients develop foot ulcers in their lifetime. The lifetime risk of diabetes foot ulcer is around 25%. That is a staggering number. And 40 to 80% of them get infected, and once infected, they requires admission for a pretty long time. Unlike the cardiology, for one day or so, these patients require a prolonged admission, prolonged offloading, prolonged staying away from work. And 68 to 80% of them get healed, but some of them remain unhealed also. And so these are all statistics from Dr. Andrew Bolton. These are all real statistics from Western world, which is our country maybe a little more. But the important question I think I wanted to stress is that the remission rate is very high. Once the diabetic foot ulcer is cured, now the term is not cured, it is remission, just like cancer. The patient the foot ulcer has went into remission. It can recur at any time, meaning that it can recur at any time. So these are all statistics. Around 1 lakh legs are amputated every year. 85% of foot ulcers amputations are preceded by foot ulcers. And leg amputation in a diabetic patient can predispose to a lot of physical and psychological problems. And according to statistics, 60 to 80% of them may die within 5 years. These are all statistics from the Western world. We don't have much statistics from India. Cost of diabetic foot ulcer treatment, the average time for healing of a diabetic foot ulcer is 28 weeks. That means 7 months, maybe 12 to 62 weeks. Earlier, ആദ്യമൊക്കെ എന്നോട് ചോദിക്കുമ്പോൾ ഡോക്ടറെ 3 ആഴ്ചയായല്ലോ ഡയബറ്റീസ് അൾസർ കരിഞ്ഞില്ലല്ലോ എന്ന് ചോദിക്കുമ്പോൾ I was feeling helpless. But now I know that these are all statistics from the Western world. The average healing time of a diabetic foot ulcer is 28 weeks, that is 7 months. The cost of treatment, this is the costliest complication of diabetes. So the good news is that coming events cast their shadows before, and 70 to 80% of foot amputations are preventable if intervened at the right time. That is the good news. So who should manage diabetes? I am presenting this mainly for this, answering this topic, this question. Who should manage diabetes? I am a physician, and our hospital has 4 my daughters are physicians, and also my son-in-laws are physicians. All of our manage diabetic foot ulcer, we are all physicians. We have an on-call surgeon only. Coming to complications of diabetes, cardiovascular disease, nephropathy and retinopathy, they have their own specialists. But diabetic foot is an orphan. Maybe I have adopted this orphan 15 years back, and now he is looking after me and my family. So need for a diabetic foot care team, a multidisciplinary team is necessary to manage diabetes, because the etiopathogenesis of diabetic foot ulcer is varied. Neuropathy, peripheral occlusive arterial disease, immunopathy, uncontrolled sugar and food deformities. Some of them they may be present, or all of them may be present in the diabetic patient, and when an injury happens or the ulcer develops on its own. So the evolution of diabetic foot ulcer movement, Jocelyn was the first to start a diabetic foot clinic way back in 1928. He said that gangrene is not heaven sent, but it is earthborn. Even now it holds true. He stressed the importance of a multidisciplinary team led by a physician. That was how he conceived a diabetic foot clinic. Experts internationally, the father of diabetic foot movement, as I think it is Andrew Bolton, and David Armstrong is a surgeon. In India also, my guru, Dr. Aranbal, is a surgeon, but the others are mainly physicians. Sharath Pense, there is a beautiful book by Dr. Sharath Pense on diabetic foot. I think everybody should read that. It's a very beautiful book, and also some monographs from Dr. Bolton. So this is my daughter, Dr. Rssdi. She's a physician, receiving an award for the best paper from Dr. Andrew Bolton and Dr. Aranbal. She was lucky to receive from both of them gave to, not to show my daughter, but to show the stalwarts. The King's College Foot Care team is led by a diabetologist. All the other specialists are there, but the first name is of a diabetologist. And also the diabetic foot clinic by the International Working Group on Diabetic Foot. They have developed 3 models of diabetic clinic. The minimal model, where any doctor, any practicing doctor with a nurse who can do some podiatry training, with podiatry training, can make a minimal model diabetic foot clinic. The intermediate model, again, the physician or a diabetologist is the team leader. He should have the support of surgeons, orthotists, all the other things are there. Even for the center of excellence, they say that a physician or a surgeon with special interest in diabetes should be the team leader. They should have all the specialists. Interventional radiologists should be a part of it. All these things, people will be there, but the team leader should be a person interested in diabetic foot, need not be a surgeon. So that is my answer to how to approach a diabetic foot. Whenever a patient comes to my OPD, my clinic, for the first time, at the time of presentation, risk assessment is the most important. What are the risks present in that feet, for that patient's feet? The feet of a diabetic patient do not ulcerate spontaneously, occurs when a combination of several risk factors are present in that feet. So we know that neuropathy is the most common thing. Around 40 to 50% of diabetic patients will have neuropathy by the age of 10 years or so. Sensory neuropathy, because of decreased pain sensation, it can lead on to increased foot pressure. Motor neuropathy, there will be wasting of the small muscles, lead on to foot deformities, especially clawing of foot, again increased foot pressure. Autonomic neuropathy, because of decreased sweating, there may be dry skin, which again lead to development of callus. All these make the feet at risk, and on top of that, if there is a peripheral arterial disease, the patient feet will be at severe risk. So peripheral neuropathy, this is the classical neuropathic feet. Symptomatic neuropathy present in 40%. Allodynia, or the altered sensation, will be there. Nocturnal exacerbation is the classical feature. I am not going to details. How to detect is biodosimetry is the gold standard. you can have monofilament or tuning fork. But these things, when the patient comes to our diabetic clinic, we do these things at the first contact with the patient itself. That is the point which I wanted to drive. Again, peripheral vascular disease, this is the classification, I'm not going into details. It can be helped by a handheld Doppler at the bedside itself, at the first point of contact. Normal ABI, this is just comparing the BP between the angle and the brachial. Normal is between 0.9 to 1.15, below 0.8 means ischemia. If the patient has ischemia, definitely, and also this is a vascular Doppler recorder where you can even detect the toe pressure. It's not moving. And toe pressure can also be recorded. Normal toe pressure is above 50. If it is less than 25, there will be toe ischemia, even though there is no ischemia. If the patient has got, if the patient presenting to my OPD has got an AB index of less than 0.8, I will not ask the patient, I will send the patient for angioplasty, further angiogram and angioplasty. And structural deformities and callus. Next. It's not moving. Coming to classification, ulcers are classified neuropathic, neuroischemic, and ulcer in a dialysis. This is the latest classification from King's College, where ulcer in a dialysis patient has got very bad prognosis, because that comes as a separate entity, because we are seeing a lot of patients now. Even they have high finger ulcers also, because of some problems with the dialysis. I am not going into details of that. Some neuropathic ulcer, we have developed a cloud-based software where we can take the photos and store it, and at the click of a button with the number of the patient, we can have all the photos, all the previous photos at the click, and even we can take the laptop along during the rounds also, so that we can see the previous pictures also, because we will forget how it developed. How it presented to us for the first time or a long time, after some time. For the photo document, we have a photographer in our foot clinic team. So this is I will come to a few cases which we have managed during the years. Case one is a 70-year-old patient presented. This is the first is how they presented to our clinic, maybe from other hospitals. Peripheral neuropathy is there, but there is no ischemia. We usually admit the patient. We start on empirical antibiotic and send for culture. And once the culture comes, we'll change the antibiotic. That is the usual thing. The patient is usually admitted for 7 to 14 days, maybe up to the maximum of 20 days before discharging the patient. So at that time, the patient may be on IV antibiotics. We do the dressings daily, because majority or 90% of them will have anesthetic foot. So there is no anesthesia needed. We do the dressings daily and do the debridement while during the rounds itself, in the bedside itself, not in the theater. So this is how it healed. I think it healed within a span of 6 months. Took 6 months. After 2 weeks, we sent the patient home, asked them to do the dressing at home, but strict offloading. We have strict offloading by methods which I will be discussing later. So this is how it healed, but healing time was 6 months. Again, similar case, presented like this with toe ulcers, which developed because of not because of ischemia, but because of the proper antibiotic are not given at the right time. He had associated kidney disease also. The toes were amputated. Healing time again 5 months. This is another case, a 53-year-old with an HbA1c of 14.3 at the time of presentation, with a big ulcer with a gangrene of the second row, but there was no ischemia. Vacuum-assisted closure had to be applied for this patient, and it healed. It healed within a span of 6 months. It took 6 months for the healing. Next is the neuroischemic ulcers. Once these ulcers present to us, we send the patient. We have an arrangement with the Bharat Hospital where a cardiologist does the angioplasty for us. We have done around more than 300 angioplasties during the last 10 years. Send the patient for angioplasties. This is how. This is comparatively a toe ulcer, little toe ulcer only. But because of the ischemia, it carries very bad prognosis. So the patient was sent for angioplasty. The angioplasty was done. I had the videos, but this is how it healed. angioplasty was done, and by the patient came back, three toes were gangrenous. Because we don't have facility in our hospital, we had to send the patient to the cardiologist, and by the patient came back, we had to amputate all the 3 toes, but it healed. It's not moving. Yes. It healed within a span of, it took 11 months. Again, this is another case, 50-year-old female, again with an AB index of 0.7 only. The patient was sent for angioplasty. Angioplasty was done for the suprafemoral artery and popliteal artery, and posterolateral artery angioplasty was done. It's not moving. Yes. Again, toe had to be amputated, but it healed. It's not moving. I'm sorry for the problems. Case 7 is again with PVD, AB index was 0.5. With the 2 ulcers, angioplasty was done and it healed. Healing time around 8 months, but it healed completely. Again, toe ulcer. Toe ulcer, when a toe ulcer develops, the classical surgical treatment is re-amputation of the toe with the removal of the metatarsal also. But we had other, we did not, we went for the conservative approach. This is a toe ulcer. There was osteomyelitis with the destruction of the bone. We admitted the patient, gave IV antibiotics, complete strict offloading, and it healed completely within 1 month. This is another case where we had to suture. If the osteomyelitis is there, we did not amputate the toe, it healed. Again, another case of osteomyelitis. We could save the toe. Because of lack of time, I am rushing through the slides. But it's not moving. This is again toe ulcers, which healed within some time. Again, a big toe ulcer with osteomyelitis. It healed without any amputation. So amputation as far as possible should be. Heel ulcer is another big issue. In one of the slides, Dr. Edinburgh's one slide is heel never heals. That was one of his slides. Heel is very difficult to heal at least. This is another. Again, this patient had angioplasty also 2 or 3 times, which failed. This is how she presented to us. We strict offloading with the proper antibiotics. Again, the patient, once the patient sent home, came back in a reinfected state. Again, we had to admit her, and this is how it progressed, and it healed in a span of 11 months. But we could heal this type of big ulcers also. That is the message. Again, another heel ulcer. Healing time, it took a long time, about a year. Another case where this was slough was there. We had to apply the vacuum assisted closure was applied, and the antibiotic were given. Again, this healed. Pluramin is another thing which we use, Pluramin for growth. I'm not lack of time because I'm not going into details of treatment of any of this. Again, it healed within a span of 9 months. These are all heel ulcers. Even big ulcers, which usually we think that skin grafting is needed, we could they manage, because the repairing capacity of human body is amazing. Because that is why that has my experience has taught me that the repairing capacity, once you aid in what you do with the glycemic control and offloading, the repairing capacity of the body is enormous. This is a big ulcer. He had left leg amputation in 2016 and presented with necrotizing fasciitis. In this picture, he presented to us with gangrene. We had to remove the entire slough area. This is how later on. And this was done. The tibia was exposed, and the tibia, we had to, bone nibbling was done for the tibia for the growth of the bone marrow, and this was the picture last week. It healed completely. So this is another big chronic ulcer. Healing time around 10 months. This is another ulcer. These are all ulcers which healed without graft, because grafting is likely to fail. I don't know much about that, but our experience is that many of the grafted skin usually, because the ulcer grafted skin, secondary healing will be better than a graft, if it is possible. Again, these are all similar cases which healed. Big ulcers. This is a big ulcer. Again, this usually look like the grafting is a must, but it healed. Healing time around 5 months. VAC therapy, I'm not going into details of that. This is how the VAC is applied. Like this, the patient has, usually we apply the VAC for 5 days, and after that, this will look much healthier. So, and aquacell dressing was maybe done 3 weeks, and it healed within 6 weeks. And this is another case. Again, healing time around 8 months. Debridement is one of the most important things. Daily debridement, whether it can be a surgical debridement or a daily debridement, for this patient also we tried a conservative approach, because otherwise the patient had to have a below-knee amputation. Midfoot could not save the feet, so we tried to avoid that, and we succeeded with the 7 months of treatment. Again, these are all ulcers which healed with conservative therapy. Again, this is another case which presentation was like this. We tried to, because these were our learning for us. We asked, the patient was told that amputation may be required, but with their consent, we tried with the conservative line. Slough was removed, because and it healed, completely healed. There was deformity of the feet, but we could adjust with a proper footwear. A conservative approach for these ulcers. I think I have few more slides, so I am rushing through. Healing with cellulotome is another thing. Skin grafting can be done with the help of this cellulotome, which takes only the superficial. And the final case is of an 85-year-old female patient presented like this, suggested AK amputation, BK amputation or AK amputation in several hospitals, but she was adamant she will not go for that. Otherwise it healed, and she was very positive that when I told her I will be presenting this case, she wanted to show her face also. So that is her face. The treatment principles of foot ulceration: debridement, pressure offloading, treatment of infection, and providing corrective footwear. These are the 4 pillars on which a successful diabetic foot ulcer treatment stands. So, debridement, surgical versus serial debridement. Do you go for a serial debridement? I have heard 1 or 2 talks from surgeons from America, from US, where they are compared the surgical debridement versus serial debridement. Both are equally effective. Serial debridement means that daily when you go for the rounds, because there is lack of pain, you can do the debridement in the bedside itself. That is how we do it. For extensive wound only, we call the surgeon for a surgical debridement. Otherwise, we do the debridement daily. My experience is that thereby we could prevent a lot of tissue loss. For a neuroischemic ulcer, we won't touch the patient unless it is revascularized. Otherwise, we will be in soup. For pressure offloading is the key of diabetic foot ulcer management. Diabetic foot ulcer is a mechanical problem, and no amount of antibiotics or dressings will heal the ulcer unless the pressure is reduced. So that is the most important thing. Till the ulcer heals, diabetic foot ulcer patient should not touch his feet on the ground. So that is a very challenging issue, and you have to educate the patient while the patient is in the hospital about all aspects of diabetic foot care, and that is the only time when the patient is all ears. He will listen to you only at that time. So bed rest with heel protection should be there when the patient is in the hospital. Special custom-made footwear can be given, but the gold standard is a total contact cast, which we use a lot. This is how a total contact is applied for an ulcer on the central part. So the patient cannot remove. If it is a removable cast, he will remove and walk with it. But this cast is very important. Only thing is that you have to do it carefully. Total contact cast again for the healing. For this ulcer also, we assess the patient once the patient is here. Once you discharge we will have a mental assessment of the psychology of that patient. If we feel that he will walk with it, we will put the plaster. Otherwise, we will give choice for using a walker or so. So that has to be there. Offloading is the most important aspect. Again, these are all. This is another prosol dressing for offloading. Mandagani, this is another thing for offloading. Treatment of infection, usually the multiple organisms will be there. So treatment depends on the type of hospitals. For a tertiary care center, multiple organisms, multiple antibiotics have to be used in the beginning, and culture is taken on the first day. And depending on the culture sensitivity, we change the antibiotics. Dressings. Depending on the stage, we have different types of dressings: hydrogels, enzyme dressing, VAC can be used, Plurmin for help to growth factors may be there, and the most important aspect is the prevention. That physicians or the doctor's role in prevention of diabetic, prevention is the most important thing, because recurrence is the rule in a diabetic foot ulcer. So you have to prevent foot ulcer. So risk assess stratification is important. Previous ulcer or amputation is at the highest risk. Once in 3 months, the feet has to be examined in detail. Otherwise, and also peripheral neuropathy, PVD, again, once in 3 months, the feet has to be examined in. This is the education hall in our hospital where they are educated. Before discharge, the patient should be educated, and again, about footwear also. This is the footwear. These are the characteristics of a footwear. Therapeutic footwear or a preventive footwear. So this is a podiatry. We have 4 podiatrists in our hospital. They do the nail trimming also. We can teach the nurses to do the nail trimming and all. So to summarize, the etiopathogenesis of diabetic foot ulcer is complex. Need a multidisciplinary approach. A team leader can be a physician or a diabetologist with a special interest in diabetic foot. Surgeon, vascular surgeon, podiatrist, interventional radiologist, their services are required. Identification of at-risk foot is the most important thing. Prevention of foot ulcer and proper care at the right time, and aftercare of foot deformity is very important. This is our team in our hospital. Thank you. This is how all the religions have advised foot care. Hindu, Muslim, or Christian, all the community have advised importance of foot care. Even now, I think the Muslim community is still practicing it daily, 3 or 4 times there, 5 times they are cleaning the feet. That is the message. You have to look at the feet of the patient. The patient has to see his feet, whether there is any ulcer or not, and the patient has to report to the hospital. You have to educate the patient regarding that proper timing of coming to the hospital also. And prevention of foot wear is the most important thing which a physician can do to the patient. Thank you for a patient hearing. Thank you very much.
Sir, thank you, sir, for very informative talk. Actually, diabetic foot ulcer is a neglected part in the diabetic management, and also very less dedicated centers are there in foot care, very less. And people are not interested to look after because of the monetary problems, and also the surgeons are not so interested. The results are not so excellent, but it is time consuming. So we need a more focus on this area, and patients are advised for self-examination of their foot very frequently. That's also very important, sir. Audience, please. For
dressings. Actually, the teaching is that hydrogen peroxide should not be used because that can injure the skin. Even for betadine also 2%, 5% betadine should not be used, 2% betadine solution. And for ointments also, the costly antibiotics are not at all needed. The cheapest antibiotic will be the best. I usually use metronidazole ointment for dressing, for the usual dressing. Then definitely for, as I don't get the time for discussion, depending on the type of ulcers, if there is any hard ulcers, you can have enzymatic papain will be there for dressing, you can use that. when there is no infection and when you want growth of granulation tissue, you can use bicoplermin, which definitely helps. Rajit.
Sir, regarding your question, its guidelines are not permitting use of betadine or hydrogen peroxide for wound dressing because it will delay the granulation process. I think the better thing you can use is a normal saline. And about the antibiotics, most of the time it will be polymicrobial. And one antibiotic you should give is focusing at the coverage of the gram-positive. Preferably, if the patient can take it orally, the preferred antibiotics will be a clindamycin orally. But problem is gastric irritation. Or if it is possible, you can give it IV. This is a clindamycin is the antibiotic which has got a better gram-positive and an anaerobic coverage with a better oral bioavailability. Along with that, based on if you have a local center culture reports of organisms, you can treat, and there is no need for treating all sorts of pseudomonas in a diabetic food if you get a culture report, because if you are not taken the sample properly, most of the time it will be surface colonization. No need for.
I did not go into the latest advances, hyperbaric oxygen therapy with Dr. Ajit is concentrating, and they are all recent advances, which I don't have much experience. Again.
If there is no more question, we will wind up the session. Thank you for the wonderful presentation.
Thank you.
Sir.
Thank you.
Thank you, sir, for this didactic session. I now welcome the chairpersons to present the memento to Dr. G. Vijay Kumar for this enlightening session. Thank you, sir. I request Dr. Sujit S. Nair to present the memento to Dr. Abdul Jalil and Dr. Muhammad Hassan. Thank you, sir. Now, we have a session to throw us some light on the topic, management of intractable diabetic neuropathy. For chairing the session, let me invite Dr. Ahmad Azhar, CVR Hospital Mannarkad, and Dr. Deepthi Sunil, Ramdas Hospital Perinthalmanna, to the dais. Welcome, sir and ma'am.
The next topic for the day is management of intractable diabetic neuropathy by Dr. Ajit Kumar sir from Trivandrum. Sir is a Chief Consultant, Department of Hyperbaric Medicine and Diabetic Foot Care, SP Fort Hospital Trivandrum, and Director of Dr. Ajit's Total Diabetes Care Center Trivandrum, Chairman and CEO of Kairali Diabetic Research and Care Forum, Senate Member of Kerala Health University from 2015 to 2021, and has also received the Best Scientific Paper Award in API Kerala 2016 and Rssdi Kerala 2015. He has also got the State of Art Diabetic Foot Clinic Award from the National Conclave on Diabetes and Diabetic Foot in Mumbai 2017. And his areas of interest include use of hyperbaric oxygen therapy in clinical medicine, diabetic foot infections, and research in the area of high-risk foot assessment and its prevention. He's got a number of publications in national and international journals. Welcome, sir, and over to sir.
Thank you, Chairperson. I think I don't waste too much of time because I know all of you are waiting for the lunch. I think first of all, I would like to thank the organizers of Rssdi for inviting me for this topic. I think my job has been made easy already by Sir Vijay Kumar sir because he had covered the diabetic foot area. And basically, I will be discussing about the intractable diabetic neuropathy, and the menu for the day will be following the introduction, the risk factors for DPN, and the pathophysiology. I think the slide is not coming in this. Okay, now it is coming. Thank you. So this is the definition which is given by the father of diabetic neuropathy, or you can say the diabetic foot, that is the presence of symptoms and the signs of peripheral nerve dysfunction in people with the diabetes after the exclusion of all the other causes. That is very important. We will discuss the common causes in the upcoming slides. So DPN is among the most distressing and costly of all the complications because a diabetic patient is experiencing. Peripheral neuropathy, when it occurs, it has got three components. It will be motor neuropathy, it's a combination of sensory neuropathy and an autonomic neuropathy. Each patient, it is different. The intensity of the subclasses of neuropathy is different in each patient, but a combo of these three will make the patient have a big problem. So I'll be restricting my talk to the painful diabetic neuropathy. The PDN occurs approximately in 30% of patients with diabetes. As many as 12% of patients with PDN, they do not report any symptoms. That is the most important aspect. And 39% of diabetes with the DPN do not receive any treatment. And it says that neuropathy is more commonly associated with the type 2 diabetes than type 1 diabetes, because there are, even the guideline says that you have to evaluate for neuropathy in a type 1 diabetes patients only after 5 years of duration. If it is a type 2 diabetes patient, the day one itself, you have to rule out a neuropathy. This is the way the India is so prevalent that or the common people, Indian people are affected with the diabetic peripheral neuropathy because of the poor food hygiene, and people are barefoot workers, and this is the statistics which is from India itself. The close center of ours is the Vijay Viswanathan Clinic and the Ramachandran et al., because all these are from Chennai and the nearby places. The average, it says it is somewhere around 14 to 30%. But these studies, few studies, Chennai study says it is 16%, but I think one study has gone up to 64%. But the international recommendation says it is 17 to 30%. So this is a notion about DPN. There are a lot of myths and facts about diabetic nephropathy exist. The people thinks that it is neuropathy is a natural result of aging. No, it is basically it's at the glycemic level which plays a major role in the origin of neuropathy in diabetic patients. And DPN only affects people with the high blood sugar. That's also not that correct. It is the most important thing is the duration of diabetes is the principal factor which decides whether the individual will have a neuropathy or not. These are the risk factors for the development of DPN. The modifiable risk factors, as I said, the duration of diabetes, the glycemic control, the coexistent dyslipidemia, the hypertension, and habits like smoking and excessive alcohol intake. That's the most important aspect in our population. Non-modifiable is the age and the duration of diabetes. And coexistence of, the current scenario, it is the coexistence of diabetic kidney diseases. This is a Eurotype study. This beautifully demonstrated the risk factors for incidence of polyneuropathy. Here you can see the factors which is leading the chart is hypertension, and followed by the smoking and the level of HbA1c. This is the mechanism of diabetic neuropathy, because I don't waste much time for this slide, because we all know the advanced glycation end products and the oxidative stress produced by the free radical injury in a diabetic patients, which will produce a damage of the the vascular endothelium and all other structures, and the lipid peroxidation, oxidation will be promoted, and these things will lead on to the mitochondrial injury and the cellular injury that ultimately results in a microvascular damage. This is the genetics, and the amount of the glycation end products also plays a major role, especially the oxidative and the nitrate stress, which results in the neuronal damage and leads to a chronic stage. This takes months to years time. This slide, please pay attention, because we know that painful diabetic neuropathy, it says that because of, you can see from the left side and the right side, because the pointer is not working. So the left side you can see the vasa nervosum is working and the nerve fiber is getting adequate blood supply. Look at the right side and you can see there is an occluded vasa nervosum, and that will result in a hypoxia. Nowadays the newer literature says that the hypoxia also plays a major role in the formation of the diabetic peripheral neuropathy. So these are the clinical impact of neuropathy, as Sir earlier said, because the painful neuropathic symptoms is very important, because the combination of the motor, sensory and the autonomic neuropathy makes a patient more vulnerable for disease, especially like a diabetic foot disease, the Charcot disease, and there is an entity called the cardiac autonomic neuropathy also is there. That part is most of the time it is what you call not attended by physicians. So the quality of life is the most important thing. The patient won't sleep properly, and they will have a lot of risk for the fractures, history of fall will be there because of the autonomic neuropathy, and this will increase the mortality and the cost of the treatment. So these are the neuropathic pain nature. Usually it says that it can affect the large fibers and the small fibers, but small fibers basically there will be a pain amplification and hyperalgesia will be there. Autonomic symptoms will be predominant. Large fibers usually in relation with the motor and the sensory changes. In that group of individuals, there will be a lot of motor deficits, especially like the wasting of the muscles, and there will be claw toes, kind of structural deformities will be there. So these are positive and negative sensory symptoms. The positive symptoms is due to excess activity of the neurons, and the negative is due to deficient of functions. The positive function, most important thing is the allodynia and hyperalgesia, because even when they put the bedsheet, patient will say, I am having a lot of irritation or the pain when it touches my skin. Negative symptoms are anesthesia and analgesia, and sensory abnormalities and the pain paradoxically can coexist. This is the burden of the painless. In one way, when we debride, we think that okay, the neuropathy is good because it is a blessing, but for patient, they won't sense even if the foreign body injury occurs. These are the problems of sensory nerve damage. This is a motor nerve damage, which makes the more pressure points on the foot, and the patient walks on that pressure points, there will be a high chance of development of the ulcers, especially under the callus. So simple thing you can do is, whenever a patient comes, you just tell him to just do the dorsiflexus big toe. So the limited joint movement makes the patient, he is more prone for what you call the injury and the advanced neuropathy stage. There is no need for any high funda instruments for doing that. This is a localized callus. You and me, every day we see the patient. Autonomic nervous, and these cracks and fissures will be, especially in the calcaneal region or the heel pad region, will be ending up in a very disaster outcome. So we have to these are the differential diagnosis. We have to rule out the claudication pain, especially in smokers, the osteoarthritis, maybe in radiculopathy. In the current scenario, the inflammatory demyelination, Charcot neuropathy, you should not miss, and fibromyalgia. These are the close differential diagnosis. This is a staging. The N1 is asymptomatic, only signs of neuropathy is there. N2 is symptomatic neuropathy, and N3 is a disabling polyneuropathy. And there is a guideline which is given in the ADA statement when you have to evaluate. The laboratory investigation, the glycemic status, most important thing is A1C. You have to rule out the anemia, especially B12 deficiency. If you can rule out, that will be good. Lipid profile, look for RFT and LFT. Electrophysiology, costly, but you can do. If you do NCV, it will be distal polysymmetric neuropathy. That will be the result you are getting. Rheumatological evaluation, because nowadays the SLE and the RI is increasing our population, so you have to rule out, especially an MCTD also, mixed connective tissue. Iron studies is very important, and you have to look for the HIV status also. So this is a recommendation for the neuropathy screening by the ADA. All patients should be assessed for diabetic peripheral neuropathy, starting at the diagnosis in case of type 2 diabetes patients. If it is a type 1, you have to do it after 5 years only. And symptoms and signs of autonomic neuropathy should be assessed in patients with a microvascular complication. My sincere request, whenever you see a diabetic patient, even if it's the day one, you have to do one investigation, that is urine microalbumin. If you do, you can know that whether the individual is already having established microvascular damage or not. This is a recommendation by the treatment that we will see in the subsequent slides. This is a screening, simple monofilament 10 gram test. You can use the touch. This is, at least if you are busy, you must see these 3 sites with any patient. Ideally, you have to look for 3 sites. If these 3 sites, 6 sites, if these 3 sites you can see, that is more than enough. And 128 hertz tuning fork, this will be for the vibration perception test, and you can have a palpation of the peripheral artery pulsations. These are simple things. And monofilament and biothersiometer is a cheap instrument, it is available, and anything more than 25 you can label it as a neuropathy. This is a mat test which is available in most of the diabetic clinic. You can make the patient walk, and you can see the pressure points which is as depicted there. The darker areas, more darker areas which there is a high pressure points is there. So this is the gold standard investigation advised by all the guidelines, because you have to, if you want to detect whether it is a small fiber involvement, you have to go for a biopsy with an electrophysiological study, but it is limited to only the higher centers. So treatment for neuropathic pain, it has got limited effects, but even if we can give a 30% of pain reduction, that is the most important, 30 to 50%, because we can't completely cure neuropathy. So at least you should tell the patient if they are pain free in 3 or 4 days in a week, that is more than enough. So these are the barriers. Basically, there are patient-related barriers there, healthcare provided, because we are more worried about the side effects of drug which is used in the neuropathy. So non-pharmacological options are there, a lot of things are there, the relaxation therapy, the yoga therapy, the acupuncture, all things are there, the transcutaneous nerve stimulation, but there is no valid RCTs are available. So glycemic control is the only way of disease modifying treatment. This is effective as a primary and a secondary prevention. The UKPDS study has demonstrated that the tight control with a conventional control of HbA1c will give a better result, better relief of symptoms. This is a disease tried the reduction in neuropathy with intensive glycemic control by either by the insulin or by the OHs available, and the insulin pump patients, they have a very good result in managing the neuropathy. These are the drugs which is available that we will see in the detail. Pregabalin, that is one we usually use. I won't go into the details of the actions of the drugs because the time doesn't permit. This is an anti-epileptic drug. You'll see how it acts, it reduces the calcium dependent release of the nociceptive neurotransmitters in the spinal cord. This study shows the efficacy of the diabetic effect of pregabalin, and the dose should be 50 to 100 milligram, that is at least 3 times a day. But this dose is very difficult to achieve because usually we limit it to 75 milligram sustained release preparation in our clinical practice because of the side effects. This is a comparison study between pregabalin and amitriptyline in painful diabetic neuropathy and assessed by the VAS score, and it has shown that the pregabalin has shown better improvement than the amitriptyline in giving pain relief, and the side effects was less associated with the pregabalin. To conclude, pregabalin SR has the advantage of fewer adverse effects and convenient dosage timing if we compare with amitriptyline. So whenever we go for old generation TCS, in old age patients we have to be really careful because it can produce a little bit of cardiac problems and QT prolongation kind of things. These are the anticonvulsants which is used for a neuropathic pain. In our day-to-day practice we use gabapentin, but the target dose, it says that 1800 to 3600 milligram is the highest recommended dose, but I know most of we are using 300 milligram BD or TDS. Valproate, I don't have any experience by using valproate. Gabapentin is again an effective drug depicted by this slide because it reduces the pain intensity over a period of 8 weeks. This is antidepressants, the duloxetine. That's one FDA approved drug. There is venlafaxine is also there, but venlafaxine is not approved by FDA. It's again, you start with a lower dose and you titrate up to the maximum dose of 120 milligram per day. This is a selective serotonin and norepinephrine reuptake inhibitor. Start at 30 to 60, then go up to the maximum dose. This study shows that the duloxetine improves 24-hour average pain severity in diabetic patient with severe peripheral neuropathy. These are the adverse effects of TCA, so you have to be very careful whenever you use amitriptyline or nortriptyline aged patients, especially more than 65 years of age. This is SNRI. This study says that there is no improvement in increasing the dose of duloxetine above 120. There is not much peripheral improvement in peripheral neuropathy. So you have to start with 30, and if you can reach the maximum dose of 120, that is more than enough. So this is an analgesic effect of comparison between duloxetine and nortriptyline. This was a 5-week study. And it has again shown that there was a significant visual analog score reduction in pain from the baseline to the study completion period if comparing with the nortriptyline. These are the opioids for neuropathic pain. Tramadol, that is what we usually use. I don't have too much of experience with oxycodone or morphine. I won't give. Tramadol is a good drug and it is good in preventing the painful or non-painful neuropathy, but the effective dose should be 210 milligram, and again we are using 50 or 100 milligrams, so this is very important. This is already, we tell vitamin D or PRP is one thing for all the diseases you have, but this study says that vitamin D is efficient in useful in painful diabetic neuropathy, but the study they did it with a single IM dose of 6 lakhs unit of vitamin D administered, and they had assessed the neuropathic parameters. It is a good study, it is an accepted study. Then it says that a single dose of 1,000 unit of vitamin D in patients with painful diabetic neuropathy is associated with a significant decrease in symptoms of painful diabetic neuropathy. So you can give vitamin D, even we usually give 60,000 unit weekly for 6 to 8 weeks. So betel, it is always a question, but this study says that betel is effective than nortriptyline. There are papers which is not supporting this also, but this paper says the betel is efficient in giving pain relief in patients in comparison with the nortriptyline. These are the studies comparison. The p-value is very good in relieving the pain, tingling and paresthesia. And to conclude, the betel was more effective than nortriptyline. This is the capsaicin. These are the local application. This is okay. if you can give, there is 8% patch is available, and it has been seen that it is very effective in painful diabetic neuropathy as per this study. I am not going into the details. This is again a very myth we have, that nutraceuticals. We have a lot of things starting from the alpha lipoic acid, coenzyme Q, vitamin L-carnitine, a lot of things we are trying. But you just check the alpha lipoic acid, what we are using it as a combination with any capsule is 100 milligram or maximum 200 milligram. But the recommendation says if you want to achieve a good reduction with alpha lipoic acid, you have to give 600 milligram. So that is not possible because it is a costly molecule. Because if you check in the drug sheet, I think most of the time patient may be paying 20 rupees or 25 rupees for a multivitamin capsule. So this is a study which has shown that L-carnitine is a little bit effective in treating the diabetic peripheral neuropathy. Sorry for I am increasing the speed because 2 more minutes is left. So these are focal peripheral neuropathy pain. As I said, the lignocaine plasters are nowadays available, and you can use the TENS, the transcutaneous electrical neural stimulation, physiotherapy centers will have. And you can use the 8%. Botulinum toxin is also coming into the market. They are using, but they are in the phase 2, phase trial studies. These are the emerging treatments that we will see in the subsequent slides. This is a topical GTN and topical clonidine. GTN patch is useful. It's an off-label treatment. Topical clonidine gel also can be used. I don't have any experience by using. This is the latest paper which has come in the field of pain management of diabetic peripheral neuropathy. So botulinum toxin, I think in subsequent years, it will be, in coming years, it will be one of the leading product which will be available, and it says that it can be administered every 3 months subcutaneously at also 50 to 300 milligram into the painful areas, which reduces the neuropathic pain intensity. These are the molecules which is waiting for approval. With a novel pharmacological treatment, when I was going through the literature, I have seen few antagonists. That one is sodium channel antagonist, the Vixotrigen. There is the NAV 1.7 antagonist. This is still in the phase 2 trial. Next one was the innate repair receptor ligand, that is sibinetidine. It is again phase 2 study, 4 milligram sibinetide administered subcutaneously, and it has also shown that it shows a little bit of improvement in HbA1c and lipid levels. I don't know what is the mechanism behind that. We are waiting for the complete report of this paper. There is again a TRP agonist also there. So these are the, I will take 1 more minute. I think pregabalin, which is a pregabalin and duloxetine is the first line drug recommended by most of the agencies, whether it is ADA, whether it is what you call the NICE guidelines or whatever it is. So this is the American College of Academic Neurology. If clinically appropriate, pregabalin should be offered in the treatment of PDN. These are evidence-based guidelines. These are the drugs level A and level B. Level A is available for pregabalin. Level B is for gabapentin and other duloxetine and other drugs we are using. There is no recommendation for lamotrigine or clonidine, mexiletine kind of group of drugs. People starts with the case, I ends with case. If anybody can answer, especially postgraduate students, I will be really happy. She came to me some 3 years back. 68-year-old lady, 8 years of diabetes, still selling for left foot for 2 months. She was treated in Bangalore. She had a visit to Goa. 1 episode of fever, treated as cellulitis. And this is the temperature. This is before the COVID era, because this non-thermometer was not available. One of my patients' son only gifted me from when he came from US. There is a temperature difference between of 3 degrees Celsius. Because most of the time we treat it as a cellulitis, we keep on giving antibiotics, but if you don't detect this condition, they will end up in 40 to 50% will end up in amputation. Yeah, this is Charcot arthropathy. So you should not miss Charcot arthropathy. Just nowadays thermometer is available, non-touch. You can just check the temperature. If it is more than 2 degrees Celsius, you can make a diagnosis of Charcot. Once again, this is summarized. I am not going into the details. Most important thing is it is manageable, but it is not completely treatable. So glycemic control and the selection of the drug based on your experience, based on the patient's age and other coexisting factors, you can select. The treatment with the DPN involves the TCAs or the anticonvulsant or SNRIs, anything. But the leading evidences are available for pregabalin, gabapentin, and duloxetine. And pregabalin is preferred over all other things. Mycophenolate also is more effective. So once again, thanks. And from this stage, making a person to a smiling face is the most important whenever we treat any patient who comes to us with a painful condition. Thanks all. Thank you. Jai Hind. Any questions, I will be happy to answer.
Thank you, sir. It's a very wonderful session. What about the negative symptoms of this peripheral neuropathy? How does this negative symptoms with medications, is there any role of medications for the negative symptoms of peripheral neuropathy?
So we have to give importance for the negative or the positive symptoms, but most of the time the negative symptoms patient won't address. That is the thing. But when we take a history, usually what I ask is whether they have a paresthesia or numbness, because whenever they describe their complaints in the local language, it is very difficult to transform it to our English words, what they are meaning. So if you treat neuropathy, the negative symptoms also carries most important, and that will, I don't know how we will record it, whether they are improving or not, because most of the time they won't address it, but it is very important to.
But if the patient have the symptomatic peripheral neuropathy with negative symptoms, is there a result in giving this gabapentin, pregabalin, duloxetine and everything?
Yes, it is there. There will be improvement in positive and negative symptoms, but the improvement, as I said, you will get it improvement in a maximum in 50 to 60% of patients. So that's what I usually tell the patient, even if you are pain-free or symptom-free for 4 to 5 days in a week, or even few hours in a day is very important, because it is not a completely curable thing. And usually what I ask is, whenever the patient comes, I used to ask whether you have a complaint of slipping of chapels. If they are putting the Hawaii chapel, you can ask. If they have a slipping of chapels, that means their grip is not there. So most of the time they won't, slipping of chapels is most important thing for a, what you call a sharp object injury. So you have to give treatment, you will get improvement in whether it is negative or positive symptoms.
Any questions from the audience? Then we can wind up the session.
Actually, I don't have any experience in giving IM injection, because I was searching in the literature. This was the one study which was supporting. I usually give 60,000 international units weekly for 6 to 8 weeks. That's what I usually do, but I don't have any experience in using the IM preparation. This study which I was quoting from US, they are tried at the one single dose of vitamin D injection, IM injection. Yes, sir.
Measure the vitamin D after 6 months or so. In case if it is still found to be low, then you can repeat the dosage. That's what. One stat injection is there I think it's very commonly used in vitamin D
Usually, I usually commonly give vitamin D, because I don't check, because it comes around 1,500 rupees. So I don't measure. So I usually give, because it doesn't produce too much of side effects. That's
instead of giving one 60,000 units every week for 2 months, and then like that, you can just give one injection of 6 lakhs and then forget. That's what.
But I don't know whether it is available here or not. I'm not sure.
It's a Arachidol injection is there. Injection Arachidol 6 lakhs is a very commonly used injection. That can be.
Pardon?
Yeah, neuropathy.
Yes, neuropathy it is really effective. That's what. It's really effective as per the studies.
Yeah, it improves.
You can use, no problem.
There are studies that supports vitamin D supplementation improves neuropathy symptoms. Yeah, it's there.
Once we start using pregabalin, the patient starts giving response, you say around 50 to 60% of improvement will be there symptomatically. After a prolonged use of duration of use of pregabalin, patient will start complaining that their symptom is it's not responding these days. So how to go ahead with that? Should we increase the dose, or should we try some new molecule, or how to, once they start?
I think whenever you are giving pregabalin, you start with a lower dose, that means 75 milligram. Always go for a sustained release preparation and select a best brand. There is a lot of difference between the best brand which is available in the market and the cheap brands. So that affects the the symptoms really. I tried in few patients with the 2 different brands. There is a lot of, I don't name the brand, but there is a lot of difference. And the good brand is very costly also. And you serially titrate the dose. And you first dose, you tell them to take it somewhere around 5 o'clock or 6 o'clock in the evening. So because even if they get a giddiness or something, they goes to sleep, by that time the drug will start act and they'll be okay by when they get up in the next morning. And you have to titrate. I don't promote that. I have searched in literature, but they are saying how long, it's a very difficult question to answer. But my suggestion will be, till the patient gets pain symptom relief, you can continue. Even after that also you can continue if the patient can tolerate the drug. Nephropathy you can give. I think giving pregabalin won't be a problem, but the only problem is this giddiness. Maybe due to a lot of other, if those who are on dialysis, they may have some fluid imbalance issues. In that kind of patients, pregabalin may produce some issues, but in that group, I usually switch over to gabapentin, that's good. Duloxetine also is good. It won't produce too much of sedation.
Just one question, sir, on you mentioned about vitamin D. My question is on vitamin B12. Again, this is something which I have looked at in many patients, but I have hardly seen a patient who is vitamin B12 deficient in our population. So the literature cites that it's around 30% patients with diabetes are having deficiency in vitamin B12, but most of the patients which we see that the vitamin B12 levels are above the normal range. So maybe because the patients are on multivitamins or they are taking a non-vegetarian food, or maybe the geography is like that. My father is a vegetarian, pure vegetarian for the last 40 or 50 years, but I checked his vitamin B12 also, still it is above normal.
So in my experience, what I have seen is vegetarian, where my hospital is situated in and around, a lot of people are vegetarians. So there I used to get a lot of B12 deficient patients. Because we eat a lot of non-veg.
People, not patients. We found that only 4 patients had vitamin B12 deficiency, but folic acid deficiency is very high. Around more than 120 patients had folic acid deficiency in Kerala. But it is different in North India, where B12 deficiency is very high. But folic acid deficiency is low. Because that is the diet. That is the diet.
Okay, Prashant, one thing you have to be careful is those who are taking regular alcohol. Regular alcohol diabetics, I think if you can give a little bit of good dose of B12, I think they will be symptom free.
Now, another point is what Prashant was telling. Most of our patients are taking metformin for quite long period of time. We all know even metformin can produce some amount of vitamin B12 deficiency. But the real thing is most of the patients, when they go to doctors, they do prescribe these multivitamins, particularly vitamin B12. That is why most of our patients are not having that problem.
Polypill.
So what about the combination of drugs like pregabalin plus amitriptyline like that?
So there is a lot of combination which is available in market, but my experience with what you call combination is very less. I don't use combinations because there is nowadays I am started using a duloxetine plus a nortriptyline. I don't have too much of experience with amitriptyline. I am a little worried about using amitriptyline because of the side effects, and most of my patients are above 65. I am comfortable with either pregabalin, gabapentin or duloxetine. So, but there is a new molecule which is there, duloxetine plus nortriptyline. It is good, but only problem is sedation.
Pregabalin with nortriptyline is there.
Yeah.
Any two drugs with complementary mode of action can be combined. Maybe they can reap the benefit of both, and that is there. And regarding B12 deficiency, actually in pure vegetarians, it is very common. It's not very uncommon. Usually they present with the positive symptoms. They were talking about positive and negative symptoms. They usually comes with some severe burning sensation and positive symptoms. So they respond with B12 supplementation, replacement. And even in patients with B12, normal B12 levels, especially the lower ranges of normal, high doses of methylcobalamin is found to be beneficial in controlling neuropathic pain in studies. There are studies which support that. It is there. So even if the patient has got a normal B12 level within the normal range, you can still give it, especially if the patient is on long-term B12, metformin, especially 2 grams more than 5 years or so, and predominantly vegetarians. Because our patients usually, they are not non-vegetarians. They consume, suppose if you ask somebody whether they are vegetarians, they say, no, non-vegetarian. How frequently you take non-vegetarian? Once in a week I take fish curry. Maybe that is the only non-veg they consume. But they say that, so B12 deficiency is not that uncommon, especially in the ranges of normal range, lower ranges of the normal is very common.
Just one more final word on the question of pregabalin. So just wanted to mention that you have to be very careful. Any of the neuropathy drugs which we use, you have to be very careful in patients with advanced diabetes at risk of hypoglycemia. All these agents increase the risk of hypoglycemia unawareness, and especially in CKD patients, and there are high chances that the patient may get a severe hypoglycemic episode. We had one study from our own hospital. We saw that almost 70% of the patients who had a level 3 hypoglycemia, they had an agent, not only pregabalin, maybe amitriptyline, gabapentin, any of these sedative agents, because most of them will be having some amount of neuropathy, but you have to warn the patient for frequent blood glucose monitoring also.
The way it's fall following a fracture femur, that will be the end scenario.
Another important thing is fluid retention. These two things, gabapentin and pregabalin, can cause fluid retention, and especially in nephropathy, CKD, CCF patients, you may probably forget to look at this particular drug. When the patient presents with fluid retention also, immediately you go through all the drugs which may be precipitating fluid.
As the time is going, we can
it's very important.
the session, so we can wind up. Thank you, sir, for the
Thank you.
wonderful talk.
It was indeed a very informative session. Thank you, sir. I request the chairpersons to offer a memento to Dr. Ajit Kumar Shivashankaran for his wondrous efforts. Thank you, sir. I also request Dr. Shaji Abdul Ghafoor to honor our chairpersons, Dr. Ahmad Ashar and Deepthi Sunil, and Dr. Deepthi Sunil with a memento. Thank you, ma'am. Thank you, sir. On setting up of tech-savvy diabetic clinic. To chair this session, I would like to call upon Dr. A.P. Radhakrishnan, Palakkad, and Dr. Soumya Satyan, Maulana Hospital, Perinthalmanna.
First of all, let me thank the organizers of Kerala chapter, Dr. Chandni Madam, Suresh, Dr. Suresh, and Dr. Shaji for inviting me. First of all, to organize a wonderful program and inviting me to chair this session. So without much delay, I think we are getting late, and I would like to introduce Dr. Arun Shankar, is a good friend of mine. He'll be talking tech-savvy clinic. I think so. Technology is advancing very fast, and are we doing this? Are we keeping up this pace with our technology advancement in our new era? The COVID time, we learned that meetings have changed to physical meeting to online, and we started online consultations. So, but can we implement all this in our clinic to get more data for our patients? So with that, I introduce Arun Shankar, and he is a medical director and senior consultant diabetologist, Jyotidev Diabetes Center, Trivandrum. He is the chief coordinator of diabetes telemedicine, telemanagement system, and investigator in various clinical trials, and especially liraglutide, degludec, sitagliptin, and semaglutide. With that small introduction, over to you, Arun.
Thank you, sir. Thank you, ma'am. Good afternoon, all. I know that I am standing here between you and lunch. So, at the outset, let me thank Rssdi Kerala chapter, our dear chairperson Chandni ma'am, Suresh sir, and the entire new team. And I would also like to congratulate dear Dr. Shaji sir and Jayakrishan sir for the wonderful organization and conducting the conference, first quarterly Rssdi meeting. So, yeah. So these 2 years, more than 2 years, we were all suffering. Our patients were also having hard times, because among the non-communicable disease, diabetes patients were suffering a lot because they were not getting a proper treatment during the COVID time. And with this background, let me show you the basic model of digital diabetes clinic. So here you can see the treating diabetologist or physician, your diabetes subject, using connected diabetes devices. The data extracted from these devices are being transferred with the help of the apps available in these devices, such as smartphones. And these electronic medical records in your clinic is being assessed, and proper decision is made with regard to better glycemic control among your diabetes patients. So this is the basic digital diabetes clinic, or the virtual diabetes clinic, which we are seeing right now, which has helped us a lot during this COVID pandemic crisis situation. So why is it needed? What is the need of such diabetes clinic, digital diabetes clinic. Of course, we have to manage our diabetes patients round the clock. It is 24/7 job. And the various newer technologies, the available modalities go hand in hand with the progressive researches in diabetes, and which had made the virtual management of diabetes became a reality. And of course, with the usage of this, we can have a proper awareness among our diabetes patients with regard to the technologies available, so that we can provide a better quality of life among our diabetes subjects. But at the same time, it has to be cost effective, and this care is a continuum. So what are the goals of virtual diabetes clinic or the digital diabetes clinic? Of course, it is to provide healthcare facilities readily accessible to all the patients, mainly those patients who are living in remote rural areas, those patients who have a limitation in mobility, transportation difficulties, timing issues, living alone, particularly not having a proper family support. And of course, during the COVID pandemic situations or the crisis situation, definitely it will help a lot. And with the usage of these newer technologies available, we can help our patients to manage their diabetes with the help of lifestyle changes, monitoring, and proper usage of medications. And not only that, with the usage of this, the education can be implemented to prevent the onset of diabetes, the progression to complications, and with the help of self-management in diabetes care being provided. Of course, at times required, you can have a proper guidance to have emergency care among your patients. So what is telemedicine? It's a utilization of telecommunication equipments, including telephone, connected devices, sophisticated instruments for closer monitoring and intervention to achieve better glycemic control among your diabetes patients. Way back in 1998, this was the newer concept introduced by dear Dr. Jyodev Keshavdev at our center, that is Diabetes Telemanagement System, DTMS, a specialized telehealth program. Here, the major components included a customized software which includes electronic medical records with different user interfaces. We have a multidisciplinary team of diabetologists, doctors, dietitians, diabetes educators, psychologists, pharmacists involved in this team, helping the patients while they are communicating with this team either through telephone, emails, and internet using a secure website. Proper instructions or the treatment modification is being provided by the team so as to empower the patient, educate them, and troubleshoot all the things whenever, wherever it is needed. And of course, the multi-drug compliance in diabetes was linked, and still it is linked with DTMS, with diabetes pharmacy. So this was published in DTT a decade back. The cost effectiveness of the use of telemedicine and self-monitoring of blood glucose while with DTMS to achieve target HbA1c level without serious symptomatic hypoglycemia in more than 1,000 subjects with type 2 diabetes. That was a retrospective study. So you all know that we have lot robust of available technologies in diabetes management, including the commonest being highlighted here, that is the MySugar, the different apps, the one-touch reveal, and contour diabetes. I'm just rushing through the slides because of the timing. So these are all the available applications which patients are using regularly. So some among the wearable biosensors, we have two classifications, mainly wearable bands, wearable textiles, and wearable gears and other sensory devices for health monitoring. It includes wrist-mounted wearable, that is worn on the wrist, and wrist bands, of course the smartwatches. These all help in this diabetes virtual clinic while we are managing diabetes patients. And of course, among the Apple series, the Apple Smartwatch Series 4 with an FDA-approved ECG monitor is there. Apple Smartwatch Series 5 is paired with CGM devices such as Dexcom. And in our site, actually, we are using Dexcom 6 in this new study of once weekly basal insulin. Dr. Chandini Madam is also, her site is also part of this onward study, once weekly basal being compared with the once daily degludec insulin. So in that type 1 diabetes patients, we are using Dexcom sensor 6, but that is not the Apple Watch, but is the Apple iPhone being used in that study. and Apple Watch Series 6 with the help of measuring saturation. And in the 4 series, of course, the ECG captured from the Apple Watch is being transferred to the mobile as well, where you can have a proper look on the ECG. And of course, many things are connected. So we have the connected pens, the continuous glucose monitoring, the flash glucose monitoring, the newer subcutaneous insulin infusion, including the closed loop system available, not only for type 1, for type 2 as well. So in the connected pens, they automatically record the dose of insulin injected, and data can be shared with the collaborating CGM devices. The pens are being shown here. And if the FDA cleared in-pen available, that is smart pen system that combines the reusable Bluetooth pen along with the mobile app, which helps the users to administer the right insulin dose at the right time, which helps the elderly patients while you are managing to avoid extra dosage being used. And of course, the earlier I have mentioned about the glucose meters, which are being used with the help of Bluetooth connectivity, capturing of data, and the data being shared with the diabetes care team of the doctor's office. And of course, in this diabetes era, we are more focusing on glycemic variability. We are more discussing on time in range. So definitely you have to think of continuous glucose monitoring, where we are seeing the glycemic variability among your diabetes patients. Wherever it is indicated, you can opt for this continuous glucose monitoring devices to assess the low and high blood glucose variability. And definitely this CGM gives you a data in numerical and graphical format, reporting current glucose levels, the trend arrows which indicate direction and velocity of changing blood glucose levels. And among the CGM, you have two mainly. The one is first one is professional CGM, that is the diagnostic blinded continuous glucose monitoring, where the patient is wearing the CGM device for a period of 2 weeks, and later the patient returns back the sensor and the equipment to the clinic, the data being downloaded at the clinic and being analyzed. And of course, regarding the treatment modification can be done after assessing the glycemic variability with the usage of professional CGM. And the next one is the personal CGM, and this is very commonly used now in type 1 diabetes patients and among few of the type 2 diabetes patients, where you have brittle diabetes, more of blood glucose variability with frequent episodes of hypoglycemia. You can have this personal CGM being used, that is the real-time continuous glucose monitoring, that is Guardian 3, and intermittently scanned CGM, that is flash monitoring, Freestyle Libre. So moving on to continuous subcutaneous insulin infusion, the newer one, which is the sensor augmented pump therapy, SAP, where insulin infusion being done with the usage of insulin pump and the insulin dosage being adjusted with the data available or the glycemic variability sensed with the usage of continuous glucose monitoring data. And of course, the introduction of this real-time sensor augmented insulin pump is considered as a major turning point in the development of closed loop insulin delivery or an artificial pancreas. So the hybrid closed loop pump, it's another insulin pump being used to deliver variable basal insulin profile for your type 1 diabetes patients using an algorithm and the real-time CGM sensor to know the glucose trends and the dosage being modified accordingly. So the use of this HCL, that is a hybrid closed loop in adults and adolescents with type 1 diabetes, has also been shown to increase time in glycemic range and reduction of HbA1c without going for hypoglycemia, at the same time addressing the hyperglycemia as well, where with the newer insulin pumps, including the 780G from the Medtronic, we could attain more than 90% of time in range among our type 1 diabetes patients. So the sensor augmented pump and the HCL system have resulted in advancement in the care of type 1 diabetes, but have never met the realistic expectations of neither parents nor patients. So another movement was from Europe and other parts of the world, that is DIY. What is DIY? Do it yourself artificial pancreas. It consists of existing or old insulin pumps used along with continuous glucose sensors monitoring and connected to open source algorithm. And DIY looping has significantly improved the daytime excursion, which reduces the inter and intraday glycemic variability and produces stringent overnight control without going for the risk of having hypoglycemia among your type 1 patients. So this was the paper being presented, the DIY artificial pancreas, a narrative of the first patient and the physician experience from India last year. And you can see after looping, HbA1c reduced from 7.2 to 6.2%, and time in range increased to 90 to 95% from less than 60%. So the number of hypoglycemic events was clearly shown that it was reduced to 2 to 3 per month from 2 to 3 per day, and the awareness towards hypoglycemia improved. So this was the experience with DIY from India. So here you have the entire innovative diabetes technologies available which we can provide for our diabetes patients, starting from the connected glucometers, connected glucose meter apps, connected insulin pumps, connected insulin pens, and of course the non-invasive BG meters which will be available soon. And with all these gadgets available, definitely the team which you are having should help the patients to demonstrate the operation of blood glucose monitoring devices, educate them, starting and troubleshooting the CGM devices properly, and to clarify the doubts regarding medications and dosage, modify the diet according to the patient requirement. And of course, these data being recorded will help the healthcare professional and the entire team to make a proper decision while you are managing diabetes. So after this, all gadgets, something related to other diabetes management, of course, you have the teleophthalmology for diabetes eye care, where the eye screening with non-dilated retinal examination, fundus screening, and image being taken by the skilled eye technician, the data being transferred to the HCP, where the evaluation will be done and the decision will be taken properly. So these are the advantages of teleophthalmology. Already the things were discussed regarding the foot ulcers. So telepodiatry for diabetes foot care also will help to prevent the so-called foot ulcers among your patients, and at times those who are at risk can be evaluated and screened, and right decision can be made. So these are the different modalities available in telepodiatry. I'm just running through. So after the startage of the COVID scenario, definitely you have to touch something related to COVID in your presentation. So this was again our observation, that is the virtual COVID inpatient care being provided from our center. VCIP is a home-based interventional economic model wherein a consenting patient will remain in their home and consult with the VCIP team via audio video consultation to treat COVID-19 in a similar manner to inpatient care. But there is something different in this, because the treatment intervention was also being made with the usage of VCIP. So this was the scenario where we were addressing the blood glucose, monitoring the vitals regularly, titrating the dosage of insulin with the usage of the gadgets available, including home glucose monitoring with glucose meters or the sensors available, including the personal CGM sensors. And patient were taken care. And this paper was presented, a new interventional home care model of COVID management, virtual COVID IP, in the journal. So what are the advantages of virtual diabetes clinic? Definitely the modern gadgets which we are all using right now. Anybody in diabetes management, you will see the patient or the patient's bystanders will be having the gadgets, so that we can make use of that properly. It is nothing like only for high profile patients. Any patient who are using the modern gadgets can use this properly to have a better control in their diabetes management. So the advantages being, diabetes being a chronic illness, definitely you will require more brief consultation, which makes the patient remain in target levels. So the evidence shows that there is robust data showing reduction in cost and complications, and you can have a tracking of the patient's graph, the blood sugar values or the trend during the consultation, with which you can discuss with the patient, and you can motivate the patient for a better control in their diabetes management. And of course, you can save the time of frequent travel or face-to-face visits whenever, wherever it is possible. So these are the challenges while we are using the virtual diabetes clinic or the digital diabetes clinic, which I am discussing right now. Among the patients, few are not satisfied with the usage of digital diabetes clinics. And of course, while transferring data, it should be clear and pakka. So many challenges are there. I'm not going into detail. Among the requisites for this advanced digital diabetes clinic, the main focus I would like to point out here is virtual diabetes clinic approach should be adaptable. scalable, and clearly demonstrates safety, efficacy, and cost effectiveness. So definitely we require more and more large studies with the usage of digital diabetes and the gadgets available in diabetes management, so that we can use it very efficiently while we are managing our diabetes patients. So I would like to conclude with this slide that you have the patient with disability in this digital world. The main focus, patient will be giving the data with the usage of the so-called gadgets, including the smartphones, computer, tablets, all those connected or standalone devices. The data being collected from these devices or the gadgets should be transferred to the healthcare professional or the doctor's office, and with regular monitoring and checking of this various data available, patient or the team involved will be able to help the patient to manage diabetes in a very well, and of course in preventing the so-called macro or microvascular complication in the future among your diabetes patients. So with it, I would like to conclude, and thanks to the entire team from Rssdi Kerala chapter for giving me an opportunity, and thanks for listening. Thank you.
Thank you, sir. That was really an in-depth coverage of the topic. I think many of the terms were new for myself as well as many of the delegates over here. And as you mentioned, this is going to be the future of treatment of diabetes. So now the session is open to the delegates. Any questions?
It's almost 2:30.
I think because it is lunch time. Okay, if there are no questions from the audience side, we can conclude. Thank you. Thank you, sir.
Thank you, sir. This is as best as how a session could be wound up. But before winding up, let me invite the chairpersons to offer the memento as a small token of appreciation to Dr. Arun Shankar. Thank you, sir. I request Dr. Chandni ma'am to present the memento to Dr. Radhakrishnan and Dr. Soumya Satyan for their excellent contribution. Thank you, ma'am.
Secretary Rssdi, Dr. Shaji Abdul Ghafoor, Dr. Jayakrishnan, Dr. Sujit S. Nair, Dr. S. Ramdas, Dr. S. Mohandas, മറ്റു ഡോക്ടർമാരെയും ഇതിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. ഈ പരിപാടി ഉദ്ഘാടനം ചെയ്യുന്നതിനും പ്രസംഗിക്കുന്നതിനുമായി അലി സാഹിബിനെ ക്ഷണിച്ചോളൂ.
സ്നേഹമുള്ള സഹോദരി സഹോദരന്മാരെ, സുഹൃത്തുക്കളെ, ഇവിടെ രാവിലെ മുതൽ ഡയബറ്റിക് എക്സ്പേർട്ടുകൾ ഈ ഇവിടെ കാണുന്ന ഈ ഡോക്ടർമാരൊക്കെ ഉണ്ടല്ലോ, അപ്പോൾ കേരളത്തിലെ പല ഭാഗങ്ങളിൽ നിന്നും വന്ന ആൾക്കാരാണ്. അവർ രാവിലെ മുതൽ പല കാര്യങ്ങളും ചർച്ച ചെയ്തു. ആ കാര്യങ്ങൾ അവർക്ക് എല്ലാവർക്കും കൂടുതൽ വിവരങ്ങൾ ലഭിച്ചിട്ടുണ്ടാവും. അത് ഇവിടുത്തെ പേഷ്യൻസുമായി ബന്ധപ്പെടുക എന്നുള്ള, അല്ലെങ്കിൽ പേഷ്യൻസുമായി അവരോട് സംസാരിക്കുക, അവരെ സംശയങ്ങൾ വല്ലതും ഉണ്ടെങ്കിൽ അത് ദൂരീകരിക്കുക, അത് ക്ലിയർ ചെയ്യുക എന്നുള്ളതിൻ്റെ അടിസ്ഥാനത്തിലാണ് ഇതേപോലെ ഒരു ഓപ്പൺ ഫോറം ഇവിടെ വെച്ചിട്ടുള്ളതെന്ന് ഞാൻ മനസ്സിലാക്കുന്നത്. ഈ സംഘടനയുടെ പേര് RSSDI എന്നാണ്. RSS എന്ന് ആദ്യം കേട്ടുകൊണ്ട് പേടിച്ച് ആരും പോകണ്ടെന്നാണ് എനിക്ക് ആദ്യമായിട്ട് പറയാനുള്ളത്. നമ്മുടെ എക്സ്പെർട്ട് ആയിട്ടുള്ള ഡോക്ടർമാർ അവിടെ ഇരിക്കുന്നവരൊക്കെ, നിങ്ങൾക്ക് ഇവരൊരു അപ്പോയിൻമെൻറ്റ് കിട്ടണം, അല്ലെങ്കിൽ ഇവരൊരു മണിക്കൂർ അല്ലെങ്കിൽ ഇവരെ കുറച്ച് സമയം കിട്ടണമെന്നുണ്ടെങ്കിൽ നിങ്ങൾ കുറേ ദിവസങ്ങൾക്ക് മുമ്പ് ബുക്ക് ചെയ്യണം, എന്നാൽ മാത്രമേ ഇത് കിട്ടുള്ളൂ. ഇതിപ്പോൾ നമുക്ക് ഒരു അസുലഭ ഭാഗ്യം കിട്ടിയാണ്. പത്തനംതിട്ടയിൽ നിന്നും അതുപോലെ തന്നെ പാലയിൽ നിന്നും അതുപോലെ തന്നെ മറ്റുള്ള കോഴിക്കോട് നിന്നും ആൾക്കാരൊക്കെ ഉടനെ കൊണ്ടുവന്നിട്ടുണ്ട്. ഡോക്ടർ ഷാജി അതിന് മുൻകൈ എടുത്തതാണ്. ഷാജി നമുക്കറിയാം, കുറേയധികം കാര്യങ്ങൾ നമ്മൾ ഈ കാലഘട്ടങ്ങളിൽ ഇവിടെ നിന്നൊക്കെ ചെയ്ത ഒരാളാണ് അദ്ദേഹം. ഞാനും ആദ്യമായിട്ട് ബന്ധപ്പെടുന്ന അദ്ദേഹം നമ്മുടെ ഗവൺമെൻറ് ആശുപത്രിയിലെ ഇവിടുത്തെ സൂപ്രണ്ടായിരുന്ന കാലഘട്ടങ്ങളിലാണ്. പെരിന്തൽമണ്ണ ഗവൺമെൻറ് ആശുപത്രി നിങ്ങൾക്ക് അറിയാം, പഴയ കാലത്ത് ഒരു 10-15 വർഷം മുമ്പ് എങ്ങനെയായിരുന്നു സ്ഥിതി. ശരിക്കും ഒരു വൃത്തികെട്ട അല്ലെങ്കിൽ അങ്ങോട്ട് ചെല്ലാൻ പറ്റാത്ത തരത്തിലുള്ളൊരു ഹോസ്പിറ്റലായിരുന്നു. അദ്ദേഹത്തിൻ്റെ മികവ് കൊണ്ട് തന്നെയാണ് നമ്മൾ മറ്റുള്ള സഹായങ്ങളൊക്കെ ഞങ്ങൾ പല ഭാഗത്തും ചെയ്തു കൊടുത്തു. കേരളത്തിലെ തന്നെ ഏറ്റവും രണ്ടാമത്തെ ബെസ്റ്റ് ഹോസ്പിറ്റൽ എന്നുള്ള ക്ലീൻലിനെസ്സിന് നമുക്ക് രണ്ടാമത്തെ തന്നെ അല്ലേ, ആദ്യത്തെ ശ്രമിച്ച് കിട്ടിയില്ല. ആ കാലഘട്ടങ്ങൾ നമുക്ക് ലഭിച്ച അദ്ദേഹത്തിൻ്റെ ഒറ്റ കഴിവുണ്ട്. അപ്പോൾ അദ്ദേഹം എന്തൊരു കാര്യം ചെയ്യുകയാണെങ്കിലും വളരെ ആത്മാർത്ഥമായിട്ട് സിൻസിയറായിട്ട് ചെയ്യുന്നുണ്ട്. അതിൻ്റെ അടിസ്ഥാനത്തിലാണ് ഈ IMA നമ്മുടെ ഈ ഹാളിൽ ഇതേപോലുള്ള ഡോക്ടർമാർ എക്സ്പേർട്ടുകളെല്ലാവരും കൊണ്ടുവന്നിട്ട് ഇതേപോലുള്ള സംസാരം ഉണ്ടാക്കുന്നത്. അപ്പോൾ സ്വാഭാവികമായിട്ട് നമുക്ക് എന്തെങ്കിലും ചർച്ച ചെയ്യണമെന്നുണ്ടെങ്കിൽ പിന്നെ അവരോട് സംസാരിക്കും. അപ്പോൾ ഞാൻ വന്നപ്പോൾ ഇങ്ങോട്ട് കയറി വന്നപ്പോൾ ഭയങ്കര ബിരിയാണിയുടെ മണം എനിക്ക് കിട്ടിയത്. അപ്പോൾ ഞാൻ ചോദിച്ചു പിന്നെ ഡോക്ടറോട്, ഇത് പേഷ്യൻസ് ഇവിടെ ഡയബറ്റിക്കാണ്, നിങ്ങൾ ഞങ്ങളോടൊക്കെ ബിരിയാണി കഴിക്കണ്ടെന്ന് പറയും, എന്നിട്ട് നിങ്ങൾ ബിരിയാണി നിന്നത് ശരിയല്ലല്ലോ എന്ന് പറഞ്ഞപ്പോൾ എന്നോട് പറഞ്ഞു, അത് സാരമില്ല, ഇന്ന് മാത്രമല്ല ഇന്ന് നിങ്ങളൊരു പായസം കുടിക്കുക എന്ന് പറഞ്ഞിട്ട് ഒരു ഗ്ലാസ് പായസം എനിക്ക് തരുന്നത്. ഞാൻ ഒരു പേഷ്യൻ്റാണ്, അദ്ദേഹത്തിൻ്റെ പേഷ്യൻ്റാണ്. ഇപ്പോൾ 2-3 ദിവസം മുമ്പ് ഞാൻ ബ്ലഡ് ടെസ്റ്റ് ചെയ്തപ്പോൾ എനിക്ക് 117ആണ്. അപ്പോൾ നല്ല കൺട്രോളാണെന്ന് ഇവിടെയുള്ള എക്സ്പേർട്ട് ഇദ്ദേഹമൊക്കെ പറഞ്ഞ വളരെ വലിയ കൺട്രോളാണ്. 6.3 എന്താണ് 3 months റേറ്റ് എടുത്ത് നോക്കുകയാണെങ്കിൽ HP ഇവരെ പേര് എനിക്ക് എന്തായാലും എൻ്റെ നാവിൽ വരലില്ല. അപ്പോൾ അതുകൊണ്ട് ഞാനത് 3 മാസം എന്നുള്ള രീതിയിൽ പറയും. അത് 6.3 ആണ്. അപ്പോൾ ഞാൻ ചോദിച്ചു ഡോക്ടറെ, പായസം ഇതിന് ശരിയല്ലല്ലോ എന്ന് പറഞ്ഞപ്പോൾ അതും പറഞ്ഞു. അദ്ദേഹം പറഞ്ഞു, അത് സാധനം ഇന്നല്ലേ ഒരു ദിവസം. ഇതാണ് നമ്മളുടെ തകരാറും. നമ്മളിപ്പോൾ എവിടെയെങ്കിലും വിരുന്ന് പോയിട്ടുണ്ടെങ്കിൽ വേണ്ട എനിക്ക് പഞ്ചസാരം വേണ്ടെന്നുണ്ടെങ്കിൽ അല്ല സാധനമല്ല കുറച്ച് പായസം കുടിച്ചോളൂ, ഇന്ന് ഒരു ദിവസമല്ലേ എന്നാണ് നമ്മളെല്ലാവരും നിർബന്ധിച്ച് അങ്ങനെ നമ്മൾ ഭക്ഷണത്തിൻ്റെ ക്രമീകരണം തെറ്റുന്നതാണ് ഏറ്റവും വലിയൊരു പ്രശ്നം നമ്മൾ അനുഭവിക്കുന്നത്. നമ്മളെ സ്നേഹിക്കുന്ന ആൾക്കാരായിരിക്കും, അതുകൊണ്ടാണ് ഈ ചായ മധുരട്ട് സാരല്ല ഒരു ദിവസമല്ലേ എന്ന് പറഞ്ഞിട്ട് അങ്ങനെ കുറച്ച് തരുന്നത്. അങ്ങനെ നമ്മൾ മുന്നോട്ട് പോകാറുണ്ട്. അപ്പോൾ ഇവിടുത്തെ ഉള്ള ഡോക്ടർമാരുണ്ട്, അവർ വളരെ എക്സ്പേർട്ടുകളാണ്. അവർ കൂടുതൽ കാര്യങ്ങൾ സംസാരിക്കുന്നുള്ളത് കൊണ്ട് എനിക്കതിനെപ്പറ്റി ഒന്നും അറിയില്ലാത്തതുകൊണ്ട് ഞാൻ കൂടുതൽ കാര്യങ്ങളൊക്കെ ഒന്നും തന്നെ പോകുന്നില്ല. ഞാൻ ഒരു പേഷ്യൻ്റാണ്, നിങ്ങളൊക്കെ പോലെ തന്നെ. നിങ്ങളെ സംസാരം എന്തൊക്കെയാണെന്ന് വിചാരിച്ചാൽ കേട്ടിട്ട് പിന്നെ അതിനുള്ള മറുപടി അവർ പറയും. അതുകൊണ്ട് മറ്റുള്ള കാര്യങ്ങളൊക്കെ ഒന്നും പോകാതെ ഈ ഫോറം ഇതിൻ്റെ പിന്നെ ഔപചാരികമായ ഉദ്ഘാടന കർമ്മം നിർവഹിച്ചത് അറിയിച്ചുകൊണ്ട് എൻ്റെ വാക്കുകൾ സമ്മതിക്കുന്നു. അഭിവാദം.
RSSDI എന്ന് പറയുന്നത് റിസർച്ച് സൊസൈറ്റി ഫോർ സ്റ്റഡി ഓഫ് ഡയബറ്റീസ് ഇൻ ഇന്ത്യ. അതൊരു വലിയ പേരാണ്. പക്ഷേ അതിൻ്റെ പ്രധാനമായിട്ടുള്ള ഉദ്ദേശം പ്രമേഹ രോഗ ചികിത്സയിലുള്ള കാര്യങ്ങൾ, പ്രമേഹ ചികിത്സയിൽ ഉൾപ്പെട്ടിരിക്കുന്ന ഡോക്ടർമാരും മറ്റ് ആരോഗ്യ പ്രവർത്തകരെയും അതിനെക്കുറിച്ച് പഠിപ്പിക്കുക. അല്ലെങ്കിൽ കൂടുതൽ പുതിയ വിവരങ്ങൾ വരുമ്പോൾ നമ്മളത് ചർച്ച ചെയ്യുന്നു. കൂടുതലായിട്ട് എങ്ങനെ രോഗികളിലേക്ക് ഈ കാര്യങ്ങൾ എത്തിക്കാൻ പറ്റുമെന്ന് നമ്മളുടെ ഇടയിൽ ഡിസ്കഷൻസ് നടക്കുന്നു. അതിനോടൊപ്പം തന്നെ പ്രമേഹം എന്ന് പറയുമ്പോൾ ആ രോഗത്തിൻ്റെ ഏറ്റവും വലിയ ചികിത്സ എങ്ങനെ കൊണ്ടുപോകണം എന്ന് തീരുമാനിക്കുന്നത്, മറ്റേത് അസുഖം എടുത്താലും രോഗി സ്വന്തം ഇഞ്ചക്ഷൻ വയ്ക്കുകയും രോഗി സ്വന്തം ഷുഗർ നോക്കുക ഗ്ലൂക്കോസ് നോക്കുകയൊന്നും ചെയ്യുന്ന മറ്റൊരു അസുഖവും ഇല്ല. അപ്പോൾ രോഗിയാണ് അതിൻ്റെ കേന്ദ്ര കഥാപാത്രം. അപ്പോൾ രോഗിയും രോഗിയെ പരിചരിക്കാൻ ചുറ്റുമുള്ള ആളുകളും അവരെയാണ് പ്രാപ്തരാകേണ്ടത്. നമ്മൾ ബാക്കി ഡോക്ടർമാരും മറ്റ് ആരോഗ്യ പ്രവർത്തകരും അവരെ സഹായിക്കാനായിട്ടാണ് പലപ്പോഴും ഉണ്ടാവുക. അപ്പോൾ രോഗികളെ കൂടുതൽ ബോധവൽക്കരിച്ചാൽ മാത്രമേ നമുക്ക് ഈ പറയുന്ന രോഗനിർണയം സാധ്യമാകുകയുള്ളൂ. അപ്പോൾ അതുകൊണ്ട് തന്നെ RSSDIയുടെ ഒരു പ്രധാന പ്രവർത്തന മേഖല പൊതുജനങ്ങളെ ബോധവൽക്കരിക്കാൻ മാത്രമല്ല, നമ്മുടെ ചെറുപ്പക്കാർ, കുട്ടികൾ, അവർക്കൊക്കെ പ്രമേഹം വരാതിരിക്കാൻ എന്തൊക്കെ ചെയ്യണം, ഏതൊക്കെ തരത്തിൽ പ്രമേഹം നിയന്ത്രണം വേണം എന്നുള്ള കാര്യങ്ങൾ എത്തിക്കാനും കൂടിയാണ് സംഘടനയുടെ രണ്ടാമത്തെ ലക്ഷ്യം. മൂന്നാമത്തെ ലക്ഷ്യം തീർച്ചയായിട്ടും നമ്മുടെ നാട്ടിലെ ആളുകളിൽ ഈ പ്രമേഹ നിയന്ത്രണം, പ്രമേഹ പരിചരണം, മരുന്നുകളൊക്കെ എങ്ങനെ പ്രവർത്തിക്കുന്നു, കൂടുതൽ എന്തൊക്കെ ചെയ്യാൻ പറ്റും എന്നുള്ള തരത്തിലുള്ള പഠനങ്ങൾ. ഈ 3 ഉദ്ദേശമാണ്. അതിൽ ഇന്ന് രാവിലെ ഞങ്ങൾക്ക് ഡോക്ടർമാർ ഉൾപ്പെട്ട ഒരു ക്ലാസ്സാണ് നടത്തിയത്. ഉച്ചയ്ക്ക് നമ്മൾ ഈ സന്ദർഭം ഡോക്ടർ ഷാജിയുടെ മേൽനോട്ടത്തിൽ ഇവിടെ ഇങ്ങനെയൊരു സന്ദർഭം ഒരുക്കി കിട്ടി. അതുകൊണ്ട് ഞങ്ങളെല്ലാവരും വളരെയേറെ സന്തുഷ്ടരാണ്. അതിലേറെ സന്തുഷ്ടരാകാൻ കാരണം ശ്രീ മഞ്ഞളാംകുഴി അലി സാറ് ഇന്ന് ഇവിടെ ഈ സംഭവം ഉദ്ഘാടനം ചെയ്യാൻ അദ്ദേഹത്തിൻ്റെ തിരക്കിനിടയിൽ ഇവിടെ എത്തി എന്നുള്ളതാണ്. അദ്ദേഹത്തിന് ഞങ്ങളുടെ എല്ലാവരുടെയും വക പ്രത്യേകം താങ്ക്സ് പറയുന്നു. മറ്റ് വിദഗ്ധരായ ഡോക്ടർമാരും ഇവിടെ ഉണ്ട്. എനിക്ക് തോന്നുന്നത് ഡോക്ടർ സുരേഷാണ് ഞങ്ങളുടെ സെക്രട്ടറി. ഡോക്ടർ സുരേഷിന് ഞാൻ 2 വാക്ക് സംസാരിക്കാം. ഡോക്ടർ ഷാജി തന്നെ ഇതിന് നേതൃത്വം നൽകും, എങ്ങനെ ഈ ചർച്ച മുന്നോട്ട് പോകണമെന്നത്. എല്ലാവർക്കും അവരുടെ സംശയങ്ങൾ ചോദിക്കാം. കൂടുതൽ എന്തെങ്കിലും ഡോക്ടർമാരുടെ നിലയിൽ ഞങ്ങളിൽ നിന്ന് നിങ്ങൾക്ക് എന്തെങ്കിലും പഠനത്തിന് വേണ്ടിയോ അല്ലെങ്കിൽ ഇതിനെക്കുറിച്ച് പഠിക്കാൻ അല്ലെങ്കിൽ ടെസ്റ്റ് ചെയ്യാൻ ഉള്ള കാര്യങ്ങളൊക്കെ പിന്നീടും തുടർന്ന് എത്തിക്കാൻ ഞങ്ങൾക്ക് സാധിക്കും. ഡോക്ടർ ഷാജി ഇവിടെ ഉള്ളതുകൊണ്ട് നിങ്ങൾക്ക് അതിൽ കൂടുതലും ഞങ്ങൾക്ക് ഉറപ്പ് തരാനും ഇതുകൊണ്ട് തന്നെയാണ് പറ്റുന്നത്. താങ്ക് യു.
സുഹൃത്തുക്കളെ, ബഹുമാനനായ ഉദ്ഘാടകൻ, ബാക്കി എല്ലാ സുഹൃത്തുക്കളും, RSSDI എന്ന് നേരത്തെ പറഞ്ഞു. RSS എന്ന് പറയുന്നത് റിസർച്ച് സൊസൈറ്റി ഫോർ ദ സ്റ്റഡിയാണ്. ഏറ്റവും കൂടുതൽ പഠനങ്ങളാണ് റിസർച്ചിൽ ഡയബറ്റീസിൽ നടക്കുന്നത്. അതിനു വേണ്ടിയിട്ടാണ് ഇവിടെ നമ്മൾ ഇന്ന് ഇരിക്കുന്നത്. നിങ്ങളെ ചികിത്സിക്കാനോ അല്ലെങ്കിൽ പരിശോധിക്കാനോ അല്ല, അത് പ്രത്യേകം മനസ്സിലാക്കണം. ഇന്ന് നമ്മൾ കൂടിയിരിക്കുന്ന പല ആൾക്കാരും, നമ്മൾ പല സ്ഥലത്ത് ചെല്ലുന്ന സമയത്തും ഏറ്റവും കൂടുതൽ ഡയബറ്റീസിൽ വേണ്ട മാഡം പറഞ്ഞ പോലെ അവയർനെസ്, ബോധവൽക്കരണമാണ് ഒരു പ്രമേഹം ചികിത്സിക്കാൻ വേണ്ടത്. നിങ്ങളുടെ ഡോസ് അഡ്ജസ്റ്റ് ചെയ്ത് തന്നുകൊണ്ടോ നിങ്ങളൊന്ന് പരിശോധിച്ച് നിങ്ങളുടെ ഷുഗർ നോക്കിയതുകൊണ്ടോ നിങ്ങളുടെ പ്രമേഹത്തിൻ്റെ പ്രശ്നം തീരാൻ പോകുന്നില്ല. മറിച്ച് നിങ്ങൾ ആ അസുഖത്തിനെ കുറിച്ച് നിങ്ങൾക്ക് സ്വയം ബോധവാനായി കഴിഞ്ഞാൽ അതിൻ്റെ 10 ഇരട്ടി ഗുണം നിങ്ങൾക്കുണ്ടാവും. അതാണ് നമ്മളുടെ ഉദ്ദേശം. ഓരോ രോഗിയും ആ രോഗത്തെക്കുറിച്ച് ശാസ്ത്രീയമായി മനസ്സിലാക്കുക. ഇപ്പോൾ ഏറ്റവും കൂടുതലുള്ള പ്രോബ്ലം എന്ന് വെച്ചാൽ അശാസ്ത്രീയമായിട്ടുള്ള കാര്യങ്ങളാണ് ഏറ്റവും കൂടുതൽ സോഷ്യൽ മീഡിയ വഴി പ്രചരിക്കുന്നത്. അത് മനസ്സിലാക്കിയിട്ട് നമ്മൾ പലപ്പോഴും ശാസ്ത്രീയമായ ചികിത്സാ രീതിയിൽ നിന്നും വ്യതിചലിച്ചു പോവുകയും അശാസ്ത്രീയമായിട്ടുള്ള കാര്യങ്ങളെ അഡോപ്റ്റ് ചെയ്തിട്ട് അവസാനം കോംപ്ലിക്കേഷനിൽ എത്തുന്ന സമയത്ത് മാത്രം നമ്മൾ ഓടിച്ചെന്നിട്ട് ഡോക്ടറെ അടുത്തോ ഹോസ്പിറ്റലിൽ അടുത്തോ ചെല്ലുന്നൊരു അവസ്ഥയുണ്ട്. അങ്ങനെ വരാതിരിക്കണമെങ്കിൽ നമുക്ക് ഓരോരുത്തർക്കും നമ്മൾ അനുഭവിക്കുന്ന രോഗം വെച്ചാൽ നമ്മുടെ കൂടെ നിൽക്കുകയാണ്. നമ്മുടെ ഉടുമ്പിനെ പോലെ പിടിച്ച് നമ്മുടെ കൂടെ ജീവിതകാലം മുഴുവൻ നമ്മളെ വിടാതെ പിടിക്കുന്ന ഒരു കാര്യമായതുകൊണ്ട് അതിനെക്കുറിച്ച് നമ്മൾ അറിയണം. ഇതെന്താണ് സാധനം അറിഞ്ഞു കഴിഞ്ഞാൽ നമുക്കറിയാം. മൂർഖൻ പാമ്പിനെ പോലും അറിയുന്നവരിപ്പം പണ്ട് വേലായുധനെ അറിയാമല്ലോ, പാമ്പിനെ നന്നായി അറിയുന്ന ആളാണ്. വേലായുധൻ പാമ്പിൻ്റെ കൂടെ കടിച്ചാലും പാമ്പ് വേലായുധനെ കടിക്കില്ല. യൂഷ്വലി സാധാരണഗതിയിൽ അപൂർവമായിട്ട് കടിച്ചെന്നിരിക്കും. അതുപോലെയാണ് ഈ രോഗം. ആ രോഗത്തിനെ കുറിച്ച് നമുക്ക് മനസ്സിലായാൽ നമ്മളെ അത് ഉപദ്രവിക്കില്ല. ആ മനസ്സിലാക്കലാണ് ഏറ്റവും ഇമ്പോർട്ടൻറ്റ്. പാമ്പ് പാമ്പിന് അവനെ കൃത്യമായിട്ട് അറിയാം. അവൻ ഏത് രാജവെമ്പാലയും പോയി അവൻ പിടിക്കും കൂളായിട്ട്. കാര്യം അവൻ അറിയാം രാജവെമ്പാല എന്ത് ചെയ്യും, എങ്ങനെ ചെയ്യും, എപ്പം കടിക്കും, എപ്പം ഊതും എന്നൊക്കെ അതിന് കൃത്യമായിട്ട് അറിയുന്ന ആളാണെങ്കിൽ മാത്രമേ അതിനെ ഹാൻഡിൽ ചെയ്യാൻ പറ്റുള്ളൂ. അതേ പ്രിൻസിപ്പിളാണ് നമ്മളിവിടെയും ഉപയോഗിക്കുന്നത്. അതായത് രോഗത്തിനെ കുറിച്ച് നിങ്ങൾ കൃത്യമായി മനസ്സിലാക്കി കഴിഞ്ഞാൽ നിങ്ങളെ സംബന്ധിച്ചിടത്തോളം പിന്നെ ആ രോഗത്തിനെ കുറിച്ച് നിങ്ങൾ പേടിക്കേണ്ട, നിങ്ങളത് കടിക്കില്ല. അതാണ് ഏറ്റവും ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള പോയിന്റ് എനിക്കിന്ന് പറയാനുള്ളത്. പിന്നെ ഇവിടെ ഈ എല്ലാ മേഖലകളിലും നമ്മളെല്ലാ സ്ഥലങ്ങളിലും കേരളത്തിൻ്റെ മധ്യ കേരളം, അതുപോലെ തന്നെ ദക്ഷിണ കേരളം, സെൻട്രൽ കേരളം, നോർത്ത് കേരളം, എല്ലാ സ്ഥലങ്ങളിലും ഇതേപോലത്തെ ഓരോ ഫിസിക്കൽ മീറ്റിംഗ് നമ്മൾ ഓരോ കൊല്ലത്തിൽ നടത്തും. അതിൻ്റെ ഒരു ഭാഗമായിട്ടാണ് ഇന്നിവിടെ നടത്തുന്നത്. അതിനെ ഓർഗനൈസ് ചെയ്യാൻ വേണ്ടി നമുക്ക് വളരെ നല്ലത്, ഒന്ന് പെരിന്തൽമണ്ണ ഇങ്ങനെ നല്ലൊരു IMA ഹാൾ ഉണ്ടായത് വലിയൊരു കാര്യമാണ്. പിന്നെ രണ്ടാമത്തേത് ഡോക്ടർ ഷാജിയെ പോലുള്ള നല്ലൊരു ഓർഗനൈസർ, എല്ലാ കാര്യങ്ങളും വളരെ പക്വമായിട്ട് വളരെ കറക്റ്റായിട്ട് ഓർഗനൈസ് ചെയ്ത് ഹാൻഡിൽ ചെയ്യാൻ പറ്റുന്ന ഒരാളുണ്ടായി. നിങ്ങൾക്ക് അതുപോലുള്ളൊരു ഭിഷഗ്വരൻ, ഒരു ഡോക്ടറിനെ പെരിന്തൽമണ്ണ കിട്ടി എന്ന് പറയുന്നത് ഒരു ഭാഗ്യം തന്നെയാണ്. അപ്പം ഡോക്ടർ ഷാജിയുടെ നേതൃത്വത്തിൽ നിങ്ങൾക്കുള്ള സംശയ നിവാരണം ഞങ്ങൾ എല്ലാ സ്ഥലത്തു നിന്നും വന്ന ആൾക്കാരുണ്ട്. തിരുവനന്തപുരത്തെ ഏറ്റവും പ്രശസ്തമായിട്ടുള്ള ഡോക്ടർ ജ്യോതിദേവ് ഡയബറ്റീസ് കെയറിൻ്റെ നിങ്ങൾക്ക് കേട്ടിട്ടുണ്ടാവും, എല്ലാവരും അറിയാം. ഏറ്റവും കൂടുതൽ ഡയബറ്റീസ് അവയർനെസ് പ്രോഗ്രാംസ് കേരളത്തിൽ നടത്തുന്ന അവരാണ്. അവരുടെ അടുത്തുനിന്ന് വന്ന ഡോക്ടർ അരുൺ ശങ്കർ മുതൽ നമ്മൾ വയനാട്ടിൽ ഇങ്ങേ അറ്റത്തുള്ള ശീശാൻ മുതൽ എല്ലാ സ്ഥലത്തും പത്തനംതിട്ട എല്ലാ ആൾക്കാരും ഉണ്ട്. ഡോക്ടർ അജിത് കുമാർ ഉണ്ട്, തിരുവനന്തപുരത്ത് പ്രശസ്ത പ്രമേഹ പാദരോഗ വിദഗ്ധരായിട്ടുള്ള 2 പേര് ഇവിടെ ഉണ്ട്. ഡോക്ടർ വിജയകുമാർ ഉണ്ട്, എല്ലാ ആൾക്കാരും ഉണ്ട്. ഇപ്പോൾ ഇത്ര ആൾക്കാരോട് ഇതുമായി ബന്ധപ്പെട്ടുള്ള സംശയ നിവാരണത്തിന് വേണ്ടി ഈ അവസരം നിങ്ങൾ ഉപയോഗിക്കുക. ചികിത്സിക്കാനോ പ്ലീസ് ഡോക്ടറെ എൻ്റെ ഷുഗർ ഇത്രയാണ്, ഞാൻ ഈ മരുന്ന് കഴിക്കും, നിങ്ങൾ ഇതൊന്നും മാറ്റിത്തരുമെന്നൊന്നും ഒരിക്കലും ഇപ്പം ചോദിക്കരുതെന്ന് പ്ലീസ്. കാരണം അതിനുവേണ്ടി അല്ല ഈ അവസരം എന്ന് നിങ്ങളെ ഓർമ്മപ്പെടുത്തിക്കൊണ്ട് ഞാൻ ഡോക്ടർ ഷാജിക്ക് മൈക്ക് കൈമാറുന്നു. ഇനി നിങ്ങൾക്ക് ചോദ്യങ്ങൾ ചോദിക്കാം.
ബഹുമാന്യനായ നമ്മുടെ എല്ലാം പ്രിയങ്കരനായ MLA ശ്രീ മഞ്ചനാംകുഴി അലി സാഹിബ്, പിന്നെ ഇവിടെ പറഞ്ഞു ഓൾറെഡി നമ്മളെ ഓരോരുത്തരെ ഇൻട്രൊഡ്യൂസ് ചെയ്ത് തരാം. ഞാൻ ഡോക്ടർ ഷാജി, നിങ്ങൾക്കെല്ലാം അറിയാം. ഞാൻ കൂടുതലും സംസാരിക്കുന്ന കാര്യം എൻ്റെ സംസാരം നിങ്ങൾ കുറേ കേട്ടിട്ടുള്ളതാണ്. കുറച്ച് പ്രമേഹമൊക്കെ കൂടി വരുന്ന ആളുകളെ ഞാൻ ചിലപ്പം വഴക്കൊക്കെ പറയാറുണ്ട്. അപ്പം ഇവിടെയുള്ള ബാക്കി ഡോക്ടർമാർ ഒരു 2 വാക്ക് ആദ്യം സംസാരിക്കും. അതിനുശേഷം നിങ്ങളുടെ സംശയങ്ങൾ നമുക്ക് ചോദിക്കാം. നിങ്ങൾ പർട്ടിക്കുലർലി ഏത് ഡോക്ടറോടാണ് ചോദിക്കേണ്ടതെന്ന് വെച്ചാൽ ആ ഡോക്ടറുടെ പേര് പറഞ്ഞ് ചോദിക്കാം. ഇതിപ്പോൾ സംസാരിച്ച് ഡോക്ടർ ചാന്ദിനിയാണ്, നമ്മുടെ മെഡിക്കൽ കോളേജ് കോഴിക്കോട്ടെ പ്രൊഫസറാണ്. ഇത് ഡോക്ടർ സുരേഷ് കുമാർ, കോഴിക്കോട് തന്നെയുള്ള ഡോക്ടറാണ്. ഇനി ഓരോരുത്തരും സെൽഫായിട്ട് ഇൻട്രൊഡ്യൂസ് ചെയ്ത് 2 വാക്ക് സംസാരിക്കും. ഇനി അടുത്ത ഡോക്ടർ ജോ.
എല്ലാവർക്കും നമസ്കാരം. ഞാൻ ഡോക്ടർ അരുൺ ശങ്കർ, തിരുവനന്തപുരത്തെ ജ്യോതിദേവ്സ് ഡയബറ്റീസ് റിസർച്ച് സെൻ്ററിൽ വർക്ക് ചെയ്യുന്ന ഡോക്ടറാണ്.
ഞാൻ ഡോക്ടർ അബൂബക്കർ സീഷാൻ, വയനാട് ഫാത്തിമ ഹോസ്പിറ്റലിൽ ഡയബറ്റോളജിസ്റ്റായി വർക്ക് ചെയ്യുന്നു.
രാംദാസ്, പെരുന്തൽമണ്ണ.
ഞാൻ ഡോക്ടർ ജോ ജോർജ്, എൻഡോക്രൈനോളജിസ്റ്റാണ്. നിങ്ങൾക്ക് പെരിന്തൽമണ്ണ എൻഡോഡയബ് ക്ലിനിക്ക് പരിചയമുണ്ടാവും. ഈ എൻഡോഡയബ് ശൃംഖലയുടെ കോഴിക്കോട് ശാഖ ഞാനാണ് നടത്തുന്നത്.
ഞാൻ ഡോക്ടർ വിജയകുമാർ, പന്തളത്താണ്, പത്തനംതിട്ട ജില്ലയിലെ പന്തളത്ത് നിന്ന് വരെയാണ്. എനിക്ക് ഒരു കാര്യം മാത്രം ഒന്ന് സൂചിപ്പിക്കാനുണ്ട്. ശരിക്കും ഞാൻ ഡയബറ്റീസിൻ്റെ രോഗികളുടെ എണ്ണം കേരളത്തിൽ ഓരോ വർഷം കൂടിക്കൊണ്ടിരിക്കുകയാണ്. ശരിക്കും ഞാൻ 1972 ഒരു 2.3% ആളുകൾക്കായിരുന്നു 18 വയസ്സിന് മുകളിലുള്ളവർക്ക്. അതിപ്പോൾ ഏതാണ്ട് 27% ആളുകൾക്ക് പ്രമേഹമുണ്ട് കേരളത്തിൽ നിന്നാണ് പുതിയ പഠനങ്ങളൊക്കെ കാണിക്കുന്നത്. അത് എന്തുകൊണ്ട് കൂടുന്നു എന്നുള്ളത് ശരിക്കും എന്നെപ്പോലെ ഈ തല നിറച്ച എൻ്റെ മുമ്പിലിരിക്കുന്ന നിങ്ങൾക്കൊക്കെ മനസ്സിലാവും. കാരണം നമ്മൾ 10-50 കൊല്ലം മുമ്പ്, അല്ലെങ്കിൽ 45-50 കൊല്ലം മുമ്പ് കഴിച്ചുകൊണ്ടിരുന്ന ആഹാരമല്ല നമ്മളിപ്പോൾ കഴിക്കുന്നത്. അല്ലെങ്കിൽ നമ്മുടെ കുട്ടികളെങ്കിലും കഴിക്കുന്നത് അങ്ങനല്ല. ആഹാരത്തിലുള്ള ഒരുപാട് മാറ്റങ്ങൾ, അതുപോലെ എല്ലാവർക്കും വാഹനങ്ങളുണ്ട്, ഒട്ടും നടക്കുന്നില്ല, എക്സസൈസ് ഒന്നുമില്ല, നമ്മുടെയൊക്കെ ചെറുപ്പകാലത്ത് ചെയ്തുകൊണ്ടിരുന്ന രീതിയിലുള്ളൊരു ആഹാര രീതിയുമല്ല, ആ രീതിയിലുള്ളൊരു അധ്വാനവുമല്ല നമ്മൾ ചെയ്യുന്നത്. അതുകൊണ്ട് തന്നെയാണ് ഇത് കൂടിക്കൊണ്ടിരിക്കുന്നത്. അപ്പോൾ എന്തുകൊണ്ട് എനിക്ക് ഡയബറ്റീസ് വന്നു എന്ന് ഇപ്പോൾ നിങ്ങളുടെ മക്കളോ അല്ലെങ്കിൽ നിങ്ങൾ ആരെങ്കിലും ചോദിച്ചു കഴിഞ്ഞാൽ അതിന് മറുപടി ഞാൻ പലപ്പോഴും പറയാറുണ്ട്, നിങ്ങളോട് തന്നെ ചോദിച്ചാൽ മതി. നിങ്ങൾ ആഹാരത്തിലുണ്ടായ മാറ്റം, അതുപോലെ എക്സസൈസ് ഇല്ലായ്മ, മാനസിക സമ്മർദ്ദം കൂടുതൽ, ഈ 3 ഘടകങ്ങളാണ് പ്രധാനമായിട്ടുള്ളത്. അപ്പോൾ അത് നമ്മൾ സ്വയം തന്നെ അത് മനസ്സിലാക്കിയാൽ ഒരുപാട് ഈ ഡയബറ്റീസിൻ്റെ വരുന്നത് ഒഴിവാക്കാൻ പറ്റും. വരുന്ന ആളുകൾക്ക് ഡയബറ്റീസ് അഥവാ വന്ന ആളുകൾക്ക് അത് പെട്ടെന്ന് നിയന്ത്രിക്കാൻ പറ്റും. ആ കാര്യം മാത്രമെന്ന് എത്തിക്കൊണ്ട് ഈ ഒരു അവസരം എനിക്കിവിടെ തന്ന ഡോക്ടർ ഷാജിക്ക്, അവിടുത്തെ ഈ ടീമിനും പ്രത്യേകം നന്ദി പറഞ്ഞുകൊണ്ട് നിർത്തുന്നു. താങ്ക് യു.
നമസ്കാരം, ഞാൻ ഡോക്ടർ സുജിത് എസ് നായർ. ഈ നാട്ടുകാരൻ തന്നെയാണ്. പെരിന്തൽമണ്ണ മൗലാന ആശുപത്രിയിൽ ജോലി ചെയ്യുന്നു.
ഡോക്ടർ മോഹൻദാസ് ആണ്, രാംദാസ് ലീഗ് പെരുന്തൽമണ്ണ.
ഞാൻ ഡോക്ടർ ജി ഹരീഷ് കുമാർ, കോട്ടയം ജില്ലയിൽ പാലയിൽ IHM ഹോസ്പിറ്റൽ ഭരണങ്ങാനം ഡയബറ്റോളജിസ്റ്റും ഫിസിഷ്യനുമായിട്ട് വർക്ക് ചെയ്യുന്നു.
ഞാൻ ഡോക്ടർ അജിത് കുമാർ, തിരുവനന്തപുരത്ത് SP ഫോർട്ട് ഹോസ്പിറ്റലിൽ ഫിസിഷ്യനും ഡയബറ്റോളജിസ്റ്റായിട്ട് വർക്ക് ചെയ്യുന്നു. പിന്നെ സ്വന്തമായിട്ട് സ്ഥാപനമുണ്ട്.
ഞാൻ ഡോക്ടർ പ്രശാന്ത് ശങ്കർ, ഞാൻ പത്തനംതിട്ട ജില്ലയിൽ മുത്തൂറ്റ് ഹോസ്പിറ്റലിൽ, പത്തനംതിട്ട ടൗണിൽ മുത്തൂറ്റ് ഹോസ്പിറ്റലിൽ ഫിസിഷ്യനും ഡയബറ്റോളജിസ്റ്റായിട്ട് വർക്ക് ചെയ്യുന്നു.
ജയകൃഷ്ണൻ, തിരൂർ, ഫിസിഷ്യൻ ഡയബറ്റോളജിസ്റ്റ്.
ഇനി നിങ്ങൾക്ക് നിങ്ങളുടേതായിട്ടുള്ള എന്തെങ്കിലും ചോദ്യങ്ങൾ ചോദിക്കണമെങ്കിൽ ചോദിക്കാം. അങ്ങനെ നമുക്ക് തുടങ്ങാം.
പ്രിയമുള്ളവർ, ഇതുപോലെ ഒരു പരിപാടിയിൽ പങ്കെടുക്കാൻ കഴിഞ്ഞത് വളരെ സന്തോഷമാണ്. ഞാനൊരു ആരോഗ്യ പ്രവർത്തകനായി പ്രവർത്തിക്കുന്ന ആളാണ്. എനിക്ക് പറയാനുള്ളതും പ്രധാനമായും ഷാജി ഡോക്ടറെക്കുറിച്ചാണ്. ഞങ്ങൾ പെരിന്തൽമണ്ണയിൽ ഡയബറ്റിക് ക്ലബ് എന്ന പേരിൽ കുറേ വർഷങ്ങളായി ഈ പ്രമേഹ രോഗത്തിനെതിരായിട്ടുള്ള ബോധവൽക്കരണ പരിപാടികൾ നല്ല നിലയിൽ നടത്തി വരുന്നുണ്ട്. ഇതിൻ്റെ ഒരു റിസൾട്ട് എന്തെന്നും പറയാൻ കഴിയുന്നില്ല. ഒരു ആരോഗ്യ പ്രവർത്തകൻ എന്ന നിലയിൽ ഡോക്ടേഴ്സ് പറഞ്ഞതുപോലെ തന്നെയാണ് ഞങ്ങളും ചിന്തിക്കുക. നമ്മുടെ ലൈഫ് സ്റ്റൈൽ, പ്രത്യേകിച്ച് ഭക്ഷണം ആണ്. മലപ്പുറം ജില്ല പോലെയുള്ള ഒരു സ്ഥലത്ത് പ്രത്യേകത, ഞാൻ കോട്ടയത്ത് ജനിച്ചിട്ട് മലപ്പുറത്ത് സെറ്റിൽ ചെയ്ത് 50 വർഷമായി താമസിക്കുന്ന ആളാണ്. അപ്പോൾ ഈ 2 കൾച്ചറും എനിക്കറിയാം. ഏറ്റവും കൂടുതൽ ഭക്ഷണം കഴിക്കുന്ന ഒരു സ്ഥലമാണ്. ഷാജി ഡോക്ടർ ചില ആളുകളെങ്കിലും പിണങ്ങിപ്പോയിട്ടുണ്ട്. സാറ് OPയിലുള്ളപ്പോൾ നോക്കുന്നതും തൻ്റെ ക്ലിനിക്കൽ പേഷ്യൻറ്റിനെ നോക്കുന്നതും ഒരുപോലെയായിരുന്നു. പക്ഷേ അപ്പോഴൊക്കെ ആളുകൾ ചീത്ത പറയും. ഭക്ഷണം കഴിച്ച് ആദ്യമായി കഴിച്ച് കുഴപ്പമായിട്ട് വരുന്നവരെയൊക്കെ ചീത്ത പറയുമ്പോൾ, ഭാര്യയെ ചീത്ത പറയുമ്പോൾ ഭർത്താവ് പിണങ്ങിപ്പോയിട്ടുള്ള അനുഭവമുണ്ട്. ഷാജി ഡോക്ടറുടെ പേര് ഡോക്ടർ ഷാജി എന്നാണ് എഴുതിയിരുന്നത്. അപ്പോൾ ഞാനിടയ്ക്ക് പറയുമായിരുന്നു, ഇത് അബ്ദുൽ ഗഫൂർ എന്നൂടെ എഴുതണമെന്ന് പറഞ്ഞിട്ടുണ്ട്. ഞങ്ങൾ തമ്മിൽ അത്ര അടുപ്പമുള്ളത് കൊണ്ടാണ് കേട്ടോ ഇങ്ങനെയൊക്കെ പറയുക. അപ്പോൾ ഈ മേഖലയിൽ വലിയ ഇടപെടൽ, ബോധവൽക്കരണത്തിന് വലിയ ഇടപെടൽ, ഭക്ഷണം കഴിച്ച് കാണിച്ചു കൊടുക്കുക അടക്കം ചെയ്ത ഒരു രീതിയുണ്ട്. അപ്പോൾ എനിക്ക് നിങ്ങളോടൊക്കെ പറയാനുള്ളത്, നമ്മൾ ഈ ബോധവൽക്കരണ പരിപാടികൾ ശക്തമായി തുടരുക. ഭക്ഷണത്തിൻ്റെ പ്രശ്നങ്ങൾ, നല്ല ഭക്ഷണം കഴിക്കാൻ കിട്ടുന്നില്ല എന്നുള്ളതാണ് ഒരു പ്രശ്നം. എൻ്റെ ഒരു കാര്യം വെച്ച് കഴിഞ്ഞാൽ, നമ്മുടെ ഇറച്ചിയും മീനും മാത്രം നമ്മളൊന്ന് പരിശോധിച്ചാൽ നമുക്ക് വരുന്ന രോഗങ്ങളെക്കുറിച്ചറിയാം. അപ്പം നിങ്ങൾ ഡോക്ടേഴ്സോ അല്ലെങ്കിൽ ആരോഗ്യ പ്രവർത്തകരോ മാത്രം തീരുമാനിച്ചിട്ട് നമ്മുടെ ആരോഗ്യം സംരക്ഷിക്കാൻ കഴിയാത്ത ഒരു സ്ഥിതി നമുക്കുണ്ട്. അപ്പം റെഗുലേറ്ററി അപ്രോച്ച് നിയമപരമായി അതത് ഭരണാധികാരികളുടെ ഭാഗത്തുനിന്നും കൂടി ആളുകളെ രക്ഷിക്കാനുള്ള നടപടി എടുക്കണം. ഇപ്പം ഞാൻ ഗൾഫിലൊന്നും പോയിട്ടുള്ള ആളല്ല, പക്ഷേ ആളുകൾ എന്നോട് പറഞ്ഞിട്ടുണ്ട്, പ്രത്യേകിച്ച് ഷാജി ഡോക്ടറൊക്കെ ഇവിടുത്തെ നിയമത്തേക്കാൾ നല്ല വളരെ ശക്തമായ നിയമമാണ് നമ്മൾ പ്രദർശിക്കുന്നത്. അപ്പോൾ നമുക്ക് ചെയ്യാൻ കഴിയുന്നത് നല്ല ബോധവൽക്കരണം നടത്തിക്കൊണ്ട് നല്ല ഭക്ഷണം കഴിച്ചുകൊണ്ട്. ഷാജി ഡോക്ടർ എപ്പോഴും ഞാനിങ്ങനെ അതിശയം വിചാരിക്കും, ഷാജി ഡോക്ടറിന് പിന്നെ എല്ലാ രീതിയിലും പ്രവർത്തിക്കുന്ന ആളാണ്, പക്ഷേ ഒരു ഡോക്ടർ ഇങ്ങനെയൊക്കെ എങ്ങനെ പറയുക എന്നെനിക്ക് പലപ്പോഴും ഡോക്ടറെ കുറിച്ച് തോന്നിയിട്ടുണ്ട്. കാരണം വളരെ തുറന്നടിച്ച് കാര്യങ്ങൾ പറയും, ഒരു താല്പര്യവും കാണിക്കാതെ. എന്നിട്ടും ആളുകൾ പണങ്ങിപ്പോകുന്ന സ്ഥിതിയുണ്ട്. ഇവിടെ മലപ്പുറത്തിന് എന്താ വ്യത്യാസം എന്ന് വെച്ച് കഴിഞ്ഞാൽ, ഞാൻ 2 സുഹൃത്തുക്കളെ കൂടെ കൂട്ടിയാവുന്നു, 2-3 പേരെ കൂടെ കൂട്ടി. ഭക്ഷണം ഒഴിവാക്കാൻ ഭയങ്കര പാടാണ്. ഞങ്ങൾ കോട്ടയത്തൊക്കെ ഒരു കല്യാണത്തിന് വിളിച്ചു കഴിഞ്ഞാൽ ഒരാൾ വരണം കേട്ടോ, അല്ലെങ്കിൽ 2 ആൾ വരണം എന്നാണ് വിളിക്കുക, എല്ലാവരെയും വിളിക്കില്ല. ഇവിടെ അങ്ങനെയല്ല. ഇവിടെ ഒരു കല്യാണത്തിന് 6 പേരുള്ള, ഞങ്ങൾ കുടുംബാസൂത്രണമൊക്കെ കുറവുള്ള പ്രദേശമാണല്ലോ, 5-8 പേര് വീട്ടിലുണ്ടെങ്കിൽ 7-8 പേരുള്ള വീട്ടിൽ 7 പേര് വന്നാൽ ഈ ഗ്രഹനാഥൻ ചോദിക്കും ആ ആളെന്തി എന്ന് ചോദിക്കും. അതിങ്ങനെ കഴിക്കുന്നത് കുറച്ചൊന്നുമല്ല, ഇഷ്ടംപോലെ കൊടുക്കുവാണ്. ഞാനൊക്കെ അങ്ങനെ തിന്നിട്ടുണ്ട്. 10 കഷ്ണം കോഴിയിറച്ചി തിന്നുമായിരുന്നു.
വളരെ കറക്റ്റാണ് പറഞ്ഞത്. കാരണം ഭക്ഷണത്തിന് ഏറ്റവും കൂടുതൽ ഭയങ്കര പ്രാധാന്യം കൊടുക്കുന്ന ഒരു ജനവിഭാഗമുള്ള സ്ഥലം, ആതിഥ്യ മര്യാദ ഭയങ്കര കൂടുതലുള്ളത് കൊണ്ട് മറ്റുള്ളവരെ തീറ്റിക്കുക എന്ന് പറയുമ്പോൾ, ഇന്ന് മഞ്ഞളാംകുളി പറഞ്ഞത് തന്നെ, ഇങ്ങോട്ട് കയറി വരുമ്പോൾ ഡയബറ്റിക് ആണെന്ന് അറിഞ്ഞുകൊണ്ട് ഷാജി ഡോക്ടർ ഒരു പായസം കുടിച്ചോ എന്ന് പറയുന്നത്. കാരണം അയാളെ കുടിക്കണമെന്ന് ആഗ്രഹമുള്ളതുകൊണ്ടല്ല, മറിച്ച് എന്തെങ്കിലും ഒന്ന് പറയേണ്ടത് വെച്ചാൽ മഞ്ഞളാംകുളി മുഴിയാലി അത് കുടിച്ചില്ല, അത് വേറെ കാര്യം. ഇതിൽ പ്രധാനമായിട്ടെന്ന് വെച്ചാൽ നമ്മുടെ ഭക്ഷണത്തിന്റെ കൾച്ചർ, അതായത് നമ്മുടെ ഭക്ഷണ സംസ്കാരം മാറണം. അത് മാറാതെ നമ്മൾ ഡോക്ടർമാർ പറഞ്ഞതുകൊണ്ട് മാത്രം ഇത് മാറില്ല എന്നാണ് താങ്കൾ പറഞ്ഞതിന്റെ രത്ന ചുരുക്കം. അത് വളരെ വളരെ ഇമ്പോർട്ടൻ്റ് ആണ്. നമ്മൾ എല്ലാവരും വിചാരിക്കണം. കാരണം നമ്മൾ പലപ്പോഴും നമുക്ക് തനതായിട്ടുള്ളൊരു ഭക്ഷണ സംസ്കാരം ഉണ്ടായിരുന്നു പണ്ട്. ദാരിദ്ര്യം കൊണ്ട് ഉണ്ടായതാണോ അല്ല അങ്ങനെ ആയിരുന്നു എന്ന് അറിയില്ല. പണ്ട് നമ്മൾ ഒരുപാട് പച്ചക്കറികൾ കഴിക്കായിരുന്നു. ചോറൊക്കെ ഒരു നേരം കഴിക്കും, 2ാമത്തെ നേരം ചോറ് ചിലപ്പോൾ ഉണ്ടാവില്ല പല വീടുകളിലും. അരിഭക്ഷണം തന്നെ അടിയന്തരാവസ്ഥ കാലത്തും അരിയില്ലാത്ത കാലത്തും ഗോതമ്പ് മാത്രം കിട്ടിയിരുന്ന കാലത്ത് നമ്മൾ ഗോതമ്പിനെ പുച്ഛിക്കായിരുന്നു, ഈ അരി കിട്ടാത്തത് കൊണ്ട്. അരി അപൂർവം വീടുകളിൽ മാത്രം അവൈലബിൾ ആയിട്ടുള്ള കാര്യം ഉണ്ടായിരുന്നു. ഇന്ന് അരി വാങ്ങാത്ത വീടുകളുണ്ട്, വെറും ഗോതമ്പ് മാത്രം. കാരണം എല്ലാവരും ഡയബറ്റിക് ആണ്. അരിയേക്കാൾ നല്ലത് ഗോതമ്പാണ്. ഇനിയിപ്പോൾ അത് മാറി മറ്റു പലതുമായി മാറുന്നു. അപ്പോൾ കൾച്ചർ, അതായത് ഭക്ഷണ സംസ്കാരം മാറിക്കഴിഞ്ഞാൽ മാത്രമേ നമ്മൾക്ക് ഇതിന് ഒരു ശാശ്വതമായിട്ടുള്ളൊരു പരിഹാരം ഉണ്ടാവുള്ളൂ. അത് ഡോക്ടർമാരെ കൊണ്ടും ഒന്നും മാത്രം നടക്കുന്ന കാര്യമല്ല. നമ്മളെല്ലാവരും ഒത്തുപിടിച്ച് ഭക്ഷണ സംസ്കാരം മാറ്റാൻ വേണ്ടി ഭക്ഷണത്തിനെ കുറിച്ച് ഉള്ള സെമിനാറുകൾ ഇതേപോലെ സംഘടിപ്പിക്കണം. അപ്പോൾ അത് ശരിയാവും എന്നാണ് എനിക്ക് പറയാനുള്ളത്. എന്തെങ്കിലും പറയാനുണ്ടോ?
രണ്ടാമത്തെ ഒരു ഭാഗം കൂടെ പറയുന്നത്, ഞാൻ ആദ്യ ഭാഗം പറഞ്ഞു. 2ാമത്തെ ഭാഗം മലപ്പുറത്തിൻ്റെ ഒരു പ്രത്യേകത, പണ്ടത്തെ നിന്ന് വ്യത്യസ്തമായി കാർഷിക മേഖലയിൽ വലിയ ഇടപെടലുണ്ട്. വീട്ടുമുറ്റത്തെ കൃഷി കാര്യങ്ങൾ ചെയ്യുന്നുണ്ട്. അപ്പോൾ ഈ കാര്യം, ഈ ഭക്ഷണ രീതിയിലുള്ള അപകടം തിരിച്ചറിഞ്ഞിട്ടുണ്ട്. ഇനി അതിലേക്ക്, ആ ട്രാക്കിലേക്ക് ജനങ്ങൾ മാറ്റിയെടുക്കുക എന്നുള്ള നമ്മുടെ എല്ലാവരുടെയും കൂട്ടായ ശ്രമമാണ് ഇതിൽ.
വളരെ നന്ദി. താങ്ക് യു. താങ്ക്സ് എ ലോട്ട്. അടുത്ത ആൾക്കെന്തെങ്കിലും പറയാനുണ്ടോ? മൈക്കിനെ അടുത്ത് വേണ്ടവർ ചോദിച്ചു വാങ്ങുക. ഇത് പ്രധാനമായിട്ടും നമ്മൾ പ്രമേഹ രോഗത്തിനെ കുറിച്ച് നിങ്ങളുടെ മനസ്സിലുള്ള സംശയങ്ങളുണ്ടാവും. ആ സംശയം നിങ്ങൾ ചോദിക്കണം. അത് സ്പെസിഫിക് ആയിട്ട് ചോദിക്കുക. അതിനെക്കുറിച്ച് അതായിരിക്കും അതിനുവേണ്ടി ഈ മാക്സിമം ഇത്, കാരണം ഇനിയിപ്പോൾ ഉണ്ടാവുന്നത് പരമാവധി 1 മണിക്കൂറാണ് ഉണ്ടാവുക. അപ്പോൾ 1 മണിക്കൂറിനുള്ളിൽ പരമാവധി ഈ സംശയ നിവാരണം നടത്താൻ വേണ്ടി നിങ്ങൾ ശ്രമിക്കണം. അതൊന്ന്, കാരണം എല്ലാവരും തിരുവനന്തപുരം വരെ എത്തേണ്ടവരാണ്. പലർക്കും ട്രെയിനിനും അതിനായിട്ട് പല വിധത്തിലും പോകേണ്ടതുള്ളത് കൊണ്ട് 1 മണിക്കൂറിനുള്ളിൽ ഇത് തീർക്കേണ്ടതായതുകൊണ്ടാണ് ഞാൻ പറയുന്നത്.
ഈ പ്രമേഹ രോഗം പാരമ്പര്യമായിട്ട് ഉണ്ടാവുന്നതാണോ, അതല്ല ഭക്ഷണ രീതിയിൽ നിന്നുണ്ടാവുന്നതാണോ, അതല്ല ടെൻഷൻ കൊണ്ടുണ്ടാവുന്നതാണോ, ഏത് കാര്യം കൊണ്ടാണോ ഉണ്ടാവുന്നതെന്നുള്ളത്
ആയിട്ടുള്ളൊരു ചോദ്യമാണ്. ആർക്കാ ആൻസർ ചെയ്യുന്നത്?
ഇത് 2 കാര്യം. ഒന്ന്, അദ്ദേഹം പറഞ്ഞ ആദ്യത്തെ അതിനോട് മറുപടി പറഞ്ഞിട്ട് ഇരുന്നുള്ളുണ്ട്. അതിനെ ശരിക്കും ഈ ഡയബറ്റീസ് ക്ലബ്ബ് പ്രത്യേകിച്ചും ഡോക്ടർ ഷാജിയുടെ നേതൃത്വത്തിലൂടെ തുടങ്ങിയെന്നുള്ളത് വളരെ ശ്ലാഘനീയമായ ഒരു കാര്യമാണ്. ശരിക്കും പറഞ്ഞാൽ അതിന് സാർ മുൻകൈ എടുത്ത്, ഡോക്ടർ ഷാജിയും മുൻകൈ എടുത്ത് അത് മുമ്പോട്ട് കൊണ്ടുപോകണം. ഏറ്റവും പ്രധാനപ്പെട്ട കാര്യം ശരിക്കും പറഞ്ഞാൽ അതാണ്. ട്രീറ്റ്മെൻറ്റിൻ്റെ കാര്യത്തിൽ ഡോക്ടർക്ക് ചെയ്യുന്നതിനേക്കാൾ വളരെ കൂടുതൽ ആ ക്ലബിന് ചെയ്യാൻ പറ്റും. തീർച്ചയായിട്ടും അതിന് ഡയബറ്റീസിനെ കുറിച്ചുള്ള, പ്രത്യേകിച്ച് ഇങ്ങനെയുള്ള കാര്യങ്ങളെക്കുറിച്ചുള്ള, ഭക്ഷണത്തെക്കുറിച്ചൊക്കെ ഉള്ള സെമിനാറുകൾ നടത്തണം. അത് വളരെ നല്ല കാര്യമാണ്. പിന്നെ അങ്ങ് ചോദിച്ച ചോദ്യം, പിന്നെ അതുപോലെ തന്നെ അതിൻ്റെ 2ാമത്തെ ഭാഗത്തിലെ ആ പച്ചക്കറികളുടെ കാര്യത്തിൽ ശരിക്കും പറഞ്ഞാൽ ഞാനൊക്കെ ഒരു 10-15 വർഷം മുമ്പ് ഡയബറ്റീസ് ക്ലിനിക്കിൻ്റെ കൂട്ടത്തിൽ പച്ചക്കറി വിത്ത് വിതരണം ചെയ്യുമായിരുന്നു. വീട്ടിനകത്ത് പച്ചക്കറി കൃഷി ചെയ്യണമെന്ന്. അപ്പോൾ കൃഷി ചെയ്യുമ്പോൾ ഉള്ള ഗുണമെന്ന് വെച്ച് കഴിഞ്ഞാൽ പച്ചക്കറി കിട്ടും, രണ്ടാമത് കുറച്ച് അധ്വാനവും കിട്ടും. അത് രണ്ടും വളരെ പ്രധാനപ്പെട്ട കാര്യമാണ്. ആ നേതൃത്വം മുമ്പോട്ട് തന്നെ പോകണം. പിന്നെ ഈ 3 ചോദ്യം ചോദിച്ചു. ശരിക്കും പറഞ്ഞാൽ പാരമ്പര്യമാണോ, ആഹാരം കൊണ്ടാണോ, മാനസിക സമ്മർദ്ദം കൊണ്ടാണോ? 3ഉം ഇതിന് ഘടകങ്ങളാണ്. ഈ 3 ഘടകങ്ങൾ കൊണ്ട് ഡയബറ്റീസ് കൂടുന്നതിൽ ഭക്ഷണത്തിൻ്റെ രീതി മാറി. ഭക്ഷണത്തിൻ്റെ രീതി ദിവസം രാവിലെ മുതൽ വൈകിട്ട് വരെ ഇപ്പോൾ കളിക്കുന്ന ഒരാൾക്ക് മാനുവൽ ലേബർക്ക് ഭക്ഷണം കുറച്ച് കൂടുതൽ കഴിക്കാം, അത് കുഴപ്പമില്ല. പക്ഷേ നമ്മൾ വെറുതെ ഇരുന്നിട്ടാണ് ഭക്ഷണം കഴിക്കുന്നത്, അതാണ് പ്രശ്നം. ഈ ഭക്ഷണത്തിൻ്റെ അളവ് കൂടിയത് തന്നെയല്ല, ഭക്ഷണത്തിൻ്റെ അളവ് കൂടുകയും അതുപോലെ തന്നെ കലോറി കൂടിയ ഭക്ഷണം എന്ന് പറയും. നമ്മൾ പണ്ടൊക്കെ പച്ചക്കറികളൊക്കെ വീട്ടിലുണ്ടാകുന്ന പച്ചക്കറി അല്ലെങ്കിൽ അടുത്ത് കിട്ടുന്ന പച്ചക്കറികളാണ് കഴിച്ചാണ്. ഇപ്പോൾ നമ്മൾ ഫാസ്റ്റ് ഫുഡ്, ബേക്കറി സാധനങ്ങൾ ഉള്ള ഭക്ഷണ സാധനങ്ങൾ, ബേക്കറി സാധനങ്ങൾ അങ്ങനെയുള്ള കൂടെയല്ല കഴിക്കുന്നത്, അത് കലോറി കൂടിയ ഭക്ഷണമാണ്. അപ്പോൾ കലോറി കൂടിയ ഭക്ഷണം കഴിക്കുന്നു, അതോടൊപ്പം തന്നെ നമ്മൾ എക്സസൈസ് ചെയ്യുന്നില്ല, മാനസിക സമ്മർദ്ദം കൂടുന്നു. ഈ 3 ഘടകങ്ങളുണ്ട്. അതോടൊപ്പം തന്നെ പാരമ്പര്യം ഒരു ചെറിയ ഘടകമാണ്, ഇല്ലെന്ന് പറയാൻ പറ്റില്ല. പാരമ്പര്യം ഒരു അച്ഛനും അമ്മയ്ക്കും പ്രമേഹം ഉണ്ടെങ്കിൽ മക്കൾക്ക് വരാനുള്ളൊരു സാധ്യത ഏതാണ്ട് ഒരു 40% ഉണ്ട്, 2 മക്കൾക്കുണ്ട്. പക്ഷേ അത് വരുന്നത് ആദ്യമേ തന്നെ, ഇപ്പോൾ അച്ഛനും അമ്മയ്ക്കും പ്രമേഹമുണ്ട്, മക്കൾക്ക് പ്രമേഹം വരാതിരിക്കണമെങ്കിൽ അവർക്കൊരു പ്രായപൂർത്തിയാവുന്ന ആ സമയം മുതൽ തന്നെ കുറേയൊക്കെ ശ്രദ്ധിച്ചാൽ പറ്റും. അതായത് അമിതമായിട്ട് വണ്ണം വരാതെ നോക്കുക, നമ്മുടെയൊക്കെ മക്കൾക്ക് വണ്ണം കൂടുതൽ വരാതെ നോക്കുക. രണ്ടാമത് അവരെ കൊണ്ട് സ്ഥിരമായിട്ട് എക്സസൈസ് ചെയ്യണമെന്ന് പറയുക. പിന്നെ അവർക്ക് ഇഷ്ടമുള്ള ഭക്ഷണ സാധനങ്ങൾ എന്ന് പറയുന്നത് നമുക്കൊരു അതിനെക്കുറിച്ച് ധാരണ ഉണ്ടാക്കിയിട്ട് ചില ഭക്ഷണ സാധനങ്ങൾ നമുക്കൊരു ഡിനേ ചെയ്യണം. ഭക്ഷണ സാധനത്തിൻ്റെ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അത് ശരിക്കും ഞാൻ എൻ്റെ ഒരു അനുഭവത്തിൽ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ രുചിക്ക് വേണ്ടിയാണ് നമ്മൾ ഈ പോകുന്നത് കൂടുതലും. അത് ഒരു ഹാബിറ്റാണത്. നമുക്കിപ്പോൾ ഒരു സാധനം ഉപ്പില്ലാതെ കഴിക്കാൻ ഒരു 6 മാസം ഉപ്പില്ലാതെ കഴിച്ചു കഴിഞ്ഞാൽ പിന്നെ ഉപ്പ് ചേർക്കുന്നതായിരിക്കും ബുദ്ധിമുട്ട്. ഇപ്പം ഞാൻ ഉപ്പ് തീരെ കഴിക്കാത്ത കൂട്ടത്തിലാണ്, വളരെ കുറച്ചൊരു, എനിക്ക് താല്പര്യം പണ്ട് പോലെ ഇല്ലായിരുന്നു. പക്ഷേ അതിപ്പോൾ എനിക്ക് ഉപ്പിടുന്നതാണ്. പക്ഷേ അക്കെല്ലാം കൂടി ഉപ്പിട്ട് എവിടെയെങ്കിലും കഴിച്ചു കഴിഞ്ഞാൽ എനിക്ക് കഴിക്കാൻ ബുദ്ധിമുട്ടാണ്. അതൊരു ഹാബിറ്റാണ്, അതൊരു നമ്മൾ ശീലമാക്കണം. അത് ഡയബറ്റീസ് ഡോക്ടർ പറഞ്ഞു തരുന്ന ആഹാരത്തിൻ്റെ രീതി നമുക്ക് ആദ്യം അത്ര പിടിച്ചൊന്നും വരത്തില്ല. പക്ഷേ ഒരു 6 മാസം അല്ലെങ്കിൽ ഒരു 3 മാസം കൃത്യമായിട്ട് ആഹാരം ആ ഒരു രീതിയിൽ പോയി കഴിഞ്ഞാൽ പിന്നെ നമുക്കത് മതിയാവും. ക്വാണ്ടിറ്റി ആയാലും ഏത് ടൈപ്പ് ആഹാരമായാലും അതാണ് പ്രധാനപ്പെട്ട കാര്യം. അതെനിക്ക് മറുപടി ആയി തോന്നുന്നു.
സാറേ, ഈ പ്രസവിച്ച കുട്ടിക്ക് ഈ ഷുഗർ ഉണ്ടാകുന്നത് എന്തുകൊണ്ടാണ്? പ്രസവിച്ചിട്ട് 40 കഴിയുന്ന ഒരു കുട്ടിക്ക് ഇപ്പോൾ ഷുഗർ ഉണ്ടാകുന്നുണ്ട്. പിന്നെ കുട്ടികൾക്ക് ഷുഗർ ഉണ്ടാവുക എന്ന് പറഞ്ഞാൽ വീട്ടിൽ ഇപ്പം നിങ്ങളെ കുട്ടികളായാലും എൻ്റെ കുട്ടികളായാലും ഈ കുട്ടികൾക്ക് നമ്മൾ ഇഷ്ടമുള്ള ഭക്ഷണം കൊടുക്കാൻ കുട്ടികൾ ഭക്ഷണം കഴിക്കില്ല. അപ്പോൾ ആ കുട്ടി എന്താ പറയുന്നത് കൊണ്ടേ കൊടുക്കുകയാണ് ഇന്നത്തെ രക്ഷിതാക്കന്മാർ കൂടുതലും ചെയ്യുന്നത്.
അത് ഒരു ഘടകമാണ്. ശരിക്കും ഈ ആദ്യം ചോദിച്ച ചോദ്യം ഈ ജനിച്ച ഉടനെ വരുന്നത്, ഞങ്ങൾ അതിനെക്കുറിച്ച് ഇന്ന് രാവിലെ ഒരു സെമിനാറിൽ ചെന്നൈയിൽ നിന്ന് ഒരു ഡോക്ടർ വളരെ അപൂർവമായൊരു കാര്യമാണ്. അത് പല കാരണങ്ങളും ഉണ്ട്. അതിനെക്കുറിച്ച് വളരെ അപൂർവമായിട്ടൊരു കാര്യമാണ്. പിന്നെ പാരമ്പര്യമായിട്ടൊന്നും വരുന്നതല്ല, ചില ജീൻസിനകത്തുള്ള ചില മാറ്റങ്ങൾ വരുന്നതുകൊണ്ടാണ്. അതിനെക്കുറിച്ച് നമ്മൾ, കാരണം നമുക്കത് ഒരു 1,00,000 ഒരാൾക്ക് അങ്ങനെയൊക്കെ വരുന്നുള്ളൂ. അതുകൊണ്ട് അതിനെക്കുറിച്ച് നമ്മൾ ഒരുപാട് അറിയേണ്ട കാര്യമില്ല. പക്ഷേ ഈ ആഹാര സാധനങ്ങൾ കുട്ടികൾക്ക് കൊടുക്കുന്നത് അത് നമ്മൾ ശീലിപ്പിക്കുന്ന പോലെ ഇരിക്കും. ചില ആഹാരങ്ങൾ കലോറി കൂടുതലുള്ള ആഹാര സാധനങ്ങൾ കൊടുക്കരുത്. പ്രത്യേകിച്ച് വെയിറ്റ് മെയിൻറ്റെയിൻ ചെയ്യുന്ന കാര്യം. വെയിറ്റ് കൂടുതൽ പോഷണിച്ച ശരീരം ഉള്ളവരാണെങ്കിൽ അത് വെയിറ്റ് കൂടാതിരിക്കാനായിട്ട് നമ്മളൊരു ശ്രദ്ധിക്കണം. അത് ഈ കുട്ടികളിൽ ആഹാരത്തിൻ്റെ ആ താല്പര്യവും ചിലതൊക്കെ കൊടുക്കണ്ട എന്ന് ഡിനേ ചെയ്ത് കഴിഞ്ഞാൽ അത് ഒഴിവാക്കാൻ പറ്റണം. അതാണ്. അല്ലെങ്കിൽ അവർക്ക് രോഗം വരാനുള്ളൊരു സാധ്യത നമ്മൾ കൂട്ടുകയാണ്. നമ്മൾ അറിഞ്ഞുകൊണ്ടതിന് കൂടുതൽ നിൽക്കുകയാണെന്നുള്ളൊരു വസ്തുതയുണ്ട്. അത് നമ്മൾ ശ്രദ്ധിക്കുന്നത് പോലെ ഇരിക്കുന്നതാണ് എനിക്ക് പറയാനുള്ളത്. അല്ലേ സുരേഷ്?
താങ്ക് യു സർ.
ഹലോ സർ, ഞാൻ ഷാജി ഡോക്ടർ പേഷ്യൻ്റാണ്. അദ്ദേഹം പലപ്പോഴും പറയാൻ ടെൻഷൻ കൊണ്ടാണ് ഈ ഷുഗർ കൂടുന്നത്, പലപ്പോഴും ഉണ്ടാവാറുണ്ട്. BP അങ്ങ് കൂടുന്നത് കേട്ടിട്ടുണ്ട്. പക്ഷേ ടെൻഷൻ കൊണ്ട് ഷുഗർ കൂടാൻ സാധ്യതയുണ്ടോ കൂടുതലായിട്ട്?
ഇരുന്നോളൂ സാർ, ഇരുന്നോളൂ. അതായത് നേരത്തെ സാറ് ചോദിച്ച ചോദ്യത്തിൽ അതുണ്ടായിരുന്നു, സ്ട്രെസ്സ് കാരണം അല്ലെങ്കിൽ മാനസിക സമ്മർദ്ദം കാരണം നമുക്ക് ഡയബറ്റിസ് ഉണ്ടോ എന്നുള്ളത്. സത്യത്തിലുണ്ട്. നമുക്ക് ശരീരത്തിൽ ഈ പറയുന്ന മാനസിക സമ്മർദ്ദം അധികമായിട്ട് വരുന്ന അവസരങ്ങളിൽ ശരീരത്തിലുണ്ടാകുന്ന ചില വ്യത്യാസങ്ങളെന്ന് പറയുന്നത് ഹോർമോണുകൾ ഉൾപ്പെടെയുള്ള പ്രവർത്തനം കൊണ്ട് താൽക്കാലികമായി ഉണ്ടാകുന്ന ഷുഗർ കൂടുന്ന അവസ്ഥയുണ്ട്. അത് ഈ സ്ട്രെസ് ഡയബറ്റിസ് എന്ന് തന്നെ നമ്മൾ പറയുന്ന തരത്തിലുള്ളതുണ്ട്. നേരെ മറിച്ച് ചികിത്സയിൽ ഇരിക്കുന്നവർക്കും ഈ കൂട്ടത്തിൽ നമുക്ക് എല്ലാവർക്കും സ്ട്രെസ് ഉണ്ട്, അല്ലേ? അത് വീട്ടിലെ സംഭവങ്ങളായിരിക്കാം, അല്ലെങ്കിൽ ജോലി സ്ഥലത്തെ മറ്റ് സ്ട്രെസ് ആയിരിക്കാം, ഭാര്യയും ഭർത്താവും തമ്മിലുള്ള എന്തെങ്കിലും ഉള്ളൊരു ഇഷ്യൂ ആയിരിക്കാം, പല പ്രശ്നങ്ങളായിരിക്കാം. അത്തരം സ്ട്രെസ്സുകൾ ട്രീറ്റ്മെൻറ്റിൽ ഇരിക്കുന്ന രോഗികൾക്കും ഷുഗർ നിയന്ത്രണമില്ലാതെ ഉയരാൻ കാരണമാകാറുണ്ട്. അപ്പോൾ ഇന്ന് നേരത്തെ പറഞ്ഞതുപോലെ നേരത്തെ ഉച്ചവരെ നടന്ന സെമിനാറിൽ ഞാൻ പ്രസൻറ്റ് ചെയ്ത ടോപ്പിക് എന്ന് പറയുന്നത് നമുക്ക് ഷുഗർ ചികിത്സയിലിരിക്കുന്നവർക്ക് രക്തപരിശോധന നടത്തുന്നതിനെക്കുറിച്ചും മറ്റ് പരിശോധനകൾ നടത്തുന്നതിനെക്കുറിച്ചുമാണ്. അപ്പോൾ സാധാരണ പ്രമേഹ ചികിത്സയിലിരിക്കുന്ന വ്യക്തികളെ പരിശോധിക്കാൻ പറയുന്ന കാര്യങ്ങളിൽ ഉൾപ്പെടുന്നതാണ് വീട്ടിൽ തന്നെ നമുക്ക് ഗ്ലൂക്കോമീറ്ററിൻ്റെ സഹായത്തോടു കൂടി വിരൽത്തുമ്പിൽ നോക്കാൻ പറ്റുന്ന പരിശോധന. അപ്പോൾ ആ പരിശോധന എന്ന് പറയുന്നത് ഷുഗറിൻ്റെ അപ്പോഴത്തെ ഒരവസ്ഥ മനസ്സിലാക്കാൻ പറ്റുന്നതാണ്. പ്രമേഹം ചികിത്സിക്കുന്ന എത്ര പേര് ഈ കൂട്ടത്തിലുണ്ടോ അവരെല്ലാവരും അറിഞ്ഞിരിക്കേണ്ട കാര്യം രക്തത്തിലെ പഞ്ചസാര എന്ന് പറയുന്ന ഉയർന്നും താഴ്ന്നു പോയിക്കൊണ്ടിരിക്കുന്ന ഒരവസ്ഥയാണ്. ഒരു വാല്യൂവിനെ വെച്ചിട്ടല്ല നമ്മളത് തീരുമാനിക്കുന്നത്. അപ്പോൾ ഇപ്പോൾ ഉള്ള പരിശോധന മാർഗങ്ങളിൽ ഏറ്റവും പുതുതായിട്ട് വന്നിരിക്കുന്ന പരിശോധന മാർഗങ്ങളിലുള്ളതാണ് കയ്യിൽ സെൻസർ, ചെറിയൊരു സെൻസർ ഉപയോഗിച്ച് രക്തത്തിലെ പഞ്ചസാരയുടെ ഉയർച്ചയും താഴ്ചയും അറിയുന്നത്. ഈ പറഞ്ഞ പരിശോധനയെ പറ്റി പറയാൻ കാരണം ഞങ്ങളുടെ സെൻറ്ററിൽ തന്നെ ചികിത്സയിലിരിക്കുന്ന പല രോഗികളുടെയും ഇത്തരം പരിശോധനകൾ ചെയ്യുന്ന സമയത്ത് ഒരു രോഗിക്കുണ്ടായ ഒരു അനുഭവം കൂടെ പറയാൻ വേണ്ടിയിട്ടാണ്. അതായത് ഒരു 65-70 വയസ്സ് പ്രായമുള്ള സ്ത്രീയാണ്. ചികിത്സ നല്ലോണം പോകുന്ന ഒരു അവസരത്തിൽ ഈ പറയുന്ന സെൻസർ 14 ദിവസം നമ്മൾ ഉപയോഗിക്കുന്ന സെൻസറിൽ 24 മണിക്കൂറത്തെയും ഷുഗറിൻ്റെ വ്യത്യാസം അറിയാൻ പറ്റുന്ന ടെസ്റ്റാണ്. അപ്പോൾ ആ ടെസ്റ്റ് ചെയ്തതിൻ്റെ റിസൾട്ട് കിട്ടിയപ്പോൾ അതിൻ്റെ ഗ്രാഫ് നമുക്ക് രോഗികൾക്ക് പോലും കൃത്യമായി മനസ്സിലാക്കാൻ പറ്റുന്ന തരത്തിലുള്ളതാണ്. അപ്പോൾ ആ ഗ്രാഫ് കിട്ടിക്കഴിഞ്ഞാൽ ഭക്ഷണ ക്രമീകരണത്തിലെ മാറ്റം എന്താവണം, മരുന്നുകളുടെ മാറ്റം എന്തായിരിക്കണം എന്നുള്ളതെല്ലാം തീരുമാനിക്കാൻ പറ്റും. ഈ ഒരു വ്യക്തിയുടെ ഗ്രാഫ് കണ്ടപ്പോൾ വൈകുന്നേരം 6 മണി മുതൽ ഏകദേശം 5:30-6 മണി മുതൽ 10-11 മണി വരെയുള്ള സമയത്തെ ഷുഗർ എന്ന് പറയുന്നത് 300-400 തന്നെ ഇങ്ങനെ നിൽക്കുകയാണ്. അപ്പം എത്ര ഞങ്ങളുടെ സംഘത്തിലുള്ള എല്ലാവരും ശ്രമിച്ചിട്ടും ഇതിന് കാരണം എന്താണെന്ന് കണ്ടുപിടിക്കാൻ പറ്റിയില്ല. ഒരു കാരണവും ഇല്ല. അപ്പോഴും ഭക്ഷണമൊന്നും അങ്ങനെ കൂടുതൽ കഴിക്കുന്നൊന്നുമില്ല. വളരെ നല്ലൊരു രീതിയിൽ തന്നെ ഭക്ഷണ ക്രമീകരണം കൊണ്ടുപോകുന്ന ഒരു രോഗിയുടെ കാര്യമാണ് ഞാൻ പറയുന്നത്. പക്ഷേ ഈ സമയത്ത് ഷുഗർ കുറയുന്നില്ല. ചോദിച്ച് അവസാനം മനസ്സിലാക്കിയ കാര്യം ആ സമയത്ത് ഈ പറയുന്ന വ്യക്തി TV സീരിയൽ കണ്ടുകൊണ്ടിരിക്കുകയാണ്. അത് ഉണ്ടാക്കിയ മാനസിക സമ്മർദ്ദം കൊണ്ട് ഷുഗർ കൂടി നിൽക്കുന്നു എന്ന് പറയുന്നത്. അപ്പോൾ ചികിത്സയിൽ വേറെ മാറ്റമൊന്നും വരുത്തേണ്ടി വന്നില്ല, TV അണച്ചു വെക്കുക എന്നുള്ളതാണ് പറഞ്ഞത്. അതുകൊണ്ട് സമ്മർദ്ദം, നമുക്ക് മാനസിക സമ്മർദ്ദം എന്ന് പറയുന്നത് രക്തത്തിൻ്റെ പഞ്ചസാരയുടെ നില കൂട്ടാനും രക്തസമ്മർദ്ദം കൂട്ടാനും കാരണമാകുന്നു.
ഇനി എന്തെങ്കിലും സംശയമുണ്ടോ? ഏതെങ്കിലും സംശയങ്ങൾ ഉണ്ടെങ്കിൽ ആരെങ്കിലും ചോദിക്കും. എന്തെങ്കിലും തരത്തിലുള്ള സംശയങ്ങൾ. കാരണം ഇതിപ്പം ബേസിക്കലി ഉദാഹരണത്തിന് മരുന്ന് എപ്പോഴാണ് കഴിക്കേണ്ടത്, ഭക്ഷണത്തിന് മുമ്പ് കഴിക്കണോ പിമ്പ് കഴിക്കണോ?
സാധാരണ രോഗികൾക്കുള്ളൊരു സംശയങ്ങൾ വരുന്നത്, എൻ്റെ ഈ മരുന്നുകൾ കിഡ്നിയെ ബാധിക്കൂ? അത് സാധാരണ എല്ലാവർക്കും ഉള്ള സംശയങ്ങളാണ്.
ഈ പ്രമേഹ രോഗികൾ കഴിക്കേണ്ട മരുന്ന് ഭക്ഷണത്തിൻ്റെ മുമ്പോ ഭക്ഷണത്തിൻ്റെ ശേഷം?
അല്ലെ, പല മരുന്നുകളും പല രീതിയിലാണ് അത് പ്രവർത്തിക്കുന്നത്. ചില മരുന്നുകൾ ഭക്ഷണത്തിന് മുമ്പ് കഴിക്കേണ്ടതുണ്ട്, ചില മരുന്നുകൾ ഭക്ഷണത്തിന് ശേഷം കഴിക്കുന്നുണ്ട്. ചില ഇൻസുലിനാണെങ്കിൽ ഭക്ഷണത്തിന് അരമണിക്കൂർ മുമ്പ് എടുക്കണം. അപ്പം അങ്ങനെയാണ്. അതുപോലെ അതാണ്. അപ്പം അതിനുള്ള വ്യത്യാസങ്ങളുണ്ട്. നമ്മളിപ്പോൾ അത് കറക്റ്റായിട്ട് നമ്മൾക്ക് അതിനെ പോലെ ചെയ്തിട്ടില്ലെങ്കിൽ ചിലപ്പം വളരെ ക്ഷീണമുള്ള രോഗിക്കോ അല്ലെങ്കിൽ ആഹാരം വളരെ കുറച്ച് കഴിക്കുന്ന ആഹാരം ചിലപ്പോൾ ആഹാരം കഴിഞ്ഞ ശേഷം നമുക്ക് ചിലപ്പോൾ കൊടുക്കാൻ പറ്റുള്ളൂ. അപ്പോൾ അത് ആഹാരം എത്രയാണ് കഴിക്കുന്നതനുസരിച്ച് ചിലപ്പോൾ കുറച്ച് പ്രായമുള്ള രോഗികൾ ചിലപ്പം നമ്മൾ ഇൻസുലിൻ കൂടുതലെടുത്ത് ആഹാരം വളരെ കുറച്ചാണ് കഴിക്കുന്നതെങ്കിൽ ചിലപ്പോൾ കുറഞ്ഞു പോകും. അപ്പോൾ അതുകൊണ്ട് അങ്ങനെ ഒരു പ്രായം മുതിർന്ന അവർക്ക് കുറച്ച് വ്യത്യാസം വരുത്തേണ്ടി വരും.
അപ്പോൾ എനിക്ക് സാജു ഡോക്ടറോടാണ് ചോദിക്കേണ്ടത്. അയാൾ പേഷ്യൻ്റാണ് ഞാൻ. അയാൾ എനിക്ക് തന്നിരിക്കുന്നത് ടാബ്ലറ്റ് എഴുതിയിരിക്കുന്നത്. അപ്പം ഞാൻ ആ ഗുളിക ഭക്ഷണം കഴിച്ചതിൻ്റെ ശേഷമാണ് കഴിക്കുന്നത്. അപ്പോൾ അവിടെ ഹോസ്പിറ്റലിൽ ചെല്ലുമ്പോൾ ഞങ്ങൾ അതിനോട് വേറെ എന്തെങ്കിലുമൊക്കെ പറഞ്ഞങ്ങാണ്ട് ചൂടാവും. അപ്പോൾ പിന്നെ ഇപ്പോൾ ചാൻസ് കിട്ടിയതാണ് എനിക്ക് പറയാനുള്ളത്.
അല്ല, നിങ്ങൾ എന്നെ തന്നെയല്ലേ കാണിക്കാൻ വരുന്നത്.
ഇതിലെന്താണെന്നറിയും, നമ്മൾ ചില കാര്യങ്ങൾ ചെയ്യുമ്പോൾ ഞാൻ പറഞ്ഞ ഭക്ഷണത്തിന് മുമ്പ് കഴിക്കുക പിമ്പ് കഴിക്കുക എന്ന് പറയും. ചിലർ അതിനെന്താ പിന്നെ കഴിച്ചാൽ നമ്മൾ കുളിക്കുകയും തോർത്തും ചെയ്യാറുണ്ടല്ലോ. കുളിക്കുകയും തോർത്തും രണ്ടും ചെയ്യാറുണ്ട്. തോർത്തി കഴിഞ്ഞിട്ട് കുളിച്ചാൽ എന്തെങ്കിലും കുഴപ്പമുണ്ടോ? അതുപോലെയാണ് മരുന്നിന്റെ കാര്യം. അത് ചില കാര്യങ്ങൾ ഭക്ഷണത്തിന് മുമ്പ് കഴിക്കേണ്ടതുണ്ട്. അത് അപ്പം കഴിച്ചാലേ അതുകൊണ്ട് കാര്യം ഉണ്ടാവും. കുളിച്ച് കഴിഞ്ഞിട്ട് തോർത്തുന്ന പോലെ നമ്മൾ കുളിക്കാതെ തോർത്തിയിട്ട് പോയി കുളിച്ച് ഞാൻ രണ്ടും ചെയ്തു എന്ന് പറഞ്ഞിട്ട് കാര്യമില്ല. അതിന് ഒരു ഫലം ഉണ്ടാവില്ല. അതുപോലെ ആ മരുന്ന് കഴിക്കുന്ന സമയത്ത് ഭക്ഷണത്തിന് മുമ്പ് അരമണിക്കൂർ മുമ്പ് ഡോക്ടർ കഴിക്കണമെന്ന് പറഞ്ഞത് അങ്ങനെ കഴിച്ചാലേ ഗുണം ഉണ്ടാവുള്ളൂ. അങ്ങനെ കഴിക്കാതെ നിങ്ങൾ ചെന്നിട്ട് പിന്നെ ഷുഗർ നോക്കുമ്പോൾ ഷുഗർ കൂടിയാൽ ഡോക്ടർ നിങ്ങൾ പറഞ്ഞ മരുന്നോ കഴിച്ചു എനിക്കൊരു ഗുണമില്ലല്ലോ എന്ന് പറഞ്ഞിട്ട് ഒരു കാര്യമില്ല. അതാണ് അതിൻ്റെ ചുരുക്കം.
പിന്നെ സ്വയം ഷുഗർ ചെക്ക് ചെയ്യുമ്പോൾ അതങ്ങനെ ഒരാഴ്ചയിലോ അല്ലെങ്കിൽ 15 ദിവസമോ അപ്പോൾ ഇതിന് കൺട്രോളിങ് നിർത്താൻ പറ്റുന്ന വല്ല ടാബ്ലറ്റിങ്ങിൽ വല്ല കൺട്രോളിങ്ങിന് വല്ല പോകാൻ പറ്റുന്ന വല്ല സംവിധാനം വല്ലതുണ്ടോ? ഷുഗർ നമുക്കിപ്പോൾ ഇങ്ങനെ ചില സമയങ്ങളിൽ ഭക്ഷണം കഴിച്ചാൽ കൂടും, ചില സമയങ്ങളിൽ ചെക്ക് ചെയ്യുമ്പോൾ കുറയും. അപ്പോൾ എപ്പോൾ നോക്കുമ്പോഴും നമ്മൾ ഭക്ഷണം നമ്മൾ കഴിക്കുന്നത് ഏതാനും ഒരേ ലെവലായിരിക്കും. ഇപ്പോൾ ചക്ക ആയപ്പോൾ അങ്ങ് മാങ്ങ ആയപ്പോഴൊക്കെ ചിലപ്പോൾ ഒരു പീസൊക്കെ കഴിച്ചു കഴിയും, ചിലപ്പം അതുണ്ടാവും. ചില സമയങ്ങളിൽ നമ്മൾ ഷുഗർ ചെക്ക് ചെയ്യുമ്പോൾ അപ്പോൾ ഞാൻ പറഞ്ഞ മാതിരി ചിലപ്പം ടെൻഷൻ കൊണ്ടാവാം എന്നുള്ള ടെൻഷനൊന്നുമില്ലാതെ ഫ്രീ ആയിരിക്കുന്ന സമയത്തും സ്വാഭാവികമായിട്ട് ഷുഗർ ഇങ്ങനെ. അപ്പോൾ ഷുഗർ കൺട്രോളിങ്ങിന് വല്ല ടാബ്ലറ്റ് വല്ലതുണ്ടോ? അതല്ല ഈ പിന്നെ സാധാരണ കുടിക്കുന്ന ആ ടാബ്ലറ്റ് മാത്രമേ ഉള്ളൂ ഷുഗർ. കാരണം വിദേശത്തു നിന്ന് എനിക്ക് തന്നിരുന്നു ഒരു ടാബ്ലറ്റ് തന്നിരുന്നു. ഷുഗർ ഡെയിലി ഓരോ ഷുഗർ ഒരു ടാബ്ലറ്റ് കഴിച്ചാൽ $1 വിലയുണ്ട് ഒരു ടാബ്ലറ്റ്. അത് കഴിച്ചിട്ട് നോക്കുമ്പോൾ ഷുഗർ കുറേ കാലം ഇങ്ങനെ കൺട്രോളിങ്ങിൽ വന്നിരുന്നു. എപ്പോൾ നോക്കിയാലും ഒരേ ലെവലിൽ വന്നിരുന്നു. ഇവിടെ വന്ന് നോക്കുമ്പോൾ ഈ ഷുഗർ കഴിക്കുമ്പോൾ കാരണം എൻ്റെ ഞാൻ എപ്പോഴും കൺട്രോളിങ്ങിലാണ് കൊണ്ടുപോകണത്. സാജി ഡോക്ടർക്ക് അറിയാം ഞാനതിങ്ങനെ കൺട്രോളിങ്ങാണ് പോണത്, നടന്നിട്ടും എല്ലാ ജോലി ചെയ്തിട്ടും. പക്ഷേ മറ്റുള്ളവർക്ക് ചില സമയങ്ങളിൽ കാരണം പ്രഷർ കൂടാതെ തന്നെ അല്ലെങ്കിൽ പിന്നെ ടെൻഷൻ കൂടാതെ തന്നെ ഷുഗർ ഇങ്ങനെ കൂടി പോകുന്നുണ്ട്. അപ്പോൾ അതിന് കൺട്രോളിങ്ങിന് വല്ല മരുന്നുണ്ടോ എന്ന് ഞാൻ സംശയം ചോദിക്കാം.
ഈ പോസ്റ്റ് പ്രാൻഡിയൽ ഷുഗർ എന്ന് പറയും, അതായത് ഭക്ഷണം കഴിച്ചു കഴിയുമ്പം പെട്ടെന്ന് ഷുഗർ കൂടും. അപ്പം നമ്മൾ അത് മാത്രം കൺട്രോൾ ചെയ്യുന്ന ചില മരുന്നുകളുണ്ട്. ഭക്ഷണത്തിന് മുമ്പ് കഴിച്ചു കഴിയുമ്പോൾ നമ്മൾ ഭക്ഷണം കഴിക്കുന്ന ഈ കാർബോഹൈഡ്രേറ്റിൻ്റെ അബ്സോർപ്ഷൻ കുറയ്ക്കാനും ഈ കാർബോഹൈഡ്രേറ്റിൻ്റെ അളവനുസരിച്ച് ഇൻസുലിൻ സെക്രീറ്റ് ചെയ്യാനുള്ള മരുന്നുകളുണ്ട്. അങ്ങനെയുള്ള മരുന്നുകൾ കഴിക്കുമ്പോഴാണ് നമുക്ക് ഈ പോസ്റ്റ് പ്രാൻഡിയൽ കൺട്രോൾ ചെയ്യാൻ പറ്റുന്നത്. അതിന് ചില പ്രത്യേക മരുന്നുണ്ട്. പക്ഷേ അത് നിങ്ങൾ മുമ്പ് ഗൾഫിൽ വെച്ച് കഴിച്ച മരുന്ന് കുറച്ച് കാലം കഴിയുമ്പോൾ നിങ്ങളുടെ പാൻക്രിയാസിൻ്റെ ഇൻസുലിൻ സെക്രീഷൻ കുറഞ്ഞു വരും. അപ്പോൾ അങ്ങനെ ഒരു കണ്ടീഷൻ വരുമ്പോൾ ചിലപ്പോൾ ആ മരുന്ന് കൊണ്ട് കൺട്രോൾ ചെയ്യാൻ വയ്യാതെ വരും. അപ്പോൾ നമ്മൾ ചിലപ്പോൾ മരുന്നുകൾ മാറ്റും, ഇൻസുലിനിലേക്കൊക്കെ പോകേണ്ടതായിട്ട് വരും. അത് ഈ രോഗിയുടെ അവസ്ഥ അനുസരിച്ചാണ് നമ്മൾ എപ്പോഴും ചികിത്സ നിശ്ചയിക്കുന്നത്.
അത് പ്രൈമറിലി എന്താണെന്ന് വെച്ചാൽ നമ്മൾ ഭക്ഷണം കഴിച്ചു കഴിഞ്ഞാൽ ഷുഗർ കൂടും. അത് നോർമൽ ആൾക്കാർക്ക് അങ്ങനെ കൂടില്ല സാധാരണഗതിയിൽ. കാര്യം എന്താ വെച്ചാൽ നമ്മൾ ഭക്ഷണം കഴിക്കുന്ന സമയത്ത് ശരീരം അത് മനസ്സിലാക്കി അതിനനുസരിച്ച് ഇൻസുലിനെ ഉൽപ്പാദിപ്പിച്ച് അതിനെ നിയന്ത്രിച്ച് നിർത്തും. ഈ ഭക്ഷണം കഴിച്ചു കഴിഞ്ഞാൽ ഷുഗർ കൂടുന്നതിൻ്റെ കാര്യം എന്താ വെച്ചാൽ ശരീരത്തിന് അത് മനസ്സിലാക്കാനുള്ള കഴിവില്ലായ്മയോ, മനസ്സിലാക്കി കഴിഞ്ഞാലും അതിനൊന്നും ചെയ്യാൻ പറ്റില്ല, അതിനടുത്ത് ഇൻസുലിൻ ഇല്ല, അതുകൊണ്ടുണ്ടാകുന്ന പ്രശ്നങ്ങളോ ആയിരിക്കും ഉണ്ടാവും. അപ്പോൾ ഈ തരത്തിലുള്ള പ്രശ്നങ്ങളെ ഹാൻഡിൽ ചെയ്യാനുള്ള പല തരത്തിലുള്ള മരുന്നുണ്ട്. ഉദാഹരണത്തിന് ശരീരത്തിൽ ഷുഗർ കൂടുന്ന സമയത്ത് മാത്രം ഇൻസുലിൻ ശരീരത്തിന് ഉൽപ്പാദിപ്പിക്കാൻ പ്രാപ്തരായിട്ടുള്ള മരുന്നുകളുണ്ട്. അതല്ലാതെ എല്ലാ സമയത്തും ശരീരത്തിൽ ഇൻസുലിൻ ഉൽപ്പാദിപ്പിച്ചുകൊണ്ടിരിക്കുന്ന ടൈപ്പ് മരുന്നുകളുണ്ട്. പിന്നെ ഷാജി പറഞ്ഞ പോലെ ഭക്ഷണം കഴിക്കുന്ന സമയത്ത് കൊടുത്തു കഴിഞ്ഞാൽ ഭക്ഷണത്തിലെ കാർബോഹൈഡ്രേറ്റ് അന്നജം ശരീരത്തിലേക്ക് അബ്സോർബ് ചെയ്യുന്നത് കുറയ്ക്കുന്ന തരം മരുന്നുകളുണ്ട്. ഇൻസുലിൻ പോലുള്ള മരുന്നുകൾ. ഓരോ മരുന്നിനും ഓരോ പ്രവർത്തന രീതിയാണ്. അത് ഓരോ വ്യക്തിയുടെയും ശരീരത്തിലെ പ്രശ്നം എന്താണ്, എന്തുകൊണ്ടാണ് അദ്ദേഹത്തിൻ്റെ ഷുഗർ കൂടുന്നത്, എന്താണ് ഈ വ്യക്തിയുടെ പ്രത്യേക പ്രശ്നം എന്ന് മനസ്സിലാക്കി അതിനനുസരിച്ചുള്ള മരുന്ന് കഴിക്കുമ്പോഴേ നിങ്ങൾ ഈ പറഞ്ഞ പോലെ ഇടയ്ക്ക് കൂടുകയും കുറയുകയും ചെയ്യുന്നത് ഇല്ലാതെ ആവുള്ളൂ. അത് ശരിയായുള്ള ഉദാഹരണത്തിന് ലോറിയുടെ ടയർ എടുത്തിട്ട് കാറിനിട്ടാൽ ഓടില്ല, അത് പ്രശ്നമാവും. അതുപോലെ തന്നെ ഓരോന്നിനും ഫിറ്റായിട്ടുള്ള കാര്യമുണ്ട്. അതിന് ചക്രം തന്നെ ആയിരിക്കും, പക്ഷേ മരുന്നായിരിക്കും, പ്രമേഹമായിരിക്കും. അത് കറക്റ്റായിട്ടുള്ള കാര്യം കൊടുത്തു കഴിഞ്ഞാൽ അയാൾക്ക് മാറും. അത് കറക്റ്റ് കിട്ടുന്നത് വരെ അദ്ദേഹത്തിൻ്റെ ഷുഗർ ഇങ്ങനെ കൂടിയും കുറഞ്ഞുകൊണ്ടിരിക്കും. അവിടെയാണ് പ്രശ്നം.
സാർ അല്ല സാർ, ഈ ഇൻസുലിനാണോ ഗുളികയാണോ ഏറ്റവും നല്ലത് ഈ ഷുഗറിന്?
സാറേ ഞാൻ ഉത്തരം പറഞ്ഞ് വേറെ കാര്യം കൂടെ പോകാൻ സമയമായതുകൊണ്ടാണ്.
മറ്റൊന്ന്, ഈ അമിതമായ വിശപ്പിന് നമ്മൾ എന്തെങ്കിലും കഴിക്കുമ്പോൾ ഷുഗർ കൂടിയതുണ്ട്. ഒരു ദിവസം 4 മണിക്കൂർ കഴിഞ്ഞ് അമിതമായ വിശപ്പ്, അപ്പോൾ അതിന് ഇടയ്ക്കിടയ്ക്ക് ഭക്ഷണം കഴിക്കുമ്പോഴാണ് ഷുഗറിൻ്റെ വേരിയേഷൻ വരുന്നത്. അപ്പോൾ കഴിക്കാണ്ടിരിക്കാൻ ഭയങ്കര വിശപ്പ് വരുമ്പോൾ നമ്മൾ കഴിച്ചുകൊണ്ടേയിരിക്കും. 4-5 തവണയൊക്കെ കഴിക്കാറുണ്ട്. ഭക്ഷണം കഴിക്കുന്നത് കൊണ്ടാണ് ഏറ്റവും കൂടുതൽ 200-ന്റെ മുകളിൽ 300-നടുത്ത് ഷുഗർ വരുന്ന ഒരാളാണ് ഞാൻ. അതുകൊണ്ടാണ് ചോദിച്ചത്.
ആദ്യത്തെ ചോദ്യത്തിന് ഉത്തരം പറയാം. അതായത് ഇൻസുലിനാണോ ഗുളികയാണോ എന്നുള്ളത് അങ്ങനെ ഒന്നുമില്ല. അത് രോഗിയുടെ അവസ്ഥ. നേരത്തെ പറഞ്ഞ 3 മാസത്തെ ആവറേജ് ഷുഗർ എത്ര. പൊതുവേ ഇപ്പം പുതിയ പഠനങ്ങൾ പറയുന്നത് വെച്ചാൽ 10% മുകളിലാണെങ്കിൽ നമ്മൾ എന്തായാലും ഇൻസുലിൻ എടുക്കണം. പക്ഷേ ഇൻസുലിൻ എടുക്കുമ്പോൾ ഇൻസുലിൻ്റെ കൂടെ തന്നെ നമുക്ക് ഗുളികകളും കഴിക്കാം, അതിന് കുഴപ്പമില്ല. അത് ഡോക്ടറുടെ നിർദ്ദേശപ്രകാരം. ഇൻസുലിൻ എന്ന് പറയുന്നത് നമ്മൾ 2 നേരം എടുക്കുന്ന ഇൻസുലിനുണ്ട്, 1 നേരം എടുക്കുന്ന ഇൻസുലിനുണ്ട്, 3 നേരം എടുക്കുന്ന ഇൻസുലിനുണ്ട്. ഈ 3 നേരം എടുക്കുന്ന ഇൻസുലിൻ ആഹാരത്തിനോട് എടുക്കുമ്പോൾ നമുക്ക് കൺട്രോൾ ആകുന്നില്ലെങ്കിൽ രാത്രിയോ അല്ലെങ്കിൽ രാവിലെയോ 24 മണിക്കൂർ ആക്ഷനുള്ള കൂടുതൽ നേരെ ആക്ട് ചെയ്യുന്ന ഇൻസുലിൻ നമുക്ക് എടുക്കാം. പിന്നെ ഈ 9ന് മുകളിൽ 3 മാസത്തെ ആവറേജ് 9% മുകളിലുള്ളവർ ചിലപ്പം ഈ ദാഹ കൂടുതൽ അല്ലെങ്കിൽ നമ്മൾ അടിക്കടി മൂത്രം ഒഴിക്കുന്ന അവസ്ഥ അങ്ങനെയുള്ളവരിലും ഇൻസുലിൻ പൊതുവെ കൊടുക്കാറുണ്ട്. അല്ല ഇൻസുലിനാണോ ഗുളികയാണോ ബെറ്റർ എന്ന് ചോദിച്ചാൽ അതൊരു നമുക്ക് ഒരു എന്താ പറയുന്ന ഒരു വ്യക്തമായ ഉത്തരം പറയാൻ പറ്റത്തില്ല. ആദ്യ കാലഘട്ടങ്ങളിൽ നമ്മൾ മരുന്ന് കഴിക്കുമ്പോൾ ചില മരുന്നുകൾ ആദ്യത്തെ ഒരു 5-6 വർഷം നമ്മുടെ പാൻക്രിയാസിലുള്ള ബാക്കിയുള്ള ഇൻസുലിനെ ഉത്തേജിപ്പിച്ച് നമുക്ക് ഷുഗർ കുറയ്ക്കുന്നുണ്ട് ആക്ട് ചെയ്യുക. അതുകൊണ്ട് പറയുന്നത് കുറച്ച് കഴിയുമ്പോൾ ഷുഗർ മെഡിസിനിൽ കൺട്രോൾ ആകാതെ വരുമ്പോൾ നമ്മൾ ഇൻസുലിനോട്ട് പോകും. ഇപ്പം ആ പഴയ ജനറേഷൻ മരുന്നുകളെക്കാട്ടിയും പുതിയ നല്ല ഗുളികകൾ മാർക്കറ്റിൽ അവൈലബിൾ ആണ്. അപ്പോൾ അത് നമുക്ക് ഡോക്ടറുടെ നിർദ്ദേശപ്രകാരം പലതരത്തിലുള്ള പ്രധാനമായിട്ട് ഒരു 3-4 ക്ലാസ് ഗ്രൂപ്പിലുള്ള മരുന്നുകളാണ് പ്രധാനമായിട്ട് നമ്മൾ കഴിക്കാൻ കൊടുക്കുന്നത്. അതിന് നമുക്ക് നല്ല ഇതായിട്ട് ഉപയോഗിക്കാം. പിന്നെ അതിൻ്റെ കൂടെ വേണമെങ്കിൽ ഇൻസുലിൻ നമുക്ക് രോഗിയുടെ അവസ്ഥ അനുസരിച്ച് എടുക്കാം. പിന്നെ നമുക്ക് എന്തെങ്കിലും ഇൻഫെക്ഷൻസ് വരുമ്പോൾ അതായത് എന്തെങ്കിലും മുറിവുകളോ അല്ലെങ്കിൽ ഈ ഹാർട്ട് അറ്റാക്ക് പോലുള്ള അവസ്ഥയോ സ്ട്രോക്കൊക്കെ വരുന്ന സമയങ്ങളിൽ നമ്മൾ പൊതുവെ ഗുളികയിൽ നിന്ന് ആശുപത്രിയിൽ അഡ്മിറ്റ് ആവുകയാണെങ്കിൽ നമ്മൾ ഇൻസുലിനോട്ട് മാറ്റുന്ന ഇതാണ് കണ്ടുവരുന്നത്. പോകുന്നതിന് മുമ്പ് ഒരു കാര്യം പറഞ്ഞിട്ട് പോകാം. അതായത് നിങ്ങൾ ഏറ്റവും പ്രധാനമായിട്ടും നമ്മൾ ഹാർട്ട്, കിഡ്നി, ഇത് കണ്ണിൻ്റെ ഞരമ്പ്, ഈ കണ്ണിൻ്റെ പുറകിലുള്ള ഞരമ്പ് നിങ്ങൾ സ്ഥിരം അറ്റ്ലീസ്റ്റ് ഒരു വർഷത്തിലൊരിക്കലെങ്കിലും റെഗുലറായിട്ട് നോക്കുക. ഈ റെറ്റിന അത് നമ്മുടെ വളരെ കോമൺ ആയിട്ട് കാണുന്ന, നമുക്ക് കാഴ്ച പോയി കഴിഞ്ഞാൽ പിന്നെ തിരിച്ചിട്ട് വലിയ ബുദ്ധിമുട്ടാണ്. ചികിത്സ വളരെ എന്താ പറയുന്നത് കോസ്റ്റ്ലി ആയിട്ടുള്ളതുമാണ്. അതുകൊണ്ട് പ്രമേഹം നിങ്ങൾ കണ്ടുപിടിക്കുന്ന സമയത്ത് തന്നെ റെറ്റിന നോക്കുക. പിന്നെ വർഷത്തിലൊരിക്കൽ അല്ലെങ്കിൽ 2 വർഷത്തിലൊരിക്കൽ ഈ കണ്ണ് ഡോക്ടറുടെ നിർദ്ദേശപ്രകാരം റെറ്റിന സ്ഥിരം നിങ്ങൾ പരിശോധിക്കുക. പിന്നെ ഏത് രോഗികളും ഒരു 5 വർഷം പ്രമേഹം കഴിഞ്ഞെങ്കിൽ അതിന് മുമ്പ് ആദ്യം കണ്ടുപിടിക്കുന്നവർ ചെയ്താലും നല്ലത്. 5 മുതൽ 8 വർഷം കഴിഞ്ഞവർ പ്രധാനമായിട്ടും പാദത്തിൻ്റെ സംരക്ഷണം വളരെ ഇമ്പോർട്ടൻ്റ് ആണ്. നിങ്ങൾ ദിവസവും രാത്രി കിടക്കുന്നതിന് മുമ്പ് നിങ്ങൾ തന്നെ നിങ്ങളുടെ പാദം നോക്കുക. എവിടെയെങ്കിലും എന്തെങ്കിലും നിറവ്യത്യാസമോ ചുവപ്പോ കറുപ്പോ ഉണ്ടോ. ഈ കാലിൻ്റെ വിരലുകളുടെ ഇടഭാഗം നന്നായിട്ട് നോക്കുക. പിന്നെ കാലിൽ നിങ്ങളുടെ വീട്ടിലാരെങ്കിലും ഈ തളയിടുന്ന സ്ത്രീകളുണ്ടെങ്കിൽ വിരലിൽ ഡയബറ്റീസ് ഉണ്ടെന്നുണ്ടെങ്കിൽ അവർക്ക് ദയവീത് പറയുക ഈ തള ഊരി മാറ്റുക. ഇറങ്ങിയ പോലെ തളയിടുന്ന ഒരു രീതിയുണ്ട്, അത് മാറ്റുക. പിന്നെ അടിഭാഗത്ത് എവിടെയെങ്കിലും നമ്മൾ കാലിൽ കല്ലിപ്പോ അങ്ങനെ എന്തെങ്കിലും ഉണ്ടോ എന്ന് നോക്കുക. പാദരക്ഷകൾ ഉപയോഗിച്ച് തന്നെ നിങ്ങൾ വീടിനകത്തും പുറത്തും, അതായത് പ്രത്യേക തരത്തിലുള്ള പാദരക്ഷകളുണ്ട്, MCR പോലുള്ള ഇതിൽ ഉണ്ടാക്കിയിട്ടുള്ളത്, കൂടിയതുകൊണ്ട് EVA മെറ്റീരിയലുള്ളത്. നമുക്ക് നമ്മുടെ സാമ്പത്തിക സ്ഥിതിക്ക് അനുസരിച്ച് ഇതൊരു 5-8 വർഷം കഴിഞ്ഞ് നമ്മളിപ്പോൾ സ്ലിപ്പർ, നമ്മുടെ ഹവായി ചെരുപ്പ് സാധാരണ നിങ്ങളിട്ട് നടക്കുമ്പോൾ കാലിൽ നിന്ന് വഴുതി പോവുമെങ്കിൽ ഫ്രണ്ടിലൊരു കെട്ടും പുറകിലൊരു കെട്ടുള്ള ചെരുപ്പ് ഡോക്ടറുടെ നിർദ്ദേശപ്രകാരം നിങ്ങൾ ചെയ്യിച്ചിടുന്നതായിരിക്കുന്നില്ല. പിന്നെ ചെരുപ്പിൻ്റെ അളവെടുക്കുമ്പോൾ എപ്പോഴും ശ്രദ്ധിക്കേണ്ടത് ഉച്ചയ്ക്ക് ശേഷം പോയി എടുക്കുക. വൈകുന്നേരങ്ങളിൽ പലരുടെയും കാല് നീര് വയ്ക്കുന്നതായിട്ട് കണ്ടിട്ടുണ്ട്. ചിലപ്പോൾ ആ 1 ഇഞ്ച് വ്യത്യാസം തന്നെ പുതിയ ചെരുപ്പിടുമ്പോൾ നിങ്ങൾക്ക് ചിലപ്പോൾ ഷൂ ബൈറ്റ് മുറിവ് ഉണ്ടാക്കാം. ഇത് ശ്രദ്ധിക്കുക. പറ്റുമെങ്കിൽ ഒരു കൈ പിടിക്കുന്ന ഒരു കണ്ണാടി, നീളമുള്ള കണ്ണാടി വെച്ച് വേറെ ആരും നോക്കി തരാൻ പറ്റില്ലെങ്കിൽ പാദത്തിൻ്റെ അടിഭാഗം നിങ്ങൾക്ക് തന്നെ നോക്കാം. അല്ലെങ്കിൽ നല്ല കാഴ്ചയുള്ള വീട്ടിൽ കുട്ടികളോ ചെറുമക്കളോ ഉണ്ടെങ്കിൽ അവരായിരിക്കും ബെറ്റർ. പ്രായമുള്ളവർ കാഴ്ചക്കുറവുണ്ടെന്നുണ്ട്, അത് വളരെ കാര്യമായിട്ട് നോക്കുക. അല്ലെങ്കിൽ ഒരു വിരൽ മുറിക്കുകയോ കാല് മുറിക്കുകയോ ചെയ്ത് കഴിഞ്ഞാൽ പിന്നെ വലിയ ബുദ്ധിമുട്ടാകും.
ഇതിൽ ഒരു ഒറ്റ പ്രാവശ്യം ഞാൻ പറയാം. അതായത് ഇൻസുലിൻ ആണോ ഗുളികയാണോ നല്ലത്, അതിൽ ഇൻസുലിൻ തന്നെ പലതരം ഇൻസുലിൻ, ഏത് ഇൻസുലിനാണ് നല്ലതെന്നൊക്കെ ചോദിക്കുന്നുണ്ട്. ഞാൻ ഒറ്റ ചെറിയൊരു ഉദാഹരണം പറഞ്ഞു നിങ്ങൾക്ക് മനസ്സിലാക്കി തരാം. നമ്മൾ പേനാക്കത്തി മുതൽ, ചെറിയ പേനാക്കത്തി മുതൽ ഇടത്തരം കത്തി, വലിയ കത്തി, കൊടുവാള്, മഴു, ഇതൊക്കെ ഉണ്ട്. എന്തിനുപയോഗിക്കുന്ന ഇതൊക്കെ? മുറിക്കാൻ അല്ലേ? ഇതിലേതാ നല്ലത്? കൊടുവാളാണോ പേനക്കത്തിയാണോ നല്ലത്? ഏതാ നല്ലത്? മഴുവാണോ നല്ലത്? അത് തന്നെ അതാണ്. അപ്പൊ ഈ സംഭവം നമ്മൾ ഡോക്ടർമാർ അത് ഉപയോഗിക്കുന്നത് ഇപ്പം വീട്ടിലെ അടുക്കളയിലാണെങ്കിൽ പെണ്ണുങ്ങൾക്കറിയാം ചെറിയ കത്തിയും കൊടുവാളൊക്കെ ഉണ്ട്. അവർ ഓരോന്ന് മുറിക്കാൻ, വെണ്ടയ്ക്ക മുറിക്കാൻ അതിനനുസരിച്ചുള്ള കത്തി അവർക്കറിയാം അല്ലേ? മീൻ മുറിക്കാൻ അതിനൊരു കത്തിയുണ്ട്. വേറെ എന്തെങ്കിലും ഉണ്ടെങ്കിൽ അതിനനുസരിച്ച്, തേങ്ങ പൊളിക്കാനാണെങ്കിൽ അതിന് വേറെ കത്തിയുണ്ട് അല്ലേ? കൊടുവാളുണ്ടോ? ഇതുപോലെ തന്നെയാണ് ഡോക്ടർമാർ അതാത് സാഹചര്യങ്ങൾക്ക്, സന്ദർഭത്തിനും ആ രോഗിയുടെ അവസ്ഥയ്ക്കും രോഗിയുടെ ഷുഗറിനും അനുസരിച്ച് കറക്റ്റായിട്ട് അത് ഉപയോഗിക്കുക. അത് ഡോക്ടറിനെ തീരുമാനിക്കാൻ പറ്റില്ല. നിങ്ങളുടെ ആ പ്രത്യേക രോഗിക്ക് ഇൻസുലിൻ ആണോ നല്ലത് ഗുളികയാണോ നല്ലത് എന്നുള്ളത് ആ ഡോക്ടറിന് മാത്രമേ തീരുമാനിക്കാൻ പറ്റുള്ളൂ. അല്ലാതെ എല്ലാ വ്യക്തികൾക്കും ഈ ഇൻസുലിനാണോ നല്ലത് ഗുളികയാണോ നല്ലത് അങ്ങനെ ഒരു ഡിസ്റ്റിങ്ഷൻ ഇല്ല. അതാണ് മനസ്സിലായല്ലോ? അതാണ് നേരത്തെ ഹരീഷ് പറഞ്ഞത്. സ്ഥിരമായി മരുന്ന് കഴിക്കുന്നത് കൊണ്ട് എന്തെങ്കിലും കുഴപ്പമുണ്ടോ?
ഈ ചോദ്യം നേരത്തെ ഇൻസുലിൻ്റെ ചോദ്യം പോലെ തന്നെയാണ്. എനിക്ക് ഈ മരുന്ന് കഴിക്കുമ്പോൾ കരളിൻ്റെയോ വൃക്കയുടെയോ തകരാറ് വരുമോ എന്നുള്ളൊരു ഭയം എല്ലാവരിലും ഉണ്ട്. മനസ്സിലാക്കുക, സ്ഥിരമായി പ്രമേഹ രോഗികളിൽ കണ്ടുവരുന്ന ഒരു അപകടം എന്ന് പറയുന്നത് തുടക്കത്തിൽ പ്രമേഹ രോഗനിർണയം നടത്തി കഴിഞ്ഞാൽ അപ്പോൾ വാങ്ങിച്ച ഒരു ഡോക്ടറുടെ കുറിപ്പടി തന്നെ തുടർന്നു കൊണ്ടേയിരിക്കുക. അത് പാടില്ല, ഒരിക്കലും അത് ചെയ്യാൻ പാടില്ല. നേരത്തെ എനിക്ക് മുന്നേ പറഞ്ഞ ഡോക്ടേഴ്സ് എല്ലാവരും വ്യക്തമായി പറഞ്ഞു, ഒരു രോഗിയുടെ പ്രമേഹ രോഗാവസ്ഥ പരിഗണിച്ചിട്ടാണ് എന്ത് മരുന്ന് വേണം, ഏത് രീതിയിൽ അത് ഉപയോഗിക്കണം എന്നുള്ളൊരു നിർദ്ദേശം കൊടുക്കുന്നത്. ഇതിനെല്ലാം ട്രീറ്റ്മെൻറ്റ് ഗൈഡ് ലൈൻസ് ഉണ്ട്, നിയമങ്ങളുണ്ട്. ഏത് രോഗിക്ക് ഏത് രോഗാവസ്ഥയിൽ ഏത് മരുന്നാണ് കൊടുക്കേണ്ടതെന്നുള്ളൊരു നിയമങ്ങളുണ്ട്. അപ്പോൾ അത് ഫോളോ ചെയ്താണ് ഡോക്ടർ രോഗിയുടെ അവസ്ഥ പരിഗണിച്ച് കൊടുക്കുന്നതെന്ന് പറഞ്ഞത്. അപ്പോൾ ആ മരുന്ന് തുടരുമ്പോൾ കൃത്യമായ കാലയളവിൽ വൃക്കയുടെയോ കരളിൻ്റെയോ പ്രവർത്തനം മനസ്സിലാക്കിക്കൊണ്ട് മരുന്നുകളുടെ ഏറ്റക്കുറച്ചിൽ വരുത്തുകയോ മരുന്നുകൾ മാറ്റുകയോ ചെയ്യേണ്ടത് അത്യാവശ്യമാണ്. ഒരു മരുന്നിനും സൈഡ് എഫക്റ്റ് ഇല്ല എന്ന് ഇവിടെ ഇരിക്കുന്ന ഒരു ഡോക്ടറും പറയില്ല. മരുന്നിന് ഗുണമുണ്ടെങ്കിൽ ദോഷമുണ്ട്. പക്ഷേ വളരെ കരുതലോടുകൂടി തന്നെ പ്രമേഹ രോഗികൾ ഉപയോഗിക്കണം. പ്രമേഹ രോഗം തന്നെ രോഗം മൂർച്ഛിക്കുന്ന അല്ലെങ്കിൽ വർഷങ്ങൾ കൂടുന്ന സമയത്ത് അനുബന്ധ രോഗങ്ങളും സങ്കീർണതകളും വരുത്തിക്കൊണ്ടിരിക്കുന്നതാണ് നമ്മളുടെ എല്ലാവരുടെയും ആശങ്ക എന്ന് പറയുന്നത്. തൊട്ടു മുന്നേ ഡോക്ടർ അജിത് സാർ വളരെ ക്ലിയർ ആയിട്ട് പറഞ്ഞു, പാദരക്ഷ ഉപയോഗിക്കേണ്ടതും പാദ സംരക്ഷണം നടത്തേണ്ടതും പറഞ്ഞു. പ്രമേഹ രോഗികളുടെ ഭാവിയിൽ വരാൻ പോകുന്ന സങ്കീർണതകൾ തടയാനുള്ള മാർഗങ്ങളാണ് നമ്മൾ എല്ലാം ചർച്ച ചെയ്തുകൊണ്ടിരിക്കുന്നത്. അപ്പോൾ ചികിത്സയിൽ നിർബന്ധമായും മരുന്നുകൾ എടുക്കുമ്പോൾ നിങ്ങൾക്ക് അങ്ങനെ ഒരു ആശങ്കയുണ്ടെങ്കിൽ ചികിത്സിക്കുന്ന ഡോക്ടറുമായി സംസാരിക്കുക. ഈ മരുന്നിന് എനിക്ക് എന്തെങ്കിലും ബുദ്ധിമുട്ട് വരാൻ സാധ്യതയുണ്ടോ എന്നുള്ളത് ചോദിക്കുക. നേരത്തെ സൂചിപ്പിച്ചതുപോലെ വ്യക്തമായ സമയങ്ങളിൽ നമുക്ക് കൃത്യമായ കാലയളവിൽ മരുന്നുകളുടെ ഏറ്റക്കുറച്ചിൽ വരുത്തി മാറ്റം വരുത്തി മരുന്നുകൾ മാറ്റണം എന്നുണ്ടെങ്കിൽ മൊത്തത്തിലുള്ളൊരു മാറ്റവും വരുത്തി തന്നെ വേണം ചികിത്സ തുടരാനായിട്ട്. പിന്നെ നേരത്തെ ചോദിച്ച ആ ഒരു ചോദ്യം, അമിതമായി വിശപ്പ് അല്ലെങ്കിൽ ഒരു ക്ഷീണം വരുന്ന ഒരവസ്ഥ വരുന്നതിനെ പറ്റി പറഞ്ഞു. അത് രണ്ട് തരത്തിൽ കാണാം. പ്രമേഹം നിയന്ത്രണമില്ലാതെ തുടരുന്ന വേളയിൽ ഉണ്ടാകുന്ന ലക്ഷണമായിട്ട് കാണാം. വളരെ ഹൈ ആയിട്ട് ഷുഗർ തുടരുമ്പോൾ സത്യത്തിൽ ആ ഒരു ബുദ്ധിമുട്ട്, അമിതമായിട്ടുള്ള ഒരു വിശപ്പോ ദാഹമോ അമിതമായിട്ടുള്ള മൂത്രശങ്കയോ ഒക്കെ ഉണ്ടാവാം. അതേപോലെ തന്നെ തീരെ കുറഞ്ഞു പോകുന്ന അവസ്ഥയിലും ഉണ്ടാകാം. അപ്പോൾ ഇതിനു മുന്നേ മരുന്നുകളുടെ സമയക്രമീകരണത്തെക്കുറിച്ച് പറഞ്ഞു. അപ്പോൾ വ്യക്തമായൊരു എക്സാമ്പിളാണ് ഡോക്ടർ സുരേഷ് സാർ പറഞ്ഞത്. അപ്പോൾ മരുന്നുകൾ ഉപയോഗിക്കേണ്ട രീതിയിലല്ല എങ്കിൽ പ്രമേഹ നിയന്ത്രണത്തെ അത് ബാധിക്കുന്നത്, രക്തത്തിലെ ഏറ്റക്കുറച്ചിൽ വല്ലാതെ മോശമാകാൻ സാധ്യതയുള്ളത് ഇത്തരം ബുദ്ധിമുട്ടുകൾ കുറഞ്ഞു കഴിഞ്ഞാലും വരാനുള്ള സാധ്യതയുണ്ട്. അപ്പോൾ മരുന്നുകൾ ഉപയോഗിക്കുന്നത് ശ്രദ്ധിക്കണം. ആ മരുന്നുകൾ ഉപയോഗിക്കുമ്പോൾ ഏത് രീതിയിലുള്ള ഭക്ഷണ ക്രമീകരണമാണ് പാലിച്ചു പോകേണ്ടതെന്നുള്ളതും ഡോക്ടറുടെയോ ചികിത്സിക്കുന്ന സംഘത്തിൻ്റെയോ അഭിപ്രായം അനുസരിച്ച് പാലിച്ചു പോകണം. അല്ലാതെ മരുന്ന് ഉപയോഗിക്കുന്ന സമയത്ത് കൃത്യമായ രീതിയിൽ ഭക്ഷണം ക്രമീകരിച്ചില്ല എങ്കിൽ അമിതമായിട്ടുള്ള ഒരു ശാരീരിക അധ്വാനം ചെയ്യുന്ന അവസ്ഥയിലും ഇത്തരം ബുദ്ധിമുട്ടുകൾ ഉണ്ടാകാനുള്ള സാധ്യതയുണ്ട്. അതുകൊണ്ട് ഭക്ഷണ ക്രമീകരണവും അവിടെ കരുതലോടുകൂടി ശ്രദ്ധിക്കേണ്ടതാണ്.
സാറ് നേരത്തെ സംസാരിച്ചപ്പോൾ ഈ 24 hours ഗ്ലൂക്കോസ് റീഡ് ചെയ്യുന്ന ഒരു ഡിവൈസിനെ പറ്റി പറഞ്ഞു. അത് അവൈലബിൾ ആണോ?
പിന്നെ ഇവിടെ സാർ ഉപയോഗിക്കുന്നുണ്ടോ എന്ന് എനിക്കറിയില്ല. എല്ലായിടത്തും അത് അവൈലബിൾ ആണ്. അത്
എത്ര എക്സ്പെൻസീവ് ആണ്?
നമുക്ക് ഈ ഗ്ലൂക്കോമീറ്റർ ഉപയോഗിച്ച് പരിശോധിക്കുന്നതിനെക്കാട്ടിലും വളരെ ഈസി ആയിട്ട് നോക്കാൻ പറ്റുന്ന ടെസ്റ്റുകളാണ് ഇതെല്ലാം. അപ്പോൾ ഈ കയ്യിൽ നമുക്ക് തോളിൻ്റെ ഭാഗത്തായിട്ട് ഒരു 5 രൂപ നാണയത്തിൻ്റെ വലുപ്പത്തിലുള്ള ഒരു സ്റ്റിക്കർ രൂപത്തിലാണ് ഈ പറയുന്ന സെൻസേഴ്സ് അവൈലബിൾ ആയിട്ടുള്ളത്. രണ്ട് തരത്തിലുണ്ട്. നമുക്ക് മുന്നേ അവൈലബിൾ ആയിരുന്നതെന്ന് പറയുന്നത് ഡോക്ടർ ഇപ്പോൾ ഹോസ്പിറ്റലിൽ നിന്ന് അത് ഒട്ടിച്ചു വിട്ടിട്ട്, അത് വേദന എടുക്കുന്ന ഒരു പ്രൊസീജിയർ ഒന്നുമല്ല, ആശുപത്രിയിൽ കിടക്കുമ്പോൾ നോക്കുന്ന പരിശോധനയുമല്ല. സാധാരണ നമ്മൾ എന്തൊക്കെ ജോലികൾ ചെയ്തുകൊണ്ടിരിക്കുകയാണോ അപ്പോഴാണ് ആ പരിശോധന ചെയ്യുന്നത്, ഈ കണ്ടിന്യൂസ് ഗ്ലൂക്കോസ് മോണിറ്ററിംഗ് എന്ന് പറയുന്ന ആ ടെസ്റ്റ്. അപ്പോൾ അത് ഒട്ടിച്ചു കഴിഞ്ഞാൽ 2 ആഴ്ചത്തേക്കാണ് അത് അവിടെ ഇരിക്കുന്നത്. കുളിക്കാനോ മറ്റ് ആക്ടിവിറ്റീസിനോ ഒന്നും അത് ബാധിക്കാൻ പോകുന്നില്ല. അപ്പോൾ ഈ ഹോസ്പിറ്റലിൽ നിന്ന് ഒട്ടിച്ചു വിടുന്ന സെൻസർ എന്ന് പറയുന്നത് വേറെ, അതല്ലാതെ നമുക്ക് തന്നെ കുത്തി പരിശോധിച്ച് നോക്കുന്നതല്ലാതെ ഈ ഒട്ടിച്ചിരിക്കുന്ന സെൻസറിൽ തന്നെ സ്കാൻ ചെയ്ത് റീഡ് ചെയ്ത് ഷുഗർ വാല്യൂ നോക്കാൻ പറ്റുന്നതുമുണ്ട്. രണ്ടിൻ്റെയും വില വ്യത്യാസമാണ്. ആദ്യത്തെ ഈ പറയുന്ന ഹോസ്പിറ്റലിൽ നിന്ന് ഡിപ്ലോയ് ചെയ്യുന്ന സെൻസേഴ്സിന് ഏകദേശം ഒരു 2500 മുതൽ തുടങ്ങുന്ന വിലയാണ് വരുന്നത്. 14 ദിവസത്തെയാണ് ഞാനീ പറയുന്നത്. റീഡറുള്ള സെൻസർ കുറച്ചും കൂടെ വില കൂടും. കാരണം ആ റീഡറും കൂടെ നമ്മൾ കയ്യിൽ വെച്ച് കഴിഞ്ഞാൽ മാത്രമേ രോഗിക്ക് കുത്താതെ നോക്കാനായിട്ട് പറ്റുള്ളൂ. അപ്പം നേരത്തെ കുഞ്ഞുങ്ങളിലെ ഡയബറ്റീസിനെ പറ്റി പറഞ്ഞു. അപ്പം ടൈപ്പ് 1 പ്രമേഹം കുട്ടികളിൽ കാണുന്ന സമയത്ത് കുട്ടികൾക്ക് ദിവസവും ഒരു 6 നേരമെങ്കിലും രക്തപരിശോധന നടത്തിയാലേ 3 നേരമോ 4 നേരമോ എടുക്കുന്ന ഇൻസുലിൻ്റെ ഡോസ് തീരുമാനിക്കാൻ പറ്റുള്ളൂ. അപ്പോൾ അത്തരം സാഹചര്യങ്ങളിൽ തുടർച്ചയായി വിരലിൽ കുത്തി പരിശോധിക്കുക എന്ന് പറയുന്നത് കുട്ടികളെ സംബന്ധിച്ചിടത്തോളം വല്ലാതെ ബുദ്ധിമുട്ടുള്ള ഒരു അവസ്ഥയിൽ ഇത്തരം കാര്യങ്ങൾ ഒരുപാട് അവരെ സഹായിക്കും.
രണ്ടാമത് പറഞ്ഞ ആ ഡിവൈസിന് അതിനെത്ര?
അതിന് റീഡറിൻ്റെയും കൂടെ കോസ്റ്റ് വരുമ്പോൾ കുറച്ചും കൂടെ വരാറുണ്ട്. അത് 4000-ൽ കൂടുതൽ വരാനുള്ള സാധ്യതയുണ്ട്. ആ റീഡറിന് തന്നെ.
റീഡറിന് 4000.
സെൻസർ 14 ദിവസത്തെ സെൻസർ മാറ്റി വെക്കേണ്ടി വരും.
അത് അവൈലബിൾ. എന്താ അതിൻ്റെ പേര്?
ഒരു പലതരത്തിലുണ്ട്. ലിബ്രെ അങ്ങനെ പല സെൻസേഴ്സ് ഉണ്ട്.
എന്താണ് ഇതിന് പറയാ ഡിവൈസിന്?
അതെ,
ഡോക്ടർ പ്രിസ്ക്രൈബ് ചെയ്യണം.
അതെ അതെ അതെ.
പെയിൻലെസ് ആണ്. അഡ്വാൻസ്ഡ് ഉണ്ട്.
കാരണം എന്താ വെച്ചാൽ എനിക്ക്
കോവിഡിൻ്റെ നമുക്കറിയാം, കോവിഡ് ഉള്ള സമയത്ത് പ്രമേഹമുള്ള ആൾക്കാരിൽ പ്രശ്നങ്ങൾ ഗുരുതരമായിട്ട് നമ്മൾ കണ്ടിരുന്നു. അതൊരു കാരണം. അപ്പോൾ നമുക്കറിയാം സങ്കീർണതകൾ കൂടുതലുള്ള ആൾക്കാർക്ക് കൂടുതൽ ഗുരുതരമായ അവസ്ഥ ഉണ്ടാവും. ICUയിൽ അഡ്മിഷനൊക്കെ പ്രമേഹമുള്ളവർക്ക് കൂടുതലായിരുന്നു. മാത്രമല്ല, ഇനിയിപ്പോൾ കോവിഡ് അല്ല, ഏത് അസുഖമാണെങ്കിലും നമ്മൾ ICUയിൽ ഒരു അഡ്മിഷൻ വരികയാണെങ്കിൽ ബ്ലഡ് ഷുഗർ കൂടുതലാണെങ്കിൽ നമ്മുടെ മറ്റ് അസുഖങ്ങൾ കൊണ്ടുള്ള ഗുരുതരാവസ്ഥ പ്രമേഹമുള്ള ആൾക്കാർക്ക് പ്രമേഹം ഇല്ലാത്തവരെക്കാളും എപ്പോഴും കൂടുതലാണ്. പിന്നെ അതുകൂടാതെ നേരത്തെ ഒരാൾ ചോദിച്ചില്ലേ സ്ട്രെസ് വരുമ്പോൾ ഡയബറ്റീസ് ഉണ്ടാവുമോ? അപ്പോൾ നമുക്ക് ടൈപ്പ് 2 ഡയബറ്റീസ് വരാൻ സാധ്യതയുള്ള ആൾക്കാരാണ് മെജോറിറ്റി. നമ്മുടെ ആളുകൾ, നമ്മുടെ വീട്ടിൽ ആർക്കെങ്കിലും ഉണ്ടെങ്കിൽ, അല്ലെങ്കിൽ നമ്മളൊരു മലയാളി ആയതുകൊണ്ട് തന്നെ പ്രമേഹം വരാൻ സാധ്യത കൂടുതലുള്ള വ്യക്തികളാണ് നമ്മളെല്ലാവരും. അപ്പോൾ ഏതെങ്കിലും ഒരു സങ്കീർണമായ അവസ്ഥയിൽ കൂടെ പോകുമ്പോൾ നമുക്ക് ആ സമയത്ത് നമുക്ക് വരാൻ സാധ്യതയുള്ള പ്രമേഹം പ്രസിപിറ്റേറ്റ് ചെയ്യാം, അങ്ങനെ വരാം. അതേസമയം നമ്മൾ വലിയ കുഴപ്പങ്ങളൊന്നും ഇല്ലാണ്ട് ഇങ്ങനെ തുറന്നു പോവുകയാണെങ്കിൽ നമുക്കിപ്പോൾ വരുമായിരുന്നിരിക്കില്ല. കോവിഡ് വന്നിട്ടില്ലെങ്കിൽ ചിലപ്പോൾ ഒരു 5 വർഷമോ 10 വർഷമോ കഴിയുന്ന പ്രമേഹം കോവിഡിൻ്റെ സമയത്ത് കൂടുതലായിട്ട് വരാം. ഇനി മൂന്നാമതായിട്ട് കോവിഡ് ഒരു വൈറൽ ഇൻഫെക്ഷനാണ്. അപ്പോൾ അതിൻ്റെ കാരണങ്ങൾ കൊണ്ട് ആ വൈറസ് നേരിട്ട് പാൻക്രിയാസിനെ ബാധിക്കാം, അല്ലെങ്കിൽ പ്രമേഹ നിയന്ത്രണത്തിനുള്ള മറ്റ് ഹോർമോണുകളെ ബാധിക്കാം. അങ്ങനെ വരുമ്പോഴും നമുക്ക് പ്രമേഹം വരാൻ സാധ്യതയുണ്ട്. ഇതൊക്കെയാണെങ്കിലും നമ്മളിപ്പോൾ പ്രമേഹം ഉണ്ട് എന്നതുകൊണ്ട് എനിക്ക് കോവിഡ് വന്നാൽ ഞാൻ മരിച്ചു പോവോ, എനിക്ക് ഗൗരവമാവോ, ഞാൻ ICUയിലാവോ എന്നൊന്നും ഭയക്കേണ്ട കാര്യമില്ല. നമ്മൾ പ്രമേഹം നിയന്ത്രണത്തിലാക്കുക, സങ്കീർണതകൾ നിയന്ത്രണത്തിലാക്കുക. നേരത്തെ പറഞ്ഞ പോലെ ഷാജി ഡോക്ടറിനെയോ അല്ലെങ്കിൽ ഇവിടെയുള്ള ഒരുപാട് ഡോക്ടേഴ്സ് ഇവിടെ തന്നെയുണ്ട് പെരിന്തൽമണ്ണയിൽ. നമുക്ക് ഏറ്റവും സൗകര്യവും അടുത്തുള്ള ഡോക്ടറെ അടുത്ത് നമ്മുടെ കാര്യങ്ങൾ പറഞ്ഞിട്ട് നമുക്ക് ഏറ്റവും അനുയോജ്യമായ മരുന്ന് എന്താണോ ചികിത്സ എന്താണോ അത് തീരുമാനിക്കുക. അപ്പോൾ കോവിഡ് ഒരു കാരണമാണ്. പ്രോബബ്ലി ലോകമെമ്പാടും പ്രമേഹം ഒരു മേജർ കാരണമായിരുന്നു മരണത്തിന് വരെ. അപ്പോൾ നമ്മൾ ആ അവസ്ഥയിൽ നിന്ന് മാറിയെന്നാണ് ഇപ്പോൾ തോന്നുന്നത്. അപ്പോൾ ഇപ്പം നമ്മൾ തിരിച്ച് പ്രമേഹ നിയന്ത്രണത്തിൽ പ്രമേഹം വരാതിരിക്കാൻ, നമ്മുടെ കുഞ്ഞുങ്ങൾക്ക് പ്രമേഹം വരാതിരിക്കാൻ, പെൺകുട്ടികൾ കല്യാണം കഴിക്കുന്നതിന് മുമ്പ് അവരുടെ വെയിറ്റ് ഏറ്റവും അനുകൂലമായ വെയിറ്റ്, ഏറ്റവും യോജിച്ച രീതിയിലുള്ള ഭാരം, അതായത് അമിതവണ്ണമൊക്കെ ഒഴിവാക്കുക. ഗർഭിണിയാകാൻ സാധ്യതയുണ്ടെങ്കിൽ നമുക്ക് പ്രത്യേകിച്ചും പാരമ്പര്യമായിട്ട് പ്രമേഹം വരാൻ സാധ്യതയുണ്ടെങ്കിൽ അവരുടെ പ്രമേഹം പരിശോധിക്കുക. ഗർഭിണിയായ ഉടനെ തന്നെ ഡോക്ടറെ കാണിച്ച് പ്രമേഹം ഉണ്ടോ എന്ന് നോക്കുക. ഇതൊക്കെ നമുക്ക് ഒരുപാട് കാര്യങ്ങൾ, നമുക്ക് മുക്കിന് ലാബുണ്ട്, ഒരുപാട് ക്യാമ്പുകൾ നമ്മൾ നടത്തുന്നു, റെസിഡൻഷ്യൽ അസോസിയേഷൻ ക്യാമ്പ് നടത്തുന്നു. പക്ഷേ ഏറ്റവും സങ്കടം എന്താണെന്ന് വെച്ചാൽ ആദ്യത്തെ 3 മാസം ഒരു പ്രാവശ്യം പോലും ബ്ലഡ് ഷുഗർ ടെസ്റ്റ് ചെയ്യാണ്ട് പ്രമേഹം ഉണ്ടെന്ന് അറിയാതെ വളരെ അനിയന്ത്രിതമായ പ്രമേഹമായിട്ട് ഗർഭിണികൾ നമ്മുടെ മുന്നിൽ വന്നിരിക്കുമ്പോൾ നമുക്ക് വളരെ സങ്കടം തോന്നും. നമുക്ക് ഇത്രയും പഠിച്ച മലയാളികളുള്ള നാട്ടിൽ അങ്ങനെ ഒരു കാര്യം എന്തുകൊണ്ട് സംഭവിക്കുന്നു? അപ്പോൾ ഇതുപോലെ ഷാജി ഡോക്ടർ പറഞ്ഞ പോലത്തെ നിങ്ങളെല്ലാവരും ഉള്ള ക്ലബ്ബുകൾ ഒക്കെ ആ തരത്തിലും കൂടി ഒന്ന് നമ്മൾ നേരത്തെ കണ്ടുപിടിക്കാനും വരാതിരിക്കാനും കൂടി കുറച്ചും കൂടി ഊന്നൽ കൊടുത്താൽ തീർച്ചയായിട്ടും, പ്രത്യേകിച്ചും പെൺകുട്ടികളെ കാര്യത്തിൽ നമ്മളെല്ലാവരും ഒന്നും കൂടി ശ്രദ്ധിക്കണം. പെൺകുട്ടിക്ക് ഗർഭിണിയാകുമ്പോൾ വന്നു കഴിഞ്ഞാൽ അത് അടുത്ത തലമുറയെ കൂടെ ബാധിക്കുന്ന ഒരു വിപത്തായിട്ട് മാറും. അപ്പോൾ ഈ ഒരു കാര്യമാണ് എനിക്ക് പ്രത്യേകിച്ച് ഒന്ന് പറയാനുള്ളത്. പ്രത്യേകിച്ചും കുറച്ച് അമ്മമാരോ സഹോദരികളും കൂടിയുള്ള ഒരു ഗ്രൂപ്പ് ആയതുകൊണ്ട്.
ചെറിയ കാര്യം കൂടെ ചേർക്കാനുണ്ട്. ഈ കോവിഡ് വന്നു കഴിഞ്ഞാൽ നമ്മൾ പുറത്തിറങ്ങാൻ പാടില്ലെന്നല്ലേ? അപ്പം നടക്കാൻ പോകുന്നവരെന്ത് ചെയ്യും? മറ്റ് എക്സസൈസ് ചെയ്യാൻ സാധിക്കാതെ വന്നാൽ എന്ത് ചെയ്യും? ഓരോ 55 മിനിറ്റ് കൂടുമ്പോഴും 5 മിനിറ്റ് നമ്മുടെ മുറിക്കകത്ത് വീട്ടിനകത്ത് നടന്നാൽ മതി. ഉറങ്ങുന്ന സമയം ഒഴിച്ച്. അപ്പോൾ ആ എക്സസൈസിൻ്റെ സമയം നമ്മൾ വീണ്ടെടുക്കും, ശരീരം ശരിയായിട്ട് അനങ്ങുകയും ചെയ്യും.
സംശയങ്ങളുണ്ടോ?
അത് പ്രമേഹം എന്ന് പറയുന്നത് നമ്മുടെ ശരീരത്തിൻ്റെ ഒരു അവസ്ഥയാണെന്നും പ്രമേഹം ബാധിച്ചു കഴിഞ്ഞാൽ, അതായത് രക്തത്തിലെ പഞ്ചസാരയുടെ അളവ് കൂടിയിരുന്നാൽ നമ്മുടെ ശരീരത്തിൽ എവിടൊക്കെ രക്തം പോകുന്നുണ്ടോ ആ രക്തം എത്തുന്ന അതും അതിനോടനുബന്ധിച്ചിട്ടുള്ള എല്ലാ സ്ഥലങ്ങളിലും കാലക്രമേണ പ്രശ്നങ്ങളും പ്രയാസങ്ങളും ഉണ്ടാകുമെന്നും നമ്മുടെ അടി മുതൽ മുടി വരെ നമ്മളെ തളർത്തുന്ന, നമ്മളെയും നമ്മുടെ കുടുംബത്തെയും നമ്മുടെ സാമ്പത്തിക സ്ഥിതിയെയും സമൂഹത്തെയും തളർത്തുന്ന ഒരു വിഭക്തായി മാറ്റാതെ അവരവരെ തന്നെ വിചാരിച്ചാൽ വളരെ നിയന്ത്രിച്ചു കൊണ്ടുപോകാൻ പറ്റുകയും, ഒരുപക്ഷെ ചിലർക്ക് പ്രശ്നങ്ങളുണ്ടാവുമെങ്കിലും ഈ വർഷം വരുന്ന പ്രശ്നം നമ്മൾ നിയന്ത്രിച്ചു കഴിഞ്ഞാൽ ഒരു 10 വർഷം അപ്പുറത്തേക്ക് തള്ളിക്കൊണ്ടു പോകാനും നമ്മുടെ ജീവിതത്തിൻ്റെ സന്തോഷവും സ്വസ്ഥതയും നിലനിർത്തി കൊണ്ടുപോകാനും നാം ഓരോരുത്തരും വിചാരിച്ചാൽ സാധിക്കും. പ്രമേഹം അറിഞ്ഞുവെന്ന് വെച്ചാൽ ജീവിതം അവസാനിക്കുന്നില്ലെന്നും പ്രമേഹം വന്നാൽ ആദ്യത്തെ 5-6 വർഷം മരുന്ന് കഴിച്ച് അത് നിയന്ത്രിച്ചുകൊണ്ട് പോകുമെന്ന് വെച്ചിട്ട് 2 തവണ നോക്കിയിട്ട് പിന്നെ നോക്കാതിരിക്കുകയും ചെയ്യുന്നത് മണ്ടത്തരമാണ് തീർച്ചയായിട്ടും. അതാണ് ഇവിടെ എല്ലാവരും നമ്മളോട് പറയുവാൻ ശ്രമിച്ചുകൊണ്ടിരുന്നതും നമ്മളോട് അറിയിച്ചതും.
ഹലോ, എനിക്ക് 18 വർഷമായിട്ട് മറ്റേ പ്രമേഹ രോഗിയാണ്. പക്ഷേ 2 നേരം ഇൻസുലിൻ വെക്കുന്നുണ്ട്, 2 നേരം ഗുളികയും കഴിക്കുന്നുണ്ട്. പക്ഷേ എൻ്റെ HbA1c 10ൻ്റെ പുറത്താണ് എന്നും. 10.5 10 അങ്ങനെയാണ്, കുറയുന്നില്ല. ഒരു 3 വർഷമായിട്ട് അങ്ങനെ തന്നെ നിൽക്കുകയാണ്. അപ്പോൾ അതിന് 2 സൈസ് ഗുളിക, മറ്റേ 4 സിക്കോ 10 മില്ലിഗ്രാമാണ് കഴിക്കുന്നത്. ഏറ്റവും നല്ല ഗുളികയാണെന്നാണ് പറഞ്ഞത്. ഇൻസുലിൻ പിന്നാണ് വെക്കുന്നത് 2 നേരം.
അതെ, നമ്മൾ പ്രമേഹം ഓരോ വ്യക്തിയിലും വ്യത്യാസമുണ്ട്. ഇപ്പം നിങ്ങൾ തന്നെ നോക്കുമ്പോൾ അതിൻ്റെ ഓരോ സ്റ്റേജസ് തുടക്കത്തിൽ കൺട്രോൾ ചെയ്യാൻ കൂടുതൽ എളുപ്പമായിരിക്കാം. പിന്നെ പാൻക്രിയാസിൻ്റെ പ്രവർത്തനം കുറഞ്ഞു വരുന്നതനുസരിച്ച് ഏറ്റക്കുറച്ചുകൾ വരാനുള്ള സാധ്യതയും കൂടുതലാണ്. പ്രമേഹം കൺട്രോൾ ചെയ്യാൻ അപ്പോൾ ആദ്യമുള്ള മരുന്നുകൾ മതിയാവാതെ വരുന്ന ഒരു അവസ്ഥയും വരും. അങ്ങനെ വരുമ്പോൾ മുമ്പ് ഡോക്ടർമാർ സംസാരിച്ചതുപോലെ തന്നെ നിങ്ങളുടെ ആ ഏറ്റക്കുറച്ചിൽ പ്രമേഹത്തിൽ പഞ്ചസാര വരുന്ന വ്യതിയാനങ്ങൾക്കനുസരിച്ച് അത് ഏത് തരത്തിലാണ്, അത് നിങ്ങളുടെ ജീവിതശൈലിയുടെ ഏത് ഭാഗം, അത് ഭക്ഷണത്തിൻ്റെ രീതി കൊണ്ടാണോ, വ്യായാമത്തിൻ്റെ വ്യത്യാസം കൊണ്ടാണോ, ടെൻഷൻ കൊണ്ടാണോ, അത് ഏത് സമയത്താണ് വരുന്നത് എന്നൊക്കെ നോക്കിയിട്ട് അതിൻ്റെ കാരണങ്ങൾക്ക് അനുയോജ്യമായിട്ടുള്ള രീതിയിൽ മരുന്നുകൾ അഡ്ജസ്റ്റ് ചെയ്തിട്ടാണ് അതിന് ശരിയാക്കുന്നത്. ഒരു പരിധി എത്തുമ്പോൾ മരുന്ന് മതിയാവുന്നില്ല, അല്ലെങ്കിൽ മരുന്ന് ആവശ്യത്തിനുള്ള ഫലം തരുന്നില്ല എന്ന് വരുമ്പോൾ ഇൻസുലിൻ ആക്കുന്നു. ഇൻസുലിൻ തന്നെ പല ലെവലിലോട്ട് പോകേണ്ടി വരും. ഇപ്പം നിങ്ങൾ പറഞ്ഞു ഫോക്സിക എന്നുള്ള ഗുളിക കഴിക്കുന്നുണ്ട്, 2 നേരം ഇൻസുലിൻ എടുക്കുന്നുണ്ട്. അത് വളരെ നല്ലൊരു ചികിത്സ തന്നെയാണ്. പക്ഷെ അത് മതിയാവുന്നുണ്ടാവില്ല. അങ്ങനെയുള്ളപ്പോൾ അതിൻ്റെ അടുത്ത സ്റ്റെപ്പിലോട്ട് പോകേണ്ടി വരും. അടുത്ത സ്റ്റെപ്പ് എന്ന് പറയുമ്പോൾ പല നോക്കേണ്ടി വരും. അത് നിങ്ങളുടെ പ്രമേഹത്തിൻ്റെ HbA1c നിങ്ങൾ പറഞ്ഞു ഓൾറെഡി 10ൻ്റെ മേളിലാണ്. അത് വളരെ മോശമായ ഒരു ലെവലാണ്. അത് കൺട്രോൾ ആക്കുക തന്നെ വേണം. പക്ഷേ അതിൻ്റെ കൂടെ തന്നെ നിങ്ങളുടെ അവയവങ്ങളെ ഏതൊക്കെ രീതിയിൽ ബാധിച്ചിട്ടുണ്ട്, നിങ്ങളെ കണ്ണിനെ ബാധിച്ചിട്ടുണ്ടോ, കിഡ്നീനെ ബാധിച്ചിട്ടുണ്ടോ, ഞരമ്പിനെ ബാധിച്ചിട്ടുണ്ടോ, നിങ്ങളുടെ അതിൻ്റെ അസുഖം എന്താണ്, ഇതൊക്കെ നോക്കിയിട്ടാണ് ഈ ബാക്കിയുള്ള മരുന്നുകളിൽ ഏതാണ് നിങ്ങൾക്ക് ഏറ്റവും അനുയോജ്യമായത്, അത് ഏത് സമയത്ത് തരുമ്പോഴാണ് നിങ്ങളുടെ അത് കുറയ്ക്കാൻ. ഈ 10നെ എങ്ങനെ കുറയ്ക്കും? അപ്പോൾ പല രീതിയിൽ പോവാം. ഒന്നുകിൽ ഡോക്ടർ ഇപ്പം നിങ്ങൾ പറഞ്ഞു 2 നേരം ഇൻസുലിൻ 2 നേരം ഗുളികയുണ്ട്. ചിലപ്പോൾ ചില വ്യതിയാനങ്ങൾക്ക് ചില ഗുളിക ആഡ് ചെയ്യുന്നതായിരിക്കും നല്ലത്. വേറെ ചില വ്യതിയാനങ്ങൾക്ക് ഒരുപക്ഷെ 2ൽ നിന്ന് 3 നേരമോ 4 നേരമോ ഇൻസുലിൻ ആക്കുന്നതായിരിക്കും നല്ലത്. വേറെ ചില വ്യതിയാനങ്ങൾ നിങ്ങളുടെ ഭക്ഷണത്തിലോ ജീവിതശൈലിയിലോ ചില വ്യത്യാസങ്ങൾ വരുത്തിയാൽ തന്നെ ശരിയാക്കാൻ പറ്റുന്നതായിരിക്കാം. അത് ഡോക്ടറെ കാണുമ്പോൾ ഇതിന് അടുത്ത സ്റ്റെപ്പ് എന്താണ് ഡോക്ടറെ എന്ന് ചോദിച്ചു കഴിഞ്ഞാൽ നിങ്ങളെ മനസ്സിലാക്കുന്ന നിങ്ങളുടെ ഡോക്ടർ നിങ്ങൾക്ക് ഏറ്റവും അനുയോജ്യമായ രീതിയിൽ നിങ്ങളുടെ ചികിത്സ അഡ്ജസ്റ്റ് ചെയ്യുകയും അതുകൊണ്ട് നിങ്ങൾക്ക് ആ 10 എന്നുള്ളത് കുറച്ച് 7 വരെ എത്തിക്കാൻ സാധിക്കുകയും ചെയ്യും എന്ന് തന്നെയാണ് ഞാൻ വിചാരിക്കുന്നത്.
ഡോക്ടറെ ചികിത്സിച്ചാലും ഇപ്പോൾ ചിലപ്പോൾ നമ്മൾ തുടക്കത്തിൽ ഗുളികകളെ വേണ്ടി വരില്ല. ഭക്ഷണ നിയന്ത്രണവും വ്യായാമം കൊണ്ട് കൺട്രോളാവും. പിന്നെ നമ്മൾ ചെറിയ ഗുളികകൾ തുടങ്ങും. പിന്നെ കുറച്ചൊരു 10 വർഷമൊക്കെ കഴിയുമ്പോൾ ആ ഗുളികകൾ മതിയാകാതെ വരും. അപ്പോൾ അവിടെ നമ്മുടെ പ്രമേഹം നിയന്ത്രണത്തിലാവാതെ ഗുളികകളുടെ കുഴപ്പമോ ചികിത്സിക്കുന്ന ഡോക്ടറുടെ കുഴപ്പമോ അല്ലെങ്കിൽ ചികിത്സ ലഭിക്കുന്ന വ്യക്തിയുടെ കുഴപ്പമല്ല, അല്ലെങ്കിൽ ഞാനൊരു മോശം രോഗി ആയതുകൊണ്ടാണ് എന്ന് വിചാരിക്കരുത്. അപ്പോൾ മനസ്സിലായില്ലേ? അപ്പോൾ ആ തരത്തിൽ നമ്മൾ ചികിത്സ മാറ്റിക്കൊണ്ടേയിരിക്കും. അല്ലെങ്കിൽ ഞാൻ നേരത്തെ കാണിച്ച ഡോക്ടർ ഒരു ഗുളികയിൽ അന്ന് കൺട്രോളായിരുന്നു, ഇപ്പോൾ 10 വർഷം കഴിഞ്ഞിട്ട് നിങ്ങൾ 3 ഗുളിക എഴുതിയിട്ട് കൺട്രോൾ ആവുന്നില്ലല്ലോ എന്നൊക്കെ ചോദിക്കുന്ന രോഗികളെയും നമ്മൾ കണ്ടിട്ടുണ്ട്. അപ്പോൾ അത് ഡോക്ടറുടെയോ രോഗിയുടെയോ കുഴപ്പമല്ല. പിന്നെ വേറൊരു കാര്യം കൂടിയുണ്ട്. പ്രമേഹ നിയന്ത്രണത്തിൽ നമ്മൾ ഇപ്പോൾ എല്ലാവരും പറഞ്ഞു ഇൻഡിവിജ്വലൈസ് കെയർ, ഓരോ വ്യക്തിക്ക് അനുയോജ്യമായ നിയന്ത്രണം മാത്രമല്ല, അതുകൊണ്ടുള്ള ഹൈപ്പോഗ്ലൈസീമിയ, രക്തത്തിലെ പഞ്ചസാര 70 കുറഞ്ഞിട്ടുള്ളൊരവസ്ഥ ഇല്ലാതിരിക്കുകയും വേണമല്ലോ. അപ്പോൾ തീർച്ചയായിട്ടും നിങ്ങൾ ഈ പറഞ്ഞ കാര്യം നിങ്ങളുടെ ഡോക്ടറുടെ അടുത്ത് പോയിരുന്ന് സംസാരിച്ചാൽ എങ്ങനെയാണ് നമ്മുടെ ചികിത്സ മാറ്റേണ്ടതെന്ന് മനസ്സിലാക്കാം. മാത്രമല്ല എനിക്ക് പിന്നെയും പറയാനുള്ളത്, ഞാൻ പലപ്പോഴും കണ്ടിട്ടുണ്ട് ഈ വീട്ടിൽ പ്രത്യേകിച്ച് അമ്മമാരെ കൊണ്ടുവരുന്ന മക്കളോ സ്ത്രീകളെ കൊണ്ടുവരുന്ന ഭർത്താക്കന്മാരോ പറയുന്നത് കേൾക്കാറുണ്ട്, ഇവർ അടുക്കളയിലുള്ള മുഴുവൻ ഇരുന്ന് ഭക്ഷണം കഴിച്ചിട്ടാണ് ഇങ്ങനെ ഷുഗർ കൺട്രോൾ ആവാത്തത്. അങ്ങനെയല്ല. അപ്പോൾ നമ്മളെല്ലാവരും ഒരുമിച്ച് ചേർന്ന് വീട്ടിലെല്ലാവരും സഹായിച്ചാലേ പ്രമേഹ നിയന്ത്രണം സാധ്യമുള്ളൂ, പ്രത്യേകിച്ചും സ്ത്രീകൾക്ക്. അതാണ് എനിക്ക് പറയാൻ.
പ്രമേഹ നിയന്ത്രണം നമ്മൾ സാധാരണ എല്ലാവരും പറയും നമുക്ക് കുട്ടികൾ തൊട്ട് നമ്മൾ തുടങ്ങണം. ചിലപ്പോൾ ഇപ്പം നമുക്ക് ചെറിയ പ്രായമുള്ള കുട്ടികളിൽ തൊട്ട് ഇപ്പോൾ പൊണ്ണത്തടിയും വയറിൻ്റെ ചുറ്റളവ് കൂടുന്നതും പ്രമേഹം വരാനുള്ള സാധ്യതയുണ്ട്. അവർക്കൊരു പ്രീ ഡയബറ്റിസ് സ്റ്റേജ് വരും, അപ്പോൾ നമ്മൾ ശ്രദ്ധിക്കത്തില്ല, പിന്നെ അത് ഡയബറ്റിസ് ആവും. അപ്പം നമ്മുടെ HbA1c ഒരു 5.6 ഒക്കെ ഉണ്ടാവുള്ളൂ. പിന്നെ അപ്പം നമുക്ക് പ്രമേഹം അറിഞ്ഞു കഴിയുമ്പോൾ തന്നെ നമ്മുടെ പാങ്ക്രിയാസിലൊരു 60% കൂടുതൽ നശിച്ചിട്ടുണ്ടാവും. അത് ഓരോ വർഷവും ഒരു 3% നശിച്ചുകൊണ്ടിരിക്കും. അതാണ് ഡോക്ടർ പറഞ്ഞത്. അങ്ങനെ ഒരു 80% കൂടുതൽ ബീറ്റാകോശങ്ങൾ നശിച്ചു കഴിയുമ്പോൾ പിന്നെ നിങ്ങൾ പറയുന്ന പോലെ ഗുളികൾ അതുകൊണ്ട് മതിയാവുന്നില്ല, നമുക്ക് ഇൻസുലിൻ വ്യത്യാസം വരണം. അപ്പം ആ സമയം കൊണ്ട് നമുക്ക് ബാക്കിയുള്ള നമ്മളെ ഓരോ അവയവങ്ങളിലെ ദീർഘകാല സങ്കീർണത ഉണ്ടാകും. അങ്ങനെ കണ്ണിന് ഞരമ്പുകൾക്ക് ബാധിക്കാം, റെറ്റിനോപ്പതി വരും, കാലിലെ ഞരമ്പിനെ ബാധിച്ച ന്യൂറോപ്പതി വരും, പിന്നെ അത് കാലിൽ വ്രണം ഉണങ്ങാതെ വരും, ഗാംഗ്രീൻ വരും. അത് നമുക്ക് വേദന അറിയാതെയുള്ള ഹാർട്ടിന് അസുഖങ്ങളോ നടക്കുമ്പോൾ കിതപ്പോ ഉണ്ടെങ്കിൽ ഡോക്ടറെ കാണിച്ച് പരിശോധിച്ചിട്ടുണ്ടെങ്കിൽ നമുക്ക് ഹാർട്ടിന് അസുഖങ്ങളുണ്ടെങ്കിൽ അത് ഹാർട്ട് അറ്റാക്ക് ഉണ്ടാവാതെയും അല്ലെങ്കിൽ നമുക്ക് ഹാർട്ടിന് അസുഖം ഉണ്ടാകും. അതുപോലെ തന്നെ ഞരമ്പുകൾക്ക് തലച്ചോറിൽ വന്ന് രക്തക്കുഴൽ അടയുകയോ പൊട്ടുകയോ അല്ലെങ്കിൽ ഒരു സൈഡിൽ തളർവാദം വരാം. അങ്ങനെ അതുപോലെ വൃക്കയെ ബാധിച്ചിട്ട് ദീർഘകാല സങ്കീർണതകൾ പോയി കിഡ്നി ഫെയിലർ, എൻ സ്റ്റേജ് റീനൽ ഫെയിലർ എന്ന് പറയും, അവസാനം ഡയാലിസിസ് എത്തുന്ന സ്റ്റേജിലും. അപ്പം നമ്മളെല്ലാവരും പോയിട്ട് കിഡ്നി ടെസ്റ്റ് ചെയ്യും. എൻ്റെ കിഡ്നിക്ക് ഒരു കുഴപ്പമില്ല, എൻ്റെ ക്രിയാറ്റിൻ ഇത്രയേ ഉള്ളൂ എന്ന് പറയും. പക്ഷേ അത് നമുക്കൊരു 60% ബാധിച്ച് മാത്രമേ കിഡ്നിയെ അറിയത്തുള്ളൂ. അപ്പോൾ അതിന് മുമ്പ് അറിയുന്ന ടെസ്റ്റുകളുണ്ട്. 24 മണിക്കൂർ യൂറിൻ മൈക്രോആൽബ്യൂമിൻ എന്ന ടെസ്റ്റ് ഉണ്ട്, പ്രോട്ടീൻ ക്രിയാറ്റിൻ റേഷ്യോ എന്ന് പറഞ്ഞ ടെസ്റ്റ് ഉണ്ട്. ഈ ടെസ്റ്റുകളെല്ലാം സമയങ്ങളിൽ ഡോക്ടറെ കാണിക്കണം. അല്ലാതെ ഞാൻ പറഞ്ഞ പോലെ ഒരു മരുന്നിങ്ങനെ കഴിച്ച് ദീർഘകാലം കഴിച്ച് എപ്പോഴെങ്കിലും കുറയാതെ വരുമ്പോൾ മാത്രമല്ല ഡോക്ടറെ കാണിക്കുന്നത്. അത് ഒരു 1-2 മാസം മിനിമം ഡോക്ടറെ കാണിച്ചിട്ട് എന്ത് വ്യത്യാസപ്പെടുത്തണമെന്ന് പറയണം. അപ്പോൾ അതല്ലെങ്കിൽ ഈ പറഞ്ഞ മൂത്രത്തിൽ പത വരുമ്പോഴോ നമ്മൾ കൂടുതൽ കിഡ്നിയെ ബാധിച്ച് കഴിഞ്ഞ് നമ്മൾ വരുമ്പോഴായിരിക്കും ചിലപ്പോൾ ക്രിയാറ്റിൻ ഒരു 5 ആയിട്ടായിരിക്കും ഡോക്ടറെ അടുത്ത് വരുന്നത്. അപ്പോൾ അതിന് മുമ്പുള്ളതാ പറഞ്ഞില്ലേ എല്ലാ ടെസ്റ്റുകളും ഈ ഡോക്ടർ നേരത്തെ പറഞ്ഞ പോലെ ഞരമ്പുകളുടെ ടെസ്റ്റ് നോക്കണം, ന്യൂറോപ്പതി ടെസ്റ്റ് ചെയ്യണം. അങ്ങനെയല്ല നമ്മളെല്ലാത്തിൻ്റെയും സ്ക്രീനിങ് വർഷത്തിൽ നോക്കണം. ഡോക്ടർ പറഞ്ഞില്ല കണ്ണിൻ്റെ പരിശോധന, റെറ്റിനൽ സ്ക്രീനിങ് വേണം, ന്യൂറോപ്പതി സ്ക്രീനിങ് വേണം, ഈ മൈക്രോആൽബ്യൂമിൻ നോക്കണം. അങ്ങനെ മറ്റുള്ള സമഗ്രമായിട്ടുള്ള നമ്മൾ പിന്നെ പറഞ്ഞ് ദാഹം കൂടുതലാണെന്ന്. അപ്പോൾ ദിവസം സമയങ്ങളിൽ ആഹാരം വേണം. രാവിലെ നമ്മൾ ആഹാരം കറക്റ്റ് സമയത്ത് കഴിക്കണം. ഇടയ്ക്ക് ഇടവേളയിൽ ഒരു 11 മണിക്ക് എന്തെങ്കിലും മോരും വെള്ളമോ അങ്ങനെ എന്തെങ്കിലും കഴിക്കണം, സ്നാക്സ് കഴിക്കണം. 1 മണിക്ക് തന്നെ 1-1.5 ഉള്ളിക്ക് ചോറുണ്ണണം. പിന്നെ വൈകിട്ട് 4 മണിക്ക് ചായയുടെ കൂടെ ഒരു സ്നാക്സ് എന്തെങ്കിലും കഴിക്കണം. രാത്രി 8 മണിക്ക് കഴിക്കണം. കിടന്നുറങ്ങാൻ താമസിക്കുകയാണെങ്കിൽ ഒരു ഫ്രൂട്ട് എന്തെങ്കിലും കഴിക്കണം. അങ്ങനെ പല സമയങ്ങളായിട്ട് ആഹാരം വേണം. ഇൻസുലിൻ എടുക്കുന്നതും ഗുളികൾക്ക് ഇത് വേണം, അല്ലെങ്കിൽ നമ്മൾ പെട്ടെന്ന് കുറഞ്ഞു പോവുകയും കൂടുകയും ചെയ്യാം. അതുകൊണ്ടൊരു സമഗ്രമായിട്ടുള്ളത് ആഹാര രീതിയും തൂക്കം വേണ്ടവർക്ക് തൂക്കം കുറയ്ക്കുകയും ആഹാരം കറക്റ്റ് സമയത്ത് കഴിക്കുകയും പോഷക ഗുണമുള്ള ആഹാരം കഴിക്കുകയും കൂടുതൽ നാരുള്ള ആഹാരം കഴിക്കുകയും കൊഴുപ്പുള്ള ആഹാരം കുറയ്ക്കുകയും അങ്ങനെ ചെയ്താൽ നമുക്കൊരു ദീർഘകാലം നമുക്ക് സങ്കീർണത ഇല്ലാതെ ചെയ്യാൻ പറ്റും.
താങ്ക് യു. അപ്പം എനിക്ക് തോന്നുന്നു നമ്മൾ ടൈം ആയിട്ടുണ്ട്. നമ്മൾ എല്ലാ ആൾക്കാരും ശരിക്കും സത്യം പറഞ്ഞാൽ നിങ്ങൾക്ക് എല്ലാവർക്കും ഞാൻ ഉദ്ദേശിച്ചിരുന്നത്, ഞങ്ങൾ മനസ്സിൽ വിചാരിച്ചിരുന്നത് വെച്ചാൽ ഓരോരുത്തർക്കും ഒരുപാട് സംശയങ്ങൾ പ്രമേയത്തിനെ കുറിച്ചുണ്ട്. അത് സ്പെസിഫിക് ആയിട്ട് ഓരോ സംശയങ്ങൾ ചോദിച്ചാൽ നിവാരണം നടത്താം. പക്ഷെ വളരെ കുറച്ച് ആൾക്കാർക്ക് സംശയമുള്ളൂ. മറ്റുള്ളവർക്ക് സംശയങ്ങൾ ഉണ്ടാവും, ചോദിക്കാൻ മടിയാണ്, വെറുതെ കേൾക്കാം, സംശയങ്ങളൊന്നും പറയണ്ട എന്ന് ഇരിക്കുന്ന പോലെ ഉള്ള ഒരു അവസ്ഥയാണ്. എനിവേ, പ്രമേയത്തിനെ കുറിച്ചുള്ള സംശയങ്ങൾ ഇന്ന് നമ്മൾ മുഴുവൻ നിന്നാലും ഒരാഴ്ച പറഞ്ഞു തീർന്നാലും തീരില്ല. അതുകൊണ്ട് ഇനിയും ഇത്തരം സന്ദർഭങ്ങൾ നമുക്ക് ഉണ്ടാക്കിയെടുക്കാം. മാത്രമല്ല, ഇവിടെ പെരിന്തൽമണ്ണ നിങ്ങൾക്ക് ഇഷ്ടംപോലെ ഡോക്ടർമാരുണ്ട്. ഡോക്ടർ ഷാജിയുടെ നേതൃത്വത്തിലുള്ള ഡയബറ്റീസ് ക്ലിനിക്ക് ഉണ്ട്, ഡയബറ്റിക് ക്ലബ് ഉണ്ട്. പിന്നെ ഇവിടെ തന്നെ ഉള്ള ഡോക്ടർമാരുണ്ട്, രാംദാസ് സാറുണ്ട്, മോഹൻദാസ് സാറുണ്ട്, സുജിത്ത് ഡോക്ടറുണ്ട്, മറ്റ് ഒരുപാട് ഡോക്ടർമാർ ഇവിടെ ഉണ്ട്. ഈ ഡോക്ടർമാരൊക്കെ സംഘടിപ്പിച്ച് നിങ്ങൾക്ക് തന്നെ നിങ്ങളുടെ കൂട്ടായ്മയിൽ തന്നെ നിങ്ങൾക്ക് വേണമെങ്കിൽ കുറച്ചുകൂടി പ്രമേഹ ബോധവൽക്കരണ സെമിനാറുകൾ ഇതുപോലെ സംഘടിപ്പിക്കാം. അതിൽ ഒരു മാസത്തിലൊരിക്കലോ 3 മാസം കൂടുമ്പോഴോ അങ്ങനെ സെമിനാറുകൾ സംഘടിപ്പിച്ചു കഴിഞ്ഞാൽ നിങ്ങൾക്ക് ഇത്തരത്തിലുള്ള സംശയ നിവാരണത്തിനുള്ള ഒരു പീരിയോഡിക്കലായിട്ടുള്ള ഒരു അവസരം കിട്ടും. അതിൽ നിന്ന് നിങ്ങളുടെ അസുഖത്തിനെ കൂടുതൽ ഇഫക്റ്റീവായിട്ട് എഫിഷ്യൻ്റായിട്ട് മാനേജ് ചെയ്ത് കൊണ്ടുപോകാനും അതിൻ്റെ കോംപ്ലിക്കേഷൻസ് വരുന്നത് പ്രിവെൻറ്റ് ചെയ്യാനും പറ്റും. ആരോഗ്യമുള്ള ഒരു ഭാവി നിങ്ങൾക്ക് നിങ്ങളുടെ വരുന്ന തലമുറയ്ക്കും ഉണ്ടാക്കാനും അതുകൊണ്ട് നിങ്ങൾക്ക് പറ്റും. ഈ ഒരു പരിപാടിയിൽ ഇത്ര നേരം വന്ന് ഞങ്ങളോട് സഹകരിച്ച് ഈ ചോദ്യങ്ങൾ ചോദിച്ച് അതുപോലെ തന്നെ കമൻസ് പറഞ്ഞ് ഞങ്ങൾക്ക് ഇങ്ങോട്ട് വേണ്ട നിർദ്ദേശങ്ങളും കൂടി അതിൽ ഉൾപ്പെടുത്തിക്കൊണ്ട് പറഞ്ഞ പല ആൾക്കാരുണ്ട് ഇവിടെ. അവർക്കെല്ലാവർക്കും ഞങ്ങളുടെ എല്ലാവരുടെയും പേരിലും RSSDയുടെ പേരിലും പെരിന്തൽമണ്ണ IMAയുടെ പേരിലും നന്ദി പ്രകാശിപ്പിച്ചുകൊണ്ട് ഇന്ന് നമ്മൾ ഈ പ്രോഗ്രാം ഇവിടെ കൺക്ലൂഡ് ചെയ്യുന്നു. താങ്ക് യു. നന്ദി, നമസ്കാരം.
ഇന്നത്തെ ഈ മനോഹരമായ ദിനം അവസാനിപ്പിക്കുന്നതിനായി എല്ലാവരും നമ്മുടെ ദേശീയഗാനത്തിന് എഴുന്നേറ്റ് നിൽക്കണമെന്ന് അഭ്യർത്ഥിക്കുന്നു.
हिमाचल यमुना गंगा उच्चल जल